ये आशीष, आवाज क्यों नहीं आ रहा है?
प्रथमेश किती वाजता येतो कामावर? जेवणाची प्लेट घेऊन 25 पैसे देतो तुला. जेवणाच्या प्लेट असतात 3 कप्प्यावाल्या. इंडिया मार्ट मधून आणतो.
the this year second virtual Birmingham review course, and thanks for you joining us this morning. We are very excited about this year's program. Again, we're joined by a very eminent faculty members virtually this year, on the hope that next year we'll see you all in Birmingham. Just a few housekeeping points to start off with. You probably all got used to the virtual meetings etiquette. We're using Zoom platform this morning. So what I would like you to do is keep your mic muted at all times. There is some exceptions where we're going to be going into the thoracic only seminars, where you will have opportunities to interact and talk, and it works as a virtual meeting. And you will be invited to speak and interact. Equally, there is a component of the thoracic MDT this morning where you will be given the opportunity to interact and contribute to the patient's management. Before we go further, I would like to present to you my senior colleague, Mr. Meninda Kalkat, who has hosted this is now, and he's made it the huge success it is. So we're grateful for his ongoing contribution and support to this course. I was definitely one of the trainees who grew up benefiting from this course on a yearly basis almost. I had a subscription because I always found there's something new every year. And I believe I don't need to advertise for it amongst people who are very keen. Having said that, we are excited to be joined for some of the sessions throughout the course by the CTS members through a live stream via CTSNet on a selected talks. If you feel that the contents of the course might be of interest to you, feel free to join. It's never too late, and you will have access to one-to-one interaction with the faculty throughout the course. I also would like to take a few seconds to thank the sponsors for ongoing support of this course virtually. We understand that this might have limited benefit for our sponsors who supported us throughout this period, the same way they support us in the clinical arena by providing us support and help, and their products that we can't do our job without. So we're grateful to them. If you have any questions, feel free to contact them through the chat box, and I'm sure they will be appreciating of your interaction and support. Breaks. It can be, we all know now how difficult it is to concentrate throughout a course like that when there is coffees. As much as we'd like you to interact with your colleagues or the delegates and the faculty, ensure that you get enough rest, get some drinks, and the same way you would have if you were with us here, in order to get the maximum benefit of the course. I think without further ado, we just, I'll hand you over to my esteemed colleague, Mr. Kalkat. And there's one more thing actually before I move on to that, is if you have any questions, you can directly find the speakers on the chat room and ask them via direct message. Equally, if you open your chat room box on the view side of your Zoom, you can also type them there. We are joined by to senior cardiothoracic trainees who are keep an eye on that, and they will be passing your questions and comments whenever there is an opportunity. Hand you over to Mr. Kalka.
Good morning to everyone, and I think probably it could be good evening somewhere and good afternoon at other places. So welcome to the Birmingham Review course, and hopefully next year we might be able to see you all and other new delegates in person. So we will start with thoracic oncology. What I will request you, we've got 4 esteemed speakers here, and they will give you the broad outline of what thoracic oncology is all about. And then we have a thoracic MDT. And that's where we would like your very active participation. And that's where I will leave all the question answer sessions. So bear with us, go through these talks, write down your questions. And then when the MDT is taking place, we are trying to encompass all what is discussed in that cases we're going to discuss in the MDT. So that will be the opportunity for you to ask the questions to the panel members and to the speakers. Dr. McGann, he is a consultant radiologist who works at Cheltenham General Hospital and has been contributing to this review course for past many years. Every time I listen to him, I learn something new. So Dr. McGann, could you please connect in and share your expertise with us? Thank you so much.
Thank you very much, Mahinda, and co-chairman, ladies and gentlemen, thank you very much for having me again. I just now would ask the host to allow me to share the screen. So if you could give me the ability to share the screen, I'll get my PowerPoint going. So we'll look at doing desktop 1. Thank you. And I'm hoping that you can now see your PowerPoint presentation. Thank you, Mend. I have no declarations. I'll skip fairly quickly through staging in this 20 minutes. It won't be completely comprehensive. I've left out MRI on this occasion to keep to time. So, as you know, the vast majority of staging will concern non-small cell lung cancer. Surgically, less than 5% will be small cell. The amount that mesothelioma is included might become more important following the MARS-2 trial, which has only got a year of data so far, but we're awaiting more data on that. So why stage? It's one of the few international languages that throughout medicine that is completely understood everywhere throughout the world. It gives a very accurate prognosis, and we'll be seeing how closely the prognosis follows the stage. It remains the premier trial inclusion, and increasingly now units are being asked for their data to actually benchmark against other units. So on our meeting, I get up a favorite Google. I use the Netherlands site, the Radiology Assistant, go to lung cancer within the Radiology Assistant, get up the TNM. It's become quite complicated, as the red has shown you from the last iteration. Those are the changes. I also get up the picture of the nodal stations because I can never remember them, and then put that on my screen top. So we've had so many iterations really because at every change, even more data has been included. There's a massive amount of contributors worldwide to this lung cancer data. It's when you're looking at your patients in clinic, they will now be up to 7 years old, the data. So we may be doing better than this data implies. This is the original paper by Goldstraw, Chansky et al. Back to 2015 now. So you'll all be familiar with it. It broadly goes through the T sizes in 1 centimeter intervals, the exception being the 2 centimeter jump to the T3 level. Again, these correlate very well with prognosis. So how do you measure? Now that PACS systems can look at the tumor in all planes, you don't have to use complex oblique planes, but at least interrogate the axial and coronal planes. This tumor was staged at T3 because the measurements were made on the axial plane in mediastinal settings. In fact, the same tumor in lung windows in the same slice will look bigger. So your measurement should be on lung windows. However, it's even bigger when you measure in the coronal plane. So this becomes a T4 tumor. It was wrongly staged at T3. There is some debate around how much of the ground glass you include, and it's not always obvious about how much of related lung collapse that's included. And that's where you need your radiologist to make an educated guess. Nodal status, this hasn't changed recently. There have been some proposals to change it, but they haven't come to anything. Chansky et al. have proposed a more complex system, but we've remained at the 3 stages for nodal disease and only 2 for mesothelioma. Metastases, most effusions are metastatic. We will sample some selected ones if they make a difference to definitive treatment plan. And then using the metastasis, the nodal stage and the T combined, you arrive at a staging number, which is what recognized the world over. And broadly speaking, the N0 and N1s up to T3 will be the ones that you'll be operating on. Occasional tumors, T4 tumors with N0 status will be included in this, and you'll be hearing about some heroic resections later on in the course. So broadly speaking, N1 will not alter your surgical plan, but it will of course change prognosis. This is how well that the prognosis as determined
18 and 45.
By T stage and the numbers correlates with survival. And in particular, you'll notice that down at the worst tumors, now prognosis at 72 months is an amazing 10%. That was 0 in the last iteration. We think that you'll be hearing about this in the later talks, but vastly improves in targeted chemotherapy and selected X-ray therapy has improved this, even though our staging is now better. So better staging tends to upstage tumors. So the evidence is good for CT. We've talked about size. Local invasion can be contentious, particularly concerning chest wall and mediastinum. The distance from carina is a little bit contentious. It was set at 2 centimeters, but you'll experience from your MDT some doubt when this is measured. And is the main pulmonary artery the T4? Are the right and left pulmonary arteries T4? That they're still not fully decided. I find that the right hilum with it often has a cluster of 3 or 4 nodes, and they're often measured together. So it tends to overstage the individual, but that should be resolved by PET followed by EBUS. And only occasionally do we need to confirm the M stage. Brain CT and MR is a little more contentious. It's not based on any good evidence, by the way, and NICE admit this, in their clinical review. MR is a precious resource, and in my opinion, should be used sparingly, because at the cost of a quality adjusted life here, using MR on stage 2 is a huge amount. I would recommend McConaughey in his summary of NICE guidelines recently in the BMJ for further detail on this. So often staging is relatively straightforward in the MDT. A huge tumor here, already we know it's around the T4 stage. The CT confirms T4 tumor. It's not all collapse. We didn't think it was collapsed because it was rounded on its inferior border, but it looked here on the CT, there are definite N3 nodes extending across the midline. So this is inoperable. Here's where that tumor comes on the survival curve. So unfortunately, many deaths in the first 3 years. PET scan has revolutionized, and you'll now know it's standard for all tumors needing to be considered for definitive and radical treatment. It uses uses radioactive glucose and a dual scanner, a two-component scanner, the CT in a gentle breathing and the radiation of the radioactive glucose, all collected at the same time, and using the dose, the patient's glucose level, their body image, and the size of the tumor, you arrive at what's called the SUV, the standardized uptake value you'll hear a lot of. So we thought PET would do a lot of detecting asymptomatic metastases. So this is a CT M0 by CT, but by PET scan, you can see that there are 2 metastases here, and even more when you look at the whole body. There's another one in the humerus here. And is biopsy necessary here? Probably in this particular case, probably not. Occasionally, when a single metastasis is going to alter the course of definitive tumor, then you can argue that a transpedicular biopsy of this particular hotspot might be appropriate, but it would be difficult because you can't see it on CT at all. Our job in the MDT is to keep the momentum running and not to get stalled on incidental findings, which are very common with PET scanning. Spiculate tumor looks like cancer. Biopsied tuberculoma. Treated, much better. You can see how the emphysematous patient actually makes what might be well-defined consolidation look very spiculous and confuses us. This looks like a M0 tumor, N0. However, a single metastasis in the adrenal. So this is the kind of tumor that we need to go for to make sure that the plan of definitive surgery is a good one. This was biopsied through the stomach with endoscopic ultrasound and positive, and so the treatment plan was altered. Second tumors, second primaries, are a particular challenge in ENT, where up to 15% of ENT tumors will eventually have also lung tumors. One of our jobs, particularly when you find other tumors or other findings, is not to hold up things. This also goes for aneurysms found incidentally. This particular patient had a hotspot in the abdomen in an ostensibly radically treatable tumor. There's the hotspot. It was a polyp. So this kind of malignant polyp will have to come out eventually, but shouldn't hold up treatment. Nodal treatment, as you see here, we do very poorly just with CT, specificity and sensitivity. It gets much better with PET CT, but we need to add EBUS to make these findings definitive. This is this flow chart in McConaughey's BMJ article. I would urge you to have a look at this. It's quite simple. And really, broadly, what they're saying is we don't have to sample CT negative, PET negative nodes. We take that as negative because the numbers of false positives are excessively low, but we do need to sample positive nodes at PET because many of those will turn out to be reactive or other causes like sarcoid. So this is a rare example. We think this occurs in less than 5% of patients of a small tumor with a node which on CT was not positive. So it was less than 10 millimeters, but it was avid on PET. So this was sampled and it was positive. So this alters the treatment plan. On the other hand, you often are faced with this situation where a small tumor looks node positive. These are, by the way, not reachable with EBUS. This will need mediastinoscopy, but some nodes on this were reachable with EBUS. All were negative, and this proved to be a, you can see that the nodes take up tracer on PET. So it all looked bad. So it looked like N3 treatment, but sampling was negative, and it turned out to be a T1C N0 M0 needing radical treatment. Mesothelioma, very poor inter-observer variation on this, and that has to be borne in mind when treatment plans are formulated. It's obvious in this case where the tumor extends onto the mediastinum that this is N3. Remember, there are only 2 nodal stages. Thoracoscopy is vital here because CT biopsy is frequently negative because of the poor cellularity of mesothelioma. Finally, the only trial that's examined intensive follow-up hasn't completely reported yet, but it compared intensive follow-up with just follow-up by CT scan, and there was no statistical benefit to CT intensive follow-up leading to PET. That is a bit dismal when you think of the amount of scans that we do for follow-up, and this is something that we'll have to look at in terms of resource management in the future. But I thank you for your attention, and I'll just show you a brief picture of where I'll be in Scotland in a week's time. Thank you very much.
Thank you very much, Dr. McGann. That was absolutely fantastic. Such a succinct talk and such a clear talk. I'm sure there'll be a lot of questions for you, and I'll be grateful if you could stay back for the MDT panel. Thanks. Our next speaker is Hazim Fallah. He's a colleague, and he has stepped in for Mr. Bichet, who unfortunately has a problem at home in terms of his father not well. So he will not be able to join us. I know how much you were looking forward to listen to his talk, but I'm sure Mr. Fallah will do justice to this talk. So Mr. Fallah will connect, and he will take on from where Dr. McGann left, with a radiological staging followed by the surgical staging. Hazim, are you around?
Yeah, I'm here, Meninda. Can you see me?
Thank you very much.
Yeah, I tried to share my screen. I think I am sharing now. Yes, as Mr. Karkat said, I am Hazim Fallah, thoracic surgeon at UHB, and I have the near impossible task to match Mr. Bichet, who's I'm filling in today, to talk to you about the role of surgery, not particularly in treating lung cancer, but in the diagnostic process in terms of staging and histology. I have nothing to declare in terms of conflict of interest, and I'm hoping by the end of the talk I will shed some light on the importance, or it might be the case otherwise in some situations, in having histology before surgery, I wouldn't dwell much on the indications for additional imaging after this excellent talk from Professor McGann. I would also, there will be some interaction between what I've wanted to talk and what Dr. McGann, Professor McGann has alluded to, so I'll skip certain parts of the talk. We'll talk about the role of invasive staging. What I mean invasive could be surgery or other invasive modality, and then there will be treat for everyone, try to address the management of N2 disease, both at staging and treatment, with some treat to our audience from the US, who I trust they're up and watching this on YouTube and see and address the variation between the two sides of the Atlantic in terms of practice. I think I wouldn't dwell much on this again. Professor McGann has mentioned about the importance of obtaining biopsy and the challenges, but the bottom line is you always go for the target that will give you the highest staging. So you'll go for histological diagnosis and confirmation of staging at the same time. You will be greeted with these two cases invariably, one after the other in the MDT, where your friendly radiologist will tell you this is behind the scapula, this is going to be tricky and small and superficial, but you managed to get them to, you managed to get them to put a needle in it. It's just jumping. And then as it happened, sorry about that, as it happened, this was biopsy, then resulted in pneumothorax. And then you would argue, if this has turned out to be negative anyway, would you have biopsied it? Would you have let it go if the patient's fit for surgery? On the other hand, I don't know if this is going to skip appropriately or not. Okay, so I think the point being is if you are going to get a CT guided biopsy, that a negative and a positive will still going to lead to surgery. Why do you need to do a CT guided biopsy in the first place? An example of why you might want to, these are two cases you chose to do frozen section on at the time of surgery. And if you are following, I'm having issues with that. If you are following the herder, you'll probably be all right in most of them, as this will turn out to be non-small cell cancer at the same time this turned out to be TB. I think Professor McGann has alluded into this. But the bottom line is which ones to go for histology. In my books, I'd like to have histology if there is another cancer that I want to differentiate between primary and metastatic that determine the nature of resection, I would do. If I'm suspicious of small cell where surgery has got a limited role, lesions that I wouldn't be able to wedge easily, and then taking into consideration logistics of expertise and availability and timing, and the risk of pneumothorax. Just moving on to the radiological, radiological role of additional imaging in staging lung cancer. I'm just going to reiterate the message very quickly about the role of MRI is in the T staging of lung cancer inside the chest. And this is limited to the pancreas and the neuroinvasion or the spinal invasion for lower tumors. It won't help you in determining mediastinal invasion. You could see this tumor is likely to come out without much bother. There's a plane between it and the aorta. On the other hand, this one is questionable, and you might want to bite the bullet and go and take it out, or if the patient not fit, consider downstaging, obviously with the right consent of the risk of opening and closing. Moving on to the role of staging of surgery at the lymph node level, again reiterated by Professor McGann. This was a T1, T2 and 0M0 post-surgery with appropriate lymph node sampling or dissection. You will invariably face some that will be upstaged, and this is been echoed in many guidelines about the importance of lymph node dissection or extensive sampling. The role mainly is to it's been widely agreed that the role of that is the actual exact staging of the patient and the ability to offer them the appropriate adjuvant treatment according to their correct stage. It's emphasized on the importance of sampling lobe-specific mediastinal 3 stations, as well as the sublobar and the interlobar and the hilar lymph nodes. When it comes to the M staging, surgery could definitely help. This is a squam with a pleural effusion that was tapped to be negative, and then patient who is fit, you would consider do that in one sitting, and you put your VAT scope before committing to operating. Unfortunately, this is what you might be seeing in despite a negative, a previously negative tap, and that is an M1A. Obviously, you won't proceed with that. The patient would have had a GA, which is not a big deal, and a small cut. Now, in terms of the nodal staging and the mediastinal nodal staging and the role of invasive staging, you are greeted with a fit patient, 50 something, with a father of 3 with that. Obviously, you're very suspicious of a mediastinal and 2 disease, and Professor McGann mentioned the sensitivity and specificity with these figures, despite being very convincing sensitivity of PET. You might want to prove in 2 disease prior deciding your management plan. And true, you did that, and that would have been proven to be N2 disease. In fact, the importance of mediastinal lymph node aggressive staging or invasive staging, so to speak, is been reiterated in many guidelines. The ESTS advocate almost every tumor to have a mediastinal lymph node staging, except for the less than 3 centimeter peripheral tumor with negative PET. It does have some contradiction with the evidence with regard to the importance of sampling large non-PET avid lesion, as Professor McGann has mentioned before me. It's a decision to be made based on the size and the bulkiness and the fitness of surgery, and this is not a big deal anymore with the advent of EBUS and EUS, which are relatively very low, has got low invasiveness and fairly high specificity and sensitivity. So in that patient, let's say he's had his EBUS and it was negative, would you settle with that? Let's say it was the only lymph node and you think you could resect it, but you might want to go for the gold standard for mediastinal lymph node in sampling, which is this cervical mediastinoscopy, where you should be really aiming for all these lymph nodes as a minimum. Professor McGann touched on station 5 and 6, the aortopulmonary window, and para-aortic lymph nodes that are pertinent to the left upper lobe, and there is the extended mediastinoscopy where you would go in front of the subclavian and the innominate artery, trying to target that. It's been described by Ginsberg in the 80s, but hasn't picked up simply because it's not as straightforward. And there is a general concern about doing it. I personally don't do it, and I don't know many people who does here. I take a pragmatic view that I'll do the limited mediastinoscopy, and I would accept that if the patient has got the only lymph nodes to be involved are station 5, I would go in and resect it with the tumor as a limited single station N2 disease. So we go back to our poor friend who's now proven to be N2 disease. So in 3 minutes, I would like to give you an insight of the challenge that you might be facing in making that decision. Would you operate on this patient? Is that a yes? Is that a no? If you haven't got a straightforward answer, you cannot be heavily criticized. Data has shown that survey from 500 thoracic surgeons in the US did not have any clear consensus of how to approach N2 disease. You go across the Atlantic back to the motherland, Europe, and you would find further discrepancy from what happens in the States. In this article that looked at the registry both in Europe and the US and showed that the upstaging during surgery is double its figures in Europe than it is in the States, and the conclusion that the North American surgeons who might be watching us on YouTube are less keen on operating on the persistent N2 disease, while and they will be more keen on staging the mediastinum properly, while the European counterparts have no major issues in going for the limited N2 disease, including pneumonectomies. And it's a big deal, as Professor McGann talked about, in terms of the survival of N2 disease is not very good. It's pretty dismal, and it is important to know what you're dealing with. And data time and time again demonstrated that surgery alone for this group of patients doesn't really cut it. 8 months of survival versus 26 months with some multimodality treatment. It kind of brings the argument home that surgery is just not adequate for these patients. Another strong point here is if you've got a high T3 disease with N2 disease, the survival in 5 years from a series by Dartvell showed 0% survival in 5 years. So you really need to be very aggressive in your mediastinal staging. I will try to get through this very quickly. So what do we know about N2 disease? No matter where you live, they are detrimental to on the impact of the patient. Surgery is not enough. You really don't want to do chest wall and pancreas in N2 disease. Having said that, it's widely agreed that there are different N2 disease are not equal. And my favorite line, some more equal than others. I wouldn't dwell much on the intergroup data, but the bottom line has shown in 2 words, limited overall survival for surgery versus surgery plus chemo-rad, concurrent chemo-rad in the whole group, but better progression-free survival. The subgroup has shown a lobectomy has a better survival overall, but the study was not powered to show that. Equally, I'm reaching my 15 minutes. A very important survival factor is the ability to downstage the patient in these groups after surgery, and that might stress or make the case for the American approach, which is you do your EBUS, you demonstrate N2 disease, do chemo-rad, and you do a mediastinoscopy after. If it persisted, you go down the oncology route. If it's sterile, you will operate on a patient post-chemo-rad with surgery. The Europeans have different approach. They will do extensive mediastinoscopy and mediastinal staging. If it's a multi-station N2 disease, you go down the definite chemo-rad and you wouldn't have surgery. If you don't, and it's a limited N2 disease, you will do your operation and send it to adjuvant treatment. So as a conclusion, the staging is important for survival. you should try to get your histology as much as you can. Additional imaging, be discreet of what you might want to do. PET is essential. MRI has got its role only in limited cases. The surgery has its role not only in treating, diagnosing, and staging as well, and it could be all in one stop. Into disease, we all know that you should really make sure you stage the patient properly. If you've got chest wall, induction chemorad should be considered based on the evidence. Having said that, that's all might become hypothetical when you hear our following talks talking about the Pacific trial. Thank you very much.
I can understand this is a minefield, this topic, but you have managed to give a brief review of what is surgical staging all about. And as I said, we are adding up the minutes for our MDT, and so the question answer sessions will be combined with that. So be ready for taking questions from the delegates later. Now we'll move on the treatment bit of the lung cancer, and starting with the medical oncological input for cancer. We have Professor Gary Middleton here. Professor is working here at UHB, and he's a professor of medical oncology at University Hospitals Institute of Immunology and Immunotherapy. He's a principal investigator on plenty of studies going on, and it's always fantastic to listen to him. So get your pen and pencil and start writing what he's going to tell you. It'll be the golden nuggets. So Professor Middleton, you are online.
Good morning, all. Can you all hear me? Yep. Can you see the slides?
Right. Yes. Thank you.
Okay, I'll get cracking there. Well, look, I've got 20 minutes to talk about the whole of lung cancer, so I better get cracking. Essentially, what I'm going to do is we've got a clinic starting in 20 minutes. So I thought I'd do a 20-minute talk in 20 slides so that one or two of you can come over and help out in clinic. So I'm going to tell you how to get by in your first lung medical oncology clinic in 20 slides. In other words, what you really need to know to get you started. I think this really does summarize the sort of state of play with this particular disease at the moment. I'm going to start with this first study here. This is Keynote 189. This really does set the scene because really this established what the standard of care is for patients with non-squamous, non-small cell lung cancer in the advanced disease setting. And this was an incredibly important study. So what this study was a very straightforward trial here of patients that were randomized to either receive pembrolizumab plus chemotherapy or chemotherapy plus placebo, and the chemotherapy was pemetrexed platinum. And then it was a straightforward 1-to-1 randomization, oh sorry, 2-to-1 randomization with overall survival and progression-free survival as key primary and secondary outcomes. And I've got just here the overall survival outcomes here, and you can see for the total population a really significant improvement in the overall survival for patients receiving pembrolizumab in addition to their chemotherapy compared with chemotherapy alone. You can see those Kaplan-Meier curves, they split right at the very start and they stay apart right the way down of these. And when you start looking at the point estimates here at 12 months, 17 months versus 48%, 24 months, 45% versus 29.9%. And the hazard ratio for overall survival was 0.56, and it was a 44% reduction in the risk of death for the addition of pembrolizumab. And the crucial point about this study was crossover was allowed, and indeed crossover to an anti-PD-1 agent, which is obviously what pembrolizumab is, was 53.9%. So that's a real world amount of patients that would cross over. So the combination of chemotherapy plus immunotherapy up front for non-squamous, non-small cell lung cancer patients is clearly an absolute standard of care. And this is across all the TPS. This is tissue proportion score. In other words, the amount of cells, cancer cells expressing PD-L1, and you can see this in greater than 50% PD-L1 patients, 1 to 49% PD-L1 positive patients. And also this group of patients here, this is really important. This is is the negative patients. They've got no expression of PD-L1 on their cancer cells. In other words, very little interferon gamma being produced by T cells upregulating PD-L1, a cold tumor microenvironment. They normally respond very badly to checkpoint blockade, but you can see here that again they get a massive improvement for the addition of pembrolizumab, the anti-PD-1 agent, to chemotherapy with a hazard ratio of 0.52, and you can see this more than doubling of 24 months of survivorship. Really impressive. Same thing's also seen with progression-free survival. Again, those Kaplan-Meier's, they split right at the very top and they remain apart right the way down. So really impressive PFS improvements as well. Again, with a hazard ratio of under 0.5 there, as I say, really very impressive. And when you look at the response rates, they speak for themselves. It's along this line here. We've got objective response here. This is in all patients, so patients irrespective of PD-L1 status on the cancer cells, less than 20% for chemotherapy alone, nearly 50% for the combination with pembrolizumab. And even in that TPS less than 1%, the PD-L1 negative population, you've got a doubling of the objective response rate for the addition of pembrolizumab to chemotherapy. This is really a stunningly important study. This represents the ultimate first-line standard of care for patients who don't have a target, which I'm going to come to in a minute, in terms of their first-line treatment for non-squamous non-small cell lung cancer. And it doesn't stop there either. This is a study that was done in squamous cell patients. This is Keynote 487. Very, very similar design here, but with a 1-to-1 randomization. And what we've got here again is the overall survival, because I think overall survival is a really key gritty primary endpoint or secondary endpoint. And again, overall survival is really very important here. I've split this out according to those that are PD-L1 positive and those that are PD-L1 negative. And again, you can see there's a benefit for the addition of pembrolizumab to chemotherapy, this time Taxol Carbo, compared with Taxol Carbo alone. For those that are PD-L1 positive, you can clearly see this is beneficial. And even at the 2-year mark, the landmark here, you've still got a greater than 10% improvement in that, again, with a good hazard ratio. This PD-L1 negative group with the squames is a little bit tame, let's be perfectly honest. They were lucky at the median with a big bulge there. And by the time you get to the 2-year mark, you've got these two coming together. But again, you've got a hazard ratio in favor, although not statistically significant, for PD-L1 negative. And I think, again, this remains a standard of care for first-line patients treated with squamous lung cancer if they're fit enough for this. These combinations, chemo, IO, a serious treatment, and they've got to be fit enough to actually take these. Again, crossover, very significant in this study, so it wasn't a dilution effect for a lack of checkpoint blockade in the placebo arm, with, in this situation, 50.5% of patients crossing over to receive pembrolizumab subsequently who received chemotherapy alone up front. People always moan about paclitaxel carboplatin in the UK, but this old study here, 19 years old now, is in the audience when this was presented, basically compares what I've just shown you, carbopaclitaxel, which is the backbone of that particular chemo IO regimen in squamous cell lung cancer patients, with docetaxel cisplatin and gemcitabine cisplatin. Overall survival, time to progression, absolutely no difference at all. There's nothing wrong with Taxol Carbo. People always moan about it, but it's as good as any of the other ones without a shadow of doubt when you look at this large randomized trial. So what about those patients with high PD-L1? These are patients who've got hot tumors. PD-L1 is upregulated by interferon gamma produced by T cells. If you've got a lot of T cells, it's an immune active in microenvironment, then you're going to get heavy PD-L1. And this is what we call the greater than 50% group. Those that have got their cancer cell staining for PD-L1 of greater than 50%. And again, this is an utterly key study here. This is Keynote 24. And this, in fact, is a 5-year outcome now. And I've got 5-year outcome data, really important. I just want to feast your eyes on this, okay? So this study was quite bold at the time. It randomized patients with TPS greater than 50% to either pembrolizumab alone up front first line or standard platinum chemotherapy. And you can see again those curves part right at the very top in favor of pembrolizumab, and they stay apart right the way down this, okay? And just look at this 5-year survivorship. For patients with PD-L1 positive tumors receiving pembrolizumab up front, 1/3 of these patients are alive at the 5-year mark. That's absolutely unheard of. A lot of these patients are still alive in the chemo arm, but would have got subsequent checkpoint blockade. But to see this is unbelievable. When you think prior to immunotherapy, this figure at 5 years would be basically asymptotic to 0, would be about 1 or 2%. So these are really, really important studies indeed. Keynote 24 really tells you that if you've got PD-L1 positivity, you do fantastically with just pembrolizumab alone. And again, if we look at the progression-free survival, look at this. You've got actually actually 1 in 8 patients with no progression at all. And some of these patients will be in complete remission. And I'm pretty sure, given the patients that we treated back early on in 2013, 2014, that they're probably actually cured of their metastatic non-small cell lung cancer. Great data indeed. And the question really is, if you've got a PD-L1 greater than 50%, should you use pembrolizumab as a monotherapy or the combination? Because I've shown you that the combination still provides a hazard ratio over chemotherapy alone in the greater than 50% TPS patients. So this is something you shouldn't really do at home. It's a direct head-to-head comparison across trials, which obviously you shouldn't really do. So over here, we've got the Keynote 24 that I've just shown you. Over here, we've got Keynote 189, which I showed you right at the start. The things to look at are the point estimates again here at the 24-month mark. This is pembrolizumab alone in PD-L1 greater than 50% of 51.5%. And this is pembrolizumab plus chemotherapy at 51.9%. In other words, there's no difference whatsoever. And actually, for those patients that are possibly a little bit uncertain in terms of their condition, their performance status, we definitely would give pembrolizumab monotherapy. And the only time with the greater than 50% that I think about giving that is those that seem to have really rapid progression, and I'm worried they might not respond to checkpoint blockade and might not get on chemotherapy, or those with very bulky central disease who really do need a really rapid response to treatment. Now, one of the questions is there anything useful to add on to the pembrolizumab monotherapy in the TPS greater than 50% patients besides chemotherapy? This is a very interesting study, actually, conceptually. So this is Keynote 598, and this is pembrolizumab alone in greater than 50% TPS compared with the combination of pembrolizumab plus the anti-CTLA-4 agent ipilimumab, which basically improves naive T-cell priming. And you can see here, actually, this is a total bust, okay? This is overall survival here, absolutely no benefit at all. But would you have expected this result? The short answer to that one is probably yes. And the reason for that is that you've already got a very hot microenvironment with a lot of T cells in there by virtue of the fact of very high PD-L1. So you don't really need many more T cells in there. In other words, you don't have an absolute requirement for naive T cell priming, unlike a very cold microenvironment where that might help. Is there anything that might be useful to add on to pembrolizumab or indeed to anti-PD-1 or PD-L1 in the greater than 50%? Well, there's a lot of excitement about this agent here. This is something that's quite difficult to say at this time of the morning, but this is basically an anti-TIGIT antibody. And like PD-1, which is expressed on T cells, is also expressed on exhausted but antigen-experienced T cells. And we know that if you've got very high PD-L1 and PD-1 in a microenvironment, you're going to get all the other checkpoints upregulated, like LAG3, TIGIT, for example. And this is an anti-TIGIT antibody plus atezolizumab, which is an anti-PD-L1 agent. And in those with greater than 50%, look at this. This is a trebling of the objective response rate up to 66%. And when you then look at this again in the PD-L1 greater than 50%, you've got a very, very significant improvement in progression-free survival with a hazard ratio of a whopping 0.30. And this wasn't seen at all in the PD-L1 1 to 49%. And this is an ongoing study now called Skyscraper in the greater than 50% patients of PD-L1 alone versus PD-L1 plus TIGIT in the greater than 50%. And this could again be a new standard of care in those patients with very high levels of PD-L1 expression. Now, of course, this is a surgical meeting, so let's get on with the meat and to veg of this particular presentation. And this is now looking at something that I think is going to be coming to an MDT near you in the very near future. And this is basically neoadjuvant immunotherapy. So this is the only randomized study we've got so far. This is a randomized phase 2 study called NeoStar, published this year in Nature Medicine. Just a small number, N equals 44. But to cut a long story short, what they did here was to compare either a short course of a single agent nivolumab or a short course of nivolumab plus ipilimumab. In other words, single IO or combination immunotherapy, with the main objective main response rate here, the primary response rate, primary endpoint here being this thing here, which is major pathological response. In other words, when you take the tumor out, there's less than 10% of cancer cells left behind. Okay, so that's a pretty big bar. You can see here that when you directly compare patients who are receiving either nivolumab alone or nivolumab plus ipilimumab, you've got a doubling of the MPR. But look at this very important figure here. This is pathological complete response. And in those patients receiving combination IO, this is 4 weeks of treatment, folks. You've actually got a 40% of these patients, just under, that have got no cancer cells whatever left behind. These are the responses, the pathological responses over here on the right, and they're color-coded by radiological response. And you can see that those patients with path-CRs certainly normally get either very good radiological responses, but what's very, very important is that even in some patients with stable disease, in other words, you've done the 4 weeks of immunotherapy, there's no change whatsoever, but on radiology, some of these have got a pathological CR. So using the radiology to guide you as to what to do and what the response rate might be is not that useful, really. So as I say, a 38% pathological CR rate here, but the problem was that 2 of these patients, and there's only 20 in each group, got quite severe toxicity, one with pneumonitis and one with colitis, and 4 of the Nivo-IPI patients didn't actually get to surgery. So is there something else that's a little bit more easier to tolerate and perhaps even more active than combination nivolumab and ipilimumab? Well, the short answer to that one is probably what I've already shown you, and that is the combination of chemotherapy and anti-PD-1. In this situation, this is the Nadim study. I think this is an exceptionally important study published a year or so ago now. And basically what this did was, this is just a straightforward single-arm phase 2 study that did 3 cycles of nivolumab plus chemotherapy with Taxol Carbo. And basically the primary endpoint of the study was 24-month progression-free survival here. And we've got 46 patients treated here, as I say, with these 3 cycles of treatment. And what we've got here is basically complete pathological response in blue, major pathological response in dark blue, and then in yellow incomplete, and then these were the patients that didn't go to surgery. Out of this group, there were none of these patients got adverse events that led to treatment discontinuation or surgical delay or indeed death. And the 24-month progression-free survival in this neoadjuvantly treated group of patients was 89.9%, and exactly the same as you would expect for overall survival. And when they looked at pathological complete response rate, it was 63%. 2/3 of these patients treated with 3 cycles of chemo IO preoperatively had no cancer cells whatsoever left behind when the tumor was taken out. And the major pathological response rate in the surgical specimen was 83%. And in those 2/3 of patients with pathological complete response, the progression-free survival rate at 24 months was a massive 96.2%. I think this is going to represent the new standard of care for treatment of patients with surgical disease, resectable disease, and the ongoing phase 3s shortly to report. But I think this is coming to you very, very shortly. So for my last few minutes, we need to talk about obviously targeted therapy. So I've talked a lot about immunotherapy and a bit about surgery. Targeted therapy obviously is used a lot in lung cancer. We're very lucky. We've got diseases that respond to immunotherapy and diseases like this. This is EGFR mutant disease that respond very nicely to targeted therapy. This is a very important study that defined this drug here, osimertinib, a 3rd-generation EGFR tyrosine kinase with good activity against the T790M gatekeeper secondary resistance mutation. And basically, patients were double-blind and received either osimertinib up front for their EGFR mutant disease or the comparator EGFR tyrosine kinase inhibitor, in this situation either gefitinib or erlotinib. And basically there was 556 patients randomized on a 1-to-1 basis, and you can see here a significant improvement in outcome for osimertinib. Indeed, there's a difference here in terms of median survival of 6.8 months. And when we look at this all-important hazard ratio, and this is overall survival, again really, really important, because 31% of these patients on comparator TKI crossed over to osimertinib, which is about what you'd expect, because you get 50% getting T790M and crossing over to osimertinib. And even in the overall survival, it just about hits significant. That p-value is below the bar for the significance in this study, with a hazard ratio of 0.80, in other words, a 20% reduction in the risk of death. So that's, again, a really, really important study that quite clearly shows that osimertinib should be the standard of care up front because it improves overall survival, and particularly it also significantly improves brain met control as well, with a hazard ratio for brain met and PFS of 0.48. So brain mets are very common. Osimertinib gets in really well to the brain. So again, it's a much better brain control as well. So we give our patients first-line osimertinib. Obviously, they progress normally around the 2-year mark, maybe a little bit shorter. What do we do with these patients? This is a really nice overview of what to do in patients with osimertinib resistance. And basically, if they've got progression, but it's oligometastatic progression, one site type thing, then local ablative therapy is the right way to go with continuation of the TKI. This is actually being looked at prospectively in the randomized HALT study. But I think in the US, if you've got oligometastatic progression, it's basically a no-brainer. You just get on and you do locally ablative therapy, whether it's in the brain or outside of the brain. There are some very well described bypass pathways for osimertinib resistance. Probably the commonest one that's described is MET amplification, which is not uncommon at all. There's been a lot of work done in combining MET plus EGFR inhibitors, and certainly the story is that basically it works quite nicely. In other words, combining, for example, osimertinib, because you've got to continue the EGFR because that's still a driving factor, but you've got to block MET as well. Combining osimertinib with something like capmatinib or tepotinib or crizotinib. One of the best drugs in this group at the moment, which we can't actually access at the moment, is a drug called amivantamab, which is a bispecific EGFR MET antibody, and that's looking really, really good. Then there's a number of fusions, which we see up front, as all of you know, in our lung cancer patients, but can also be seen as secondary fusion resistance mechanisms. So RET, and again, combining a RET plus osimertinib, and ALK plus osimertinib, and ROS plus osimertinib, okay? You do get histological transformation both for first generation TKIs and indeed osimertinib to small cell, and these are obviously treated with standard chemotherapy. And then you get patients with tertiary resistance mutations. So the secondary resistance mutations, T790M, the tertiary one is C797S, and also obviously patients with unknown mechanism. What do you do with these? Well, usually just treat them with a platinum doublet. But you can, if they've got stability in their CNS, consider continuing osimertinib, because osimertinib might be controlling the CNS disease, and therefore continuing that would be valuable for the patient to prevent further progression in the brain. Again, they do that a lot in the States. In the UK, we can't really do that at the moment, but they also suggest this particular regimen here. This is the IMPALE 150 study. They put the point here that there's some safety concerns regarding this, but why would you think about using the IMPALE 150 study in patients that progressed on TKIs, EGFR TKIs? Well, it's for this reason. We use it quite a lot here in Birmingham. This is a very interesting study. This is IMPALE 150. This went the whole 9 yards. It compared chemotherapy with paclitaxel carboplatin plus anti-PD-L1 atezolizumab with chemotherapy plus bevacizumab, or all four. In other words, atezolizumab, bevacizumab, chemotherapy. And what you can see very nicely here, that in EGFR positive patients in this study, the addition of atezolizumab provided no benefit over the addition of Avastin. And that's because patients with EGFR mutant disease have got very low mutational burdens and respond very poorly to checkpoint blockade. But look at this here. If you've got the situation where you add on the atezolizumab to the Avastin and compare it with the backbone of BCP, in other words, bevacizumab plus chemotherapy, sorry about that, then you actually get a very significant hazard ratio for overall survival, 0.31 for sensitizing EGFR mutations. And I think that's a really important result. And the reason why we probably see that is because EGFR mutant tumors have got very high levels of VEGF, and VEGF is a very immunosuppressive molecule, which I haven't got time to go into. It's a whole lecture in its own right. This obviously I need to show you because this is an adjuvant study. This is AD-AURA, that basically took patients with stage 1B to 3A resected disease. They could have had adjuvant chemotherapy, and then randomized them to either placebo or 3 years of osimertinib. A very, very important study with a primary endpoint in this group of disease-free survival in the stage 2 to 3A patients. 682 patients were randomized in this particular study. As I say, disease-free survival was the primary endpoint. And just look at this here. In this group of patients, at 24 months, there were 90% of patients disease-free on osimertinib, compared with just 44% of patients receiving placebo. And there is a stunning hazard ratio for disease recurrence of 0.17, an 83% reduction in the risk of disease recurrence or death. Really very important. And again, in the secondary analysis population, which included the 1B patients, again, you've got this whopping hazard ratio for disease recurrence of 0.20. And we can actually get this at the moment on an expanded access program. We're very lucky to be able to do that. And again, I think for EGFR resected disease, then this would be the standard of care. The only caveat, and the fly in the ointment, is this might not translate to overall survival, because patients, when they relapse, will then get a TKI, and it's going to be very, very important and very interesting indeed to see whether or not there's actually an overall survival benefit with these. Last couple of slides here, but this is important data as well. This is one of the other things that we treat a lot of in lung cancer. It's much rarer than EGFR mutant disease. This is patients with ALK fusion, first described preclinically in 2007, and the first phase 1/2 was published in 2010. Pretty impressive to say the least. This is a very important study. This is basically standard first-line treatment. That was the first one that was ever used, really, crizotinib versus alectinib here. This is 303 patients with a primary endpoint of progression-free survival, and this is the updated data. Very important that alectinib gets into the brain very well, because brain metastases in ALK fusion disease is very common indeed. At baseline, 50% of these patients had that. And when we look at here, we just have a look at the progression-free survival, as I say, the primary endpoint, a very impressive hazard ratio in favour of alectinib over crizotinib, making alectinib really the first-line standard of care with no shadow of doubt. Clearly got its primary endpoint. And when you look at progression-free survival in brain mets at baseline, that was 7.4 months for crizotinib because it doesn't get into the brain, compared with 25.4 months in those receiving alectinib. So a huge difference. And look at the overall survival here. The 5-year overall survival for patients receiving alectinib was 62.5% compared with just 45.5% receiving crizotinib. And again, over half of the patients who progressed on crizotinib got a second or third line of ALK TKI, including alectinib. So again, a lot of crossover. This is a very important result. This 20% improvement in overall survival at 5 years is something not to be sneezed at. And then the final slide that I've got here, this is really, really exciting data. Some of you might have seen this. This is with what we call G12C inhibitors. So KRAS traditionally has always been seen as a completely untargetable disease, unactionable disease. But there's one KRAS mutation that is targetable, and that's G12C. That makes up about 50% of KRAS mutant adenocarcinoma of the lung. So this is 1 in 8 of our non-squamous, non-small cell lung cancer patients. So it's a lot of patients. And the reason these drugs work is because G12C is quite different from other RAS mutations. It maintains a bit of catalytic GTPase activity. So it pushes a GTP back to GDP, and then the cysteine in the G12C pushes up a little pocket which can get a covalent binder on, and that can then lock this molecule into its GDP inactive form. In other words, it actually locks it into the inactive form. That's how it works. And this is data that's just been published in the New England Journal of Medicine. This is an update. 124 evaluable patients for response. Look at this waterfall plot here. This is formerly something that we could never target. Now we've got an objective response rate in G12C mutant patients of 37.1%, disease control rate of 80%, and shrinkage in nearly 85% of the patients. And the duration of response, in other words, how long these responses go on for, was actually 11.1 months with a very quick time to response. And there's 70% of patients progression-free at 6 months, which is what you see basically with crizotinib in ALK fusion disease. And then we've got the progression-free survival here at 6.8 months and overall survival at 12.5 months. These are for us extremely important, extremely exciting data. There's a lot of work going on combining this with every single thing you can chuck the kitchen sink at. But again, for G12C patients, this is a total new standard of care. And when you add this to EGFR inhibitors, ALK inhibitors, ROS inhibitors, MET exon 14 skipping mutations, and this morning in the New England Journal of Medicine, we've got a new kid on the block, and that's HER2 mutations, which again occur in non-squamous, non-small cell lung cancer patients. And there's some really lovely data with the antibody drug conjugate TDXD showing a 55% response rate with a duration of response of 9.3 months. And another great drug to the armamentarium of lung cancer. And when you think back 20 years ago, we were doing studies of chemotherapy A versus chemotherapy B, you can surely see that we've come some way. Thanks very much indeed.
Was absolutely fantastic talk. I think it will take some time for us to actually go through your slides and take it in, but it's very, very exciting what's going around, and targeted and therapies and immunotherapies. And it's an exciting time to be a thoracic surgeon and the collaborative work we can all do together. Prof, we are planning to continue with the talks, and then there is MDT in 20 minutes. I'd be so grateful if you could join us in that panel where we will be presenting cases where what you have spoken.
I'll do my very best. So as I say, I'm just literally starting clinic now, but I'll just see if I can get the boys rolling. How long's the MDT going to go on for?
It'll be about an hour. So yeah, I know you're busy, but if you can, pitch in, that'll be great. Yeah,
I'll do my best.
Yeah, it starts at 9:10.
Okay.
And finish at 10:30. Yeah.
Right. See you later. Hopefully, I'll join at some juncture. Okay. Take care.
Awesome. Thanks, Prof.
Bye.
Thank you very, very much.
Bye.
So for the delegates, could I request you, please, you have got the feedback form, please fill it up and send it back to us. And not only will help us to improve the courses for the next year, but also that's important for you to get your certificate. So please fill that up prospectively as you go through the talks. My next speaker is Rob Stevenson. He is a radiation oncologist with us here in University Hospital Birmingham, and I've known him for the last few years. And every time he sits in the MDT, he's a voice of calm and reason, and that's what he's going to demonstrate in the talk he's going to give us now. Rob, are you there?
Sorry, I was muted. So thanks for that, Melinda. I think I need to lie down after that because Gary blows my mind every time he talks. He knows so much. I'm going to talk about easy things, and that's magic rays. So radiation oncology. So I'm a clinical oncologist at Birmingham. So I deliver chemotherapy and radiotherapy. Let's go to the next slide if I can. There we go. So basically, radiotherapy, the different kinds of radiotherapy are electrons, photons, and protons. Photons are pockets of light energy and the most commonly used clinically in radiotherapy. The dose of radiotherapy, if you don't know, is the grey. That's what we use for treatment, is the grey. And 1 grey is equivalent to 1,000 millisieverts. 1 chest X-ray is 0.1 millisieverts. So 1 grey is equivalent to 10,000 X-rays. And 1 grey in terms of radiation therapy is actually quite low. The standard dose fractionation for radiotherapy ranges between 1.8 to 2.75 grays, and that's just a single treatment of a course of treatment. Radiotherapy is in itself very dangerous. If I delivered Melinda a single 8 gray dose of radiotherapy to his whole body, he'd probably die within 2 days. So actually it is a dangerous tool. And we fractionate radiotherapy to be able to deliver treatment. That's one of our standard treatment machines. It's a Versa HD Linac, and there are different models available, but that's what we use at the QE mostly. So different kinds of radiotherapy, different nomenclatures. So radical radiotherapy, I mean, the aim is for good long-term control. There are long-term survivors, and obviously we do hope we're going to cure patients. We know that radiotherapy on its own doesn't cure many. I mean, for instance, early stage lung cancer, if we gave standard fractionated radiotherapy, the 5-year survival would be about 20%. For the equivalent patients receiving stereotactic radiotherapy, which we'll talk about later on, the 5-year survival is probably around 60%. So a significant difference from a different radiation technique. Radiotherapy can also be given neoadjuvantly, either on its own or in combination with chemotherapy for things like pancreas tumors. It can be given adjuvantly, because they involve surgical margins, and we'll briefly touch on a clinical trial later on regarding adjuvant therapy. It can be given sequential, i.e. after downstaging chemotherapy, which we would offer in stage 3 disease if it's not treatable with concurrent chemoradiotherapy at the onset due to its size and distribution. Concurrent chemoradiotherapy is the standard of care now for stage 3 disease, particularly in combination with PD-L1 inhibitors, durvalumab, in PD-L1 positive patients, which we'll touch on later. And there's something called CHART, which is continuous hyperfractionated radiotherapy, and it's basically treating patients with radiotherapy 3 times a day for 13 days continuously. That was shown to be equivalent to concurrent chemoradiotherapy, but you can't access durvalumab in stage 3 disease. And actually CHART in the UK is essentially defunct. I think the last centre using CHART has now stopped doing it in favour of concurrent chemoradiotherapy. So adjuvant radiotherapy, it's been shown to be detrimental actually. There was a decrease in 2-year survival from 55% to 48%. That's based on quite an old trial. And it was using old radiotherapy techniques with higher degrees of toxicity. We only really use adjuvant radiotherapy now if it involves surgical margins, if the MDT agrees. A recent trial, the LungArc trial, looked at adjuvant radiotherapy in completely resected N2 disease, and there was no overall survival benefits. There is, however, a benefit in terms of local disease-free progression with adjuvant radiotherapy, but we don't really offer this due to the toxicity and no overall survival benefit. Sequential radiotherapy, that I said before, the rationale is to shrink the tumour first with chemotherapy and destroy micrometastasis before delivering radical dose radiotherapy. This was the standard of care before we started using concurrent chemoradiotherapy, and the cure rates were lower. The 5-year survival benefit is, however, better with sequential than radiotherapy on its own. It's a 5-year, 5% added benefit, although that trial was from 26 years ago. So again, an old trial with old techniques. And with sequential chemoradiotherapy, it was normally 4 cycles of a platinum doublet before receiving the radiotherapy, obviously restaging after 4 to ensure that you can encompass the disease with the radiotherapy field. So now the standard of care for stage 3 disease is concurrent chemoradiotherapy. Again, there was a 5% 5-year survival benefit over and above sequential. So it's a stepwise approach. There's for radical radiotherapy versus sequential, there's a 5% benefit, and then additional 5% benefit using the concurrent approach versus sequential. Unfortunately, there is added toxicity because with stage 3 disease, we generally will always be treating the mediastinum. So there's added toxicity such as esophagitis and pneumonitis, which can be difficult to manage in some patients, particularly if you're considering immunotherapy straight after concurrent chemoradiotherapy. Concurrent chemorad should be the standard of care for suitable patients in stage 3 disease, and it certainly is in Birmingham. Touching on the Pacific study, so this is an adjuvant treatment after definitive treatment with concurrent chemoradiotherapy. So they looked at adding on a year of durvalumab 2 weekly after concurrent chemoradiotherapy. And they showed that it improves 4-year overall survival from 36% to 49.6%, which is remarkable. You've got a group of patients whose prognosis, 5-10 years ago was dire, probably 20-30%, and now we're getting up to 50% with the adjuvant with the use of durvalumab. Durvalumab's only indicated in the UK. I know different countries have different funding and licensing, but it's only indicated if you've got a PD-L1 positive patient over 1%. And sometimes to get around this, because we do know that there is the PD-L1 is heterogeneous in tumours, often we ask for a block to be retested, because sometimes a PD-L1 negative patient can turn into a PD-L1 positive patient on resampling, which would then open the door for them for durvalumab and increased overall survival benefits. So durvalumab should be the standard of care in a PD-L1 positive patient following definitive concurrent chemoradiotherapy. So going back to actually, because Hazem earlier on talked about the Albane, the 139 intergroup study. That trial was some time ago, and I think NICE in the UK have advocated neoadjuvant concurrent chemoradiotherapy before surgery, and that is based on old data, and they haven't taken into consideration durvalumab in their working out of what should be standard of care for these patients. So sometimes it's very difficult in MDT to actually work out what we should be doing that's best for the patient in stage 3 disease. And my feeling is that the best evidence currently for PD-L1 positive patients would be definitive chemo rad followed by durvalumab rather than neoadjuvant concurrent chemoradiotherapy. And there's just the updated graph on Pacific 4 data showing that there's a persistent over 10% overall survival benefit each year with the addition of durvalumab. So palliative radiotherapy, this is really to control symptoms. If a patient's pretty fit, we'll give say a longer course of radiotherapy, say 36 gray, 39 gray, and 12 to 13 fractions. Or if they're not particularly fit, we may get a single 8 gray fraction. The way we work this out is if we expect a patient to be alive, 6 to 8 weeks after having radiotherapy, we would give them a longer course of radiotherapy because they'll get better control and they'd get reduced side effects. However, if we don't expect a patient to be alive for long, we would give a single treatment to help with their symptoms in the short term, knowing that unfortunately they won't be alive to experience any long-term side effects. So palliative radiotherapy in the main is given for things like hemoptysis, pain, cough, and dysphagia, and for distant metastases such as bone and brain metastases. On that note, we would not offer brain radiotherapy to patients who have a performance status of 2. There was a trial, the Quartz trial, that looked into best supportive care with steroids versus steroids and whole brain radiotherapy. And there was no additional benefit for giving whole brain radiotherapy in patients with PS2 or 3 performance status. As a caveat, I have treated patients with 36 or 39 gray, 12 or 13 fractions, who have lived for, I've got one patient who I saw the other week who's basically still alive 5 years down the line with no evidence of progression. So in some patients, it can significantly delay or cure them from their cancer, but that's quite rare. So SABRE, stereotactic lung radiotherapy, it's a higher dose per fraction. As I mentioned earlier on, the standard dose is 1.8 to 2.75 gray per fraction. With stereotactic radiotherapy, it can be up to 18 gray per fraction, but it's a very small targeted area. So it's in the UK, it's used for T1, T2 tumors, but less than 5 centimeters. The 2-year local control rate is over 80%, it's around 90% actually. And it's an option for non-surgical candidates, so medically inoperable patients or those that refuse surgery. At the QE, we have the CyberKnife, and other centres do. Outside of the QE, there's a few in London, obviously abroad, there's the CyberKnife units. So we can either use CyberKnife or we can use the standard Linac, which I showed you earlier on. Obviously, tumours move when the patients breathe, and so we do a 4D planning scan. So it's a CT scan as patients are breathing, so we can incorporate the full movement of the tumour when we're planning the radiotherapy, so we know that we're incorporating the whole tumour and not missing, because obviously we don't want to miss when we treat, because we can't retreat with stereotactic radiotherapy in the same area. So there's quite a lot of evidence for SABRE. So the cause specific survival at 5 years is about 57% there. Local control about 90%. The problem with stereotactic radiotherapy is that we can only treat out of what we call a no-fly zone. So more central disease we don't treat outside of a clinical trial, because in the original trials there were deaths from treating the mediastinum within this no-fly zone, which I'll show in the next slide. The other problem is obviously we don't prophylactically irradiate the lymph nodes. Obviously when you do surgery, you do a lymph node dissection. But in stereotactic radiotherapy, as long as we feel the lymph nodes are negative on PET scan or proven on EBUS, we don't treat the lymph nodes. And therefore, the biggest issue with the larger tumours is a local relapse within the lymph nodes rather than distant relapse. So there's a no-fly zone. So we outlined the proximal bronchial tree when we're planning these patients, and unfortunately, if it lies within the no-fly zone, we're unable to give stereotactic radiotherapy outside of a clinical trial. So briefly touching on a case, so you can get some dramatic responses with stereotactic radiotherapy. So pre-treatment, it was 4.7 centimeters, 4 weeks, which we don't standardly do. Imaging, this is 3.5 centimeters, and then 10 weeks post-treatment, only 2.4 centimeters. So quite dramatic responses. Sometimes we get these responses on treatment and we'll have to replan the patient. So again, there's a CT image of the tumor there, shrinking there, and so it's a reasonable sized tumor at the onset. Again, shrinkage there at 6 months, but the issue here is show the relapse in the lymph node. And so that's the issue with SABRE. We don't treat the lymph nodes. If we thought the lymph nodes were involved, then obviously we'd give radical radiotherapy or chemoradiotherapy, where the outcomes are poorer than stereotactic radiotherapy. Obviously, surgery would be the best option for this patient. We thought the lymph node may be involved. So sorry, that's a very quick roundup of radiotherapy. I've only had 10 minutes. So I think we're moving on to the MDT now.
So again, great talk. I think there's a lot to discuss, but you know, with the paucity of time we have, you have given the broad outline. So what we are planning to do is going to run an MDT, just like a real life MDT, which we often do in real practice. So we have cases lined up, and what we want is the panel to be visible if possible, and the panel is going to be Dr. McGann, Dr. David Waller, Rob, you're going to be there. Dr. Dejaraman is sitting next to me. I hope Dr. Alan Seho will connect with us from Hong Kong. and Professor Middleton will be nipping in and out of the busy clinic he has. And of course, I'm here. But this MDT is your participation. So I would like you to be actively participating in this discussion. This is your opportunity to ask as many questions as you want to. I can see there are few coming up, but hopefully we will get them covered in the cases we are going to present. But please feel free. We have got an hour and a half to discuss these cases. So let's make it as interactive as possible. So if people do not raise their hands, then I'm going to randomly pick up one of you to take the discussion forwards. So shall we go through the, so Akshay, he's a registrar with us, so he'll be presenting the cases. I hope the panel is there somewhere and we will connect. I will see if we can get all the panel members one after the other in one line on one side. We are trying to get that, but please make yourself visible. Thank you so much. Right, Akshay, to you.
Good morning, everyone. So welcome to the Thoracic MDT. So we'll start with the first case.
Just 71 years old, male, lifelong smoker with a background of COPD and peripheral vascular disease, performance tests of 1 without any allergies. His pulmonary function tests were done and shown here with an FEV1 of 2.62, which is 93% of the predicted, and an FVC of 4.92, which is 133% of predicted. So this is the CT scan.
Here, one of the radiologists working at UHB. So you can see coronal and sagittal reformats showing you a nodule which looks speculate in a background of centrilobular emphysema, hyperexpanded lungs. It looks like a solitary nodule in terms of the T staging. So people who have learned the TNM staging can start thinking how big it is. It's roughly 1.5 centimeters in size. Go on to the next slide, please.
So now the question is, what further element of the lung functions do we need?
Keep butting in. It's a simple, straightforward question. So what other lung function do you need?
We need DLCO.
That. You can %. You can't hear anything. Can people hear me? Excuse, guys.
Yeah, no, it cuts out at times.
Right, okay. So, okay, Islam, Ibrahim, okay. So what do you think about the transfer factors here? Think they are okay?
It's 67%, so it's okay. Yeah, we have to calculate the predicted post-operative if we are thinking about taking the upper lobe away.
Okay, very good, very good. Okay, can we go to the next slide?
Probability that we are dealing with a lung cancer.
Answer these questions. What is the pre-test probability that we are dealing with a cancer? You need to know what they are. What are the different scores?
The Brock score and the Herder score.
We use. What further investigation are required to substantiate that? Okay, very good. Yeah, tell us about that.
So the CT scan gives us the Brock score. And if the Brock score is above 10%, then PET CT will give us the Herder score.
Investigation in the form of a PET scan, yeah?
Yes.
The hilar node on the right side, but no activity elsewhere. So we have staged this lesion as T1B and 1, and I'm not adding the rest of the scan here, so take it as M0.
What Herder score is and what Brock score is?
Brock score takes into account, I think I'm not sure about all the parameters, but location of the tumor, number of tumors, whether the patient is smoker or not, any positive family history, and it gives a percentage. So less than 10% is a low chance of being a malignancy, but this is between 50 and 75 years of people. More than 10%, there's a significant chance. And then Herder score gives us 3 categories. Less than 10%, again, there's a low chance of malignancy. 10 to 70% intermediate, and more than 70% is a high chance of malignancy. And that takes into account the PET scan and also number of lesions, size of lesion, smoking history, age.
Okay, I think that's quite a comprehensive answer.
Do we need to do any further investigations?
So you said there was a hilar node positive.
Yes, correct. Yeah.
And of course, if the patient is performance status 1, so if the patient is for further management, depending upon how the patient is, then we might need an EBUS to biopsy and maybe CT guided peripheral biopsy, because that nodule is quite peripheral.
Yes, and that's what the results of EBUS were. All the information given to you, you think this patient is resectable?
From the clinical staging wise, it looks the patient is resectable. It's T1B and 1.
Correct. Correct. Could you identify who you are? You are quite enthusiastic and intelligent delegate.
My name is Soumya, Soumya Guha from Sheffield.
Oh, fantastic, Soumya. Okay, so in your view, the patient is resectable, and I agree he's resectable. So after you have clarified the patient is resectable, what else you do? You look for the operability. Is that right?
Yes.
So how are you going to assess this patient is operable?
The operability can be assessed by the tripartite assessment, which means we need to see the postoperative dyspnea score, which we can predict by calculating the postoperative FEV1 and TLCO. And then the perioperative cardiac risk, which we can use the revised cardiac risk index to calculate, and the mortality from the surgery, which we can use the thoracic score to calculate. And if all three, well, the risks from all three are acceptable, then we can say the patient is operable. So the risks can be, it can be good, moderate, or poor, depending upon what we find.
Okay. So what further investigation do you need in this patient? If this patient is sitting with you in the clinic, how will you assess him for the operability?
So the patient is performance status 1. So I'd like to ask how fit and active the patient is in general. I mean, his post-op lung functions were not very bad, and if he is due for a right upper lobe resection, then he's going to get three segments removed. So his post-op, from whatever we saw, post-op FEV1 DLCO should be above 40%. So that should give him, from the BTS point of view, a decent risk from post-operative dyspnea point of view. For the cardiac, I'll obviously take a history of all the cardiac, if there is any positive cardiac history. And then if there is, then he'll need to be investigated from the point of view of echo and other investigations to see what that risk is. One of the ways, if the patient is borderline, is to just do tests such as a stair climbing test, or a shuttle walk test, or a cardiopulmonary exercise test, if the post-operative FEV1 or DLCO was calculated to be less than 40%, to see what the risk is. But if the patient is fine.
That's absolutely right. So you do a subjective and objective assessment of the fitness. So that's what the objective evidence is there in front of you.
So VO2 max is 14.6. Think above 15 we consider to be good. Between 12 and 15 is a bit borderline. Respiratory exchange ratio is 1.14. I'm not sure, but I think if respiratory exchange ratio is more than 1, the effort is. So I'm not very sure about that one, but it was terminated early. So from this point of view, it looks like the VO2 max is just about meeting the criteria of 15. It is slightly less than 15.
First three options. So first three lines are sorted. So what are the strategies you have?
So the strategies we have is well, surgical resection followed by with the systemic lymph node sampling, and the options, as you mentioned, are three. I think the gold standard was lobectomy, but there is some more evidence that is coming out to say that if it is less than 2 centimeters, even a sublobar anatomical resection or segmentectomy has got almost equivalent survival and disease-free progression. But yes, in the gold standard would be lobectomy and lymph node sampling.
Okay, right. So let's say you talk to the patient, and the patient refused to undergo surgery.
So the options for if the patient is refusing to undergo surgery are SABR, and if the patient does not want SABR, then then the patient can radiofrequency ablation or given conventional radiotherapy, depending upon what the MDT decides. So this is a peripheral lesion, so it's not in the no-fly zone. So it can be, and it is not very close to the diaphragm, so it can be tackled by SABR.
Right.
But the N1, I'm not sure the N1 lymph node would be tackled by SABR because it's in the hilum and would be quite close to the airways.
Okay. So Rob, what if this patient is not agreeable for surgery, and we don't have a diagnosis here either? So what are the options?
Well, without histology, I mean, certainly it's not a SABR candidate because it's N1, so it's a stage 2, isn't it? So we'd normally require histology for conventional radiotherapy. So we'd ask for CT guided biopsy, or MDT. We'd have a discussion with the MDT agreed that it was a radiological diagnosis of lung cancer, and there'd be conventional radiotherapy, so 55 gray and 20 fractions over 4 weeks without chemotherapy.
Okay. 5-year survival for this patient?
Probably around 20%, 15 to 20%.
Yeah,
so very low.
It's very low. So that shows us how important for such a patient where the lesion is T1 possible and one, the surgical intervention is important from the prognostic point of view. Anything else? Soumya, you come from a very high-profile unit. So anything else you will do before you decide to take him for surgery?
So I've done
said, okay, take the patient to surgery. You have seen the patient in the clinic, and he says, okay, doc, go ahead, do the operation. Anything else you're going to do?
So I've got the tissue done. I mean, the CT scan, biopsy, the EBUS has been done. The preoperative assessment has been done. CPET has been done. I have consent of the patient. The patient is operable and resectable, so that should be okay. No, I think the patient is a resectable tumor. I know there is some evidence that if there is a PET positive hilar lymph node and if EBUS is negative or US is negative, then the mediastinal surgical mediastinal sampling can be done. But in this case, it's a station 7, which we will either way sample. So should be able to go for.
Oh, that's right. So we agreed that this patient is resectable. We agreed the patient wants to proceed with surgery. So what else we need to do is that's what is coming on the screen, that in majority of the centers, we do discuss these cases who are relatively high risks in a high risk MDT comprising surgeons and anesthetists. And then this is most important, the preoperative optimization of these patients and following the ERAS protocols. Okay, so this is something which is becoming a part and parcel of successful management, overall management of these patients. So that's what you just need to be mindful of. So this is a routine case which you all get discussed in the MDT, but there is a little nuances here and there which you should be aware of. And that's the learning points which are highlighted in front of you. Great. Shall we go to the next one?
Yeah, so this is the next case. So this is a 62-year-old lady. She's got comorbidities in terms of hypertension, osteoarthritis. She's an ex-smoker. Reasonable exercise tolerance, does get short of breath when climbing the stairs, but has been graded as PS1. Okay, so these are her pulmonary function tests. So FEV1 73, FVC 69, and a TLCO of 67. So she subsequently underwent CT scan, and this is what was found. So these are the two most pertinent slices, axial views.
For the lower lobes, you can see ground glass nodules. So you can see one on the left lower lobe and one in the right lower lobe. We have two lesions here, and we always are now stuck with the question, are these synchronous tumors or is it metastatic disease? The staging is vastly different in that setting.
Who is going to tell me? What do you think? Is it a synchronous primary or are these metastases? So who's raised the hands? Who's coming forward? Soumya, you can take a bit of a rest. Who else is there? Islam, your hand is up. Yes, please.
So we don't know if these are synchronous tumors, like secondary from one another or not, and or either they are two primaries. So I would start with doing a PET CT scan.
See, you had a CT scan. You have seen this. Okay.
A PET CT.
PET scan.
What do you think you find in your practice when you send ground glass nodules for a PET CT study?
Especially for these small lesions, they come usually as negative.
Absolutely. So unless you have a solid nodule within those ground glass nodules, unless they're mixed with a solid component, it's very highly unlikely your PET CT is actually going to help you very much. And as you can see, there's very low level activity, almost same as a blood pool in the left lower lobe. We can hardly see the right lower lobe lesion. So I don't think we are much further by asking for a PET CT in patients with ground glass nodules. So these nodules, you want to be either tracking them, if you've been tracking them, or you want to try and get a sample from a brave radiologist.
Because they're just behind the scapula and they're very small, actually. I think they're less than 1 centimeter. It will be very difficult to get a radiological guided sample from either of them. But if the PET CT scan show no other tumors in the body or no other secondaries elsewhere, I would take a wedge of the one that's less likely to be the primary.
Islam, hold on. What are your views looking at that? You asked for the PET scan when I asked you a question whether they are synchronous primaries or metastases. So you said I need a PET scan. So how has PET scan helped you with that question? What do you think they are after looking at that PET scan now?
From this PET scan, they both looks have low ability to low SUV uptake. So it hasn't added anything to me actually, but from looking at the rest of the scan, I would have a look and see if there's anything else in the body.
Okay. Dr. McGann, you see these problems quite frequently these days with the multiple lesions, and that discussion we always have whether they are metastatic or they are synchronous. Is there anything you can look at radiologically to help us to distinguish that?
Yes, I think so, Mahinda. I think demonstrating growth is useful. So at this stage, you could consider a 3-month follow-up. One might be demonstrating differential growth to the other, and therefore will be more of a target for definitive treatment. Don't forget that if the SUV is a bit higher on some of these ground glass lesions, that can actually point towards infection, because bizarrely SUV has a reverse relationship in ground glass lesions to the presence of tumor. In some cases, infection has higher SUV. So I think in this sort of a case, demonstrating growth is important.
Bilateral tumors, and in this one they are ground glass, but bilateral solid tumors. Does the mediastinal staging with a PET scan helps to clarify or static, or they are synchronous?
Yes, if there is a mediastinal lymph nodes, this means it's more likely that to be one is secondary from the other. But if there is no mediastinal lymph nodes, then this means that it's more likely that for them to be either synchronous tumors or unrelated tumors.
Okay, right. So with what Dr. McGann just mentioned, keeping that in mind, what is your management for this patient? What are you going to do? You've seen the scan, CT scan, and you saw the PET scan. What is your approach for this patient? Lesions. B. At 3 months. Do people agree that we should repeat a CT scan at 3 months? That is one of the approaches, that you can repeat a CT scan and one of these lesions may either show growth or may resolve, or both of them can resolve. So you can have some idea about how these two lesions are behaving, and you can target one or the other for either diagnostic procedure or more formal surgical resection. Yes.
So yes, to add on to that, we did follow it up for about a year. They have not changed. Okay. The patient works in a hospital. His performance status 0. She got fed up with keep an eye on it.
Surgery, or will recommend we should do something?
Sorry, Melinda, you keep cutting out. I don't know if there's a problem with the audio.
Oh, I'm so sorry.
That's all right. It's just intermittent and we can't hear you.
Okay.
I think we need to speak.
Rob, what we are saying is that what is the approach for this patient in which the lesions are stable over a year now?
So, I mean, if it's pure ground glass, is it Madhava? Or you see, we can't hear you.
Glass, can you hear me?
I can now, yeah. So both pure ground glass.
Yeah.
So from a radiotherapy point of view, we wouldn't do anything. If there's no evidence of any solid component, there's no serial growth, and obviously the PET avidity is very low. So from a radiotherapy point of view, we wouldn't intervene.
Okay. Okay.
To Dr. Dijaram, and who's got a chance only to look at these cuts. The reporting radiologist in the peripheral hospital felt there is a small component of part solid, less than half of a centimeter, less than 5 centimeter, small part solid component. Can everyone hear me? Was a small component when we drilled the radiologist to that question. We decided they were very small, less than half a centimeter, a solid component to it when he's blown it up on his system.
I guess we could offer a CT guided biopsy of that nodule, and that might help take it forwards if any chemo options were there.
So this patient, as we have just gone through the investigations, has got good lung function, good exercise tolerance. This patient works as a nurse in the hospital, and she wants something to be done for her. And there are various options here, but with a patient like that, who will consider surgical approach, and is there anybody who will say, okay, we can keep following this up? The reason we are discussing this case is that we need to know what is the management strategy for the patients with ground glass opacities, the patients with ground glass plus solid component, and the patients who have got a completely solid component in the lesion. So there are very clear guidelines for these patients to be managed. Madhav, will you tell us about the follow-up of the ground glass opacities, please?
So in general, the follow-up regime is a total of 4 years. So you would do the first scan at 3 months to see if it disappears. If it disappears, then we are home and dry. If not, you get a repeat scan at year 1, year 2, and year 4. So that is a normal regime for ground glass nodules.
Right. And if there's a solid component?
You have the option to subject the patient to PET CT and plan a biopsy from there.
Yeah. So it's pretty clear. So if you have a solid component and there is some growth in the size of the lesions, the patient needs to have a definitive treatment, either biopsy or resection, or these patients need to be offered alternative treatment strategy. But if these lesions are not increasing in size, then that's a bit of a dilemma as what to do, and then you need to sit in the MDT, make a decision and discuss it with the patient and proceed with it. Now, I understand this patient decided to proceed with surgery, which was endorsed by the MDT, and now what surgery will be offered to this patient? Ectomy or lobectomy? It on one side, both sides, or sequentially?
Would it be worthwhile putting the CT scan back up to have a look?
Again, and you say the management in Hong Kong will be more aggressive. Is that right?
Yeah. Hi. Yeah, absolutely. It's good to be reminded of attitudes in the UK. I think if this was a patient in China, Japan, or Korea, there would be no question. We'd go straight in. I think partly, as you probably know, sometimes the differential diagnoses in these lesions does vary across different geographies. And if you look at a lot of the results coming from our part of the world, a lot of these lesions, whether you call it a solitary nodule or a GGO or a part solid nodule, if you go through an MDT and there's an element of suspicion, then the malignancy rates in some of these nodules can be as high as 80%, even higher in some series. In this sort of situation, up front, we would offer surgery. We wouldn't insist on it. And this patient is a fairly good candidate. Her comorbidities are quite minimal. Her lung function is adequate. And we can offer uniportal VATS. You go in, you could do a segmentectomy, but if this is a GGO, it's quite small. You can even get away with a wedge resection with a wide margin. And what you do, of course, is you send it off for frozen section. If it's benign, this patient goes home in 24 hours with minimal pain. She's fully functional. If it's malignant, she can tolerate lobectomy. You have the option of doing a lobectomy on the left side. You can do a lymph node clearance at the same time. If the lymph nodes are all negative, then the chances of the opposite side being a malignancy are very low, and that can be observed with expected management. I think that's what we would probably do here in Hong Kong.
Alan, that's absolutely fantastic summary of what should ideally be done. I think that's what our recommendation probably would be in UK as well, but as a step, probably we will, and most of the MDT will take, is to just repeat a scan in 3 months, because this is the only scan, and see what the shadows look like in 3 months. And of course, if they are getting bigger or getting more solid, and we proceed with it. But that's a fantastic idea, as you said, that you approach the bigger lesion first, do a frozen section, is a cancer, and do a lymph node dissection. And if all clear, then you can further follow up the smaller lesion.
Yeah, I think there was a comment that, I mean, it's obviously important to do no harm. So when you do discuss within your own MDTs, I think for all the delegates here, it's important for you as surgeons to understand how much harm you are causing. In your own practices, the harm that comes from a minimally invasive wedge resection can vary from unit to unit. And if you're quite confident on offering minimal harm with a good diagnosis and cure rates in these patients, then yeah, that can be considered.
Great, that's fantastic. Yeah, Madhav.
Hi, Alan. Thanks for that input. Can I ask a question? So you said up to 80% of these lesions have malignancy in them. But
no, not all of them. Not all of them. It's if we go through an MDT and it's decided that you do resect. If you analyze the resected specimens, then ultimately the ones resect, the malignancy rate in the resected specimens is 80 to 90%.
That's right.
So my follow-on question basically is: do you think they were highly malignant potential, or do you think we could have watched them? Because I tend to see loads of ground glass nodules, which we've been watching for years and have not shifted very much. So what if I'm subjecting the patient to surgery when he or she didn't need it?
Exactly. I think that's the point. There are geographical differences, and the numbers I'm quoting are from the Taiwanese studies and from mainland Chinese studies. And in East Asian population, I think we do see different differential with these similar GGO small nodules. I think the case in Europe could be quite different. It's also important to be aware that as we hear about the Brock and the Hayter estimate models, the data for the Brock model actually comes from mostly a Western population. So if we are considering East Asian or even South Asian populations, I don't think we actually have good enough data, I think, for those populations. And so we don't actually use Brock model very much at all in East Asia.
That's very interesting. Thank you. Thank you for that insight.
Okay. So, Professor Middleton, I'm going to come to you now. So this patient obviously has, what you can see on the screen, had a left lower lobe segmentectomy, as Alan suggested, in 2019, and then we followed up the right lower lobe lesion for some time, and then undertook a lobectomy in 2021. You're right. So, Prof, what I'm going to ask you is this, that we do see these cases with multiple lesions who do come to us, we remove them, and then there's a discussion, or there were multiple lesions, 2 on one side, 1 on the other side. Should these patients have some adjuvant treatment? Could you just summarize your views on this?
Yeah, I just want to echo what Alan said, though, because
Prof, you need to have your mic in front of you. I think you. It's.
I just want to echo and agree with what Alan said. So we've actually got quite a lot of Southeast Asian patients here, and they're often quite shocked when we do a watch and wait because that is not what they do in Southeast Asia. As you say, I've got one of my patients that exactly like Alan mentioned. In fact, Alan might have even operated on for all I know, that actually was there. And I know full well that patient would never have got an operation. In fact, from memory, I think they'd been seen here, then sort of was living 6 months here, 6 months there, went to Hong Kong, had it whipped out, came back and sort of said, oh, it's been done now. So it's quite interesting. They are much more aggressive. And don't forget, they are the world leaders in this sort of lesion. You know, it's an exceptionally common problem in Southeast Asia. And, you know, they've gathered an inordinate amount of data and information on the natural history of these and how best to treat them over the years. So they are more aggressive. In terms of adjuvant therapy, you've got to think about what you can achieve with this. So if you've got a straightforward, very slow growing lipidic adenocarcinoma with no target in there, and I'll come back to that in a second, then actually the likelihood that chemotherapy application is going to change in any way, shape or form the natural history of the disease is very unlikely. It's in no way, shape or form curative. Obviously, the one thing that clearly is all exciting at the moment, and I presented a bit of that data today, is whether they've got a target, and in particular an EGFR mutation. And, you know, a proportion of these will, of course, have an EGFR mutation in it. And again, Alan will know that, you know, that is fertile ground for a GOJ type lesion in Southeast Asia. You know, you've got a 50-50 chance in Japan or Taiwan or Hong Kong that an EGFR mutation. And, you know, that data from ADAURA is pretty stunning. And, you know, that does include patients with 1B disease. So even quite small lesions, which are node negative, you know, we can include those. And even in the UK on the expanded access program, we can give it to those. And I think it's very difficult not to do it when you can see hazard ratios of 0.2. Now, the crux is, and I think it's very important, is that whether this is going to translate to an overall survival benefit, because, you know, what you might find is that when they do relapse, they go onto a TKI, that it might just completely dilute out any benefit that you get in the adjuvant setting. And there is very good, again, Southeast Asian data, particularly Chinese data on this, where again, they're leading the field by a mile in these sort of studies, where they've done adjuvant studies with gefitinib, for example, showing extremely good disease-free survivals and PFSs, but then when they've looked at overall survival, it's not been quite as good. And having said that, those hazard ratios for first-generation TKIs are not 0.17 and 0.20, they're more like the 0.5. And so it might be with something really, really effective, there might be a benefit, but you've got to remember that with these drugs, resistance is inevitable. And so if I was a betting man, and I am a betting man, I never win any races, but anyway, I'm a betting man, and you asked me to say what would be the overall survival hazard ratio in 5 years' time, I've got a feeling it might be a bust. But as it stands at the moment with that sort of hazard ratio, which is really, it's not unique, but it's pretty much getting there. You know, when you start to get down into the teens for a hazard ratio, you can't not do that from a patient perspective. So I think that's what one would do. If there's an EGFR mutation in there, then one would give a TKI, I think, for sure. But if it was somebody with, you know, multiple ground glass opacities after one's been taken out with no target in it, we would watch and wait, because again, if there's not a surgical resectability potential there, then, you know, you've got to think about what you can achieve. And chemotherapy on its own is pretty bland. These are always PD-L1 negative tumors largely. And, you know, you do get patients, as everybody in this room knows, that you out at 4 or 5 years, it's looking exactly the same as it did before. You know, so it's about assessing the tempo of the disease. And then if you do get some progression, then jump on it at that point. It's just about assessing risk-benefit equation for treatments that can have toxicities for sure.
Comments, Prof. Shall we move to the next case?
with a history of chondrosarcoma of the right knee, which was resected in 2017. Post-operatively, he had chemotherapy. He was a known case of hypothyroidism and hypertension, an ex-smoker for the last 10 years with a 10-pack-year history, but a good exercise tolerance with a performance status of 0. So his pulmonary function tests were done, which showed an FEV1 of 85%, an FVC of 90%, and transfer factor of 65%. So we did a CT scan for this gentleman.
See a smooth nodule in the right upper lobe. Once we got a slide on the way. Sorry. So there's a bilobulated nodule in the right lower lobe. As you can see. And I think we decided to watch and we repeated a follow-up scan a couple of months later. So we have multi-site or multi-lobe lesions, which with the history and the shape that they are highly likely to be metastases.
You so unmute yourself and come out.
Melinda, I think your audio is completely gone.
Okay, can you hear me now?
Yes, that's better. Thank you.
Right. Okay. So Shilpa.
Yes. Good morning, everyone.
Okay. Great.
Hello.
Right, Shilpa.
Yeah.
So you have seen the scans. So what do you think we are dealing with here?
Looking at the case details and the scan, it appears to be likely metastasis from the previous right knee chondrosarcoma. So there are two nodules, right? One in the right upper lobe and the other in the right lower lobe. We have followed it up. I'm sorry, I've just lost one point. After the follow-up, have the nodules remained the same or have they increased?
Okay, so what do you what do you want to look at in the follow-up scan for these patients? So the first scan, which we showed, you could see 3 lesions, well-rounded, and your assessment is right. This could be metastasis. Why do you want to do a follow-up scan?
Because they are more than one met.
Yeah. So what do you want to look at in the follow-up scan? What is going on in your mind? First of all, you have said it is metastasis. Why he decided to keep that?
No, I just want to actually know first that if the chemotherapy is completed or not, if he has completed his chemotherapy, and when was his primary operated?
Okay. So what is going on in your mind?
So if it is a multiple metastasis and chemotherapy is completed, that means we are dealing with a persistent pulmonary met, which might need to be addressed.
Right. Okay. That these are metastases, patient's chemotherapy and all that. That will come, we'll discuss that in a minute. But the question I was asking you is why you are getting a follow-up? What do you want to see in the follow-up scan?
No, if it is increasing in size.
Yeah.
Yeah.
So you want to look at the numbers?
Yes,
Both.
you have to look at the numbers. It's a follow-up scan at 4th month. Yeah, so it has increased in size, and since it's a sarcoma, we should we should assess the patient for its fitness by means of tripartite that assessment, and if it is and if he's a candidate for surgical pulmonary metastasis.
Which email?
Before that, we
Who's on the email? Sorry? Who's on the email?
Louis, can you please mute yourself? Louis.
I've done it.
Okay. Thanks. Right. Okay. So the reason we have put in this case is basically to discuss metastatectomies. So, Shilpa, is there an evidence to undertake metastatectomies? Do you know anything about why we are contemplating metastatectomy in this patient?
Yes, so metastasectomies should be offered only if the met is resectable, patient is operable, the primary is absolutely controlled.
Okay.
And the number of metastasis is also one of the criteria which will add to our surgical decision making.
Okay. Okay. Stay there. Alan.
Yeah, here.
From Hong Kong about the metastasis. Now, this is a chondrosarcoma, not responsive to chemotherapy. And this is a patient 2 years down the line after primary being removed and 3 lesions.
Yeah. Well, sir, again, it varies from MDT to MDT. In Hong Kong, our oncologists are usually rather pessimistic on non-surgical options for these cases. So we would go in quite aggressively. I think in that first initial CT, there were only 2 lesions. Is that right? One in the right upper, one in the right lower. We would have gone in at that stage. I think we often do repeat surgery if they recur after that. In fact, I'm seeing one case tomorrow with exactly this.
Rob, probably I'll ask you to come in as well. But what the approach we take in UK and majority of center is that we do offer metastatectomies with that caveat that primary is under control. There's a good disease-free interval. The number of lesions are not more than 3 or 4, and depends on the primary histology. What we do here is, and that's why I was Shilpa asking you why we want to repeat the scan, is this, that if on the repeat scan, the number of lesions are going up, then that shows that if you do undertake metastatectomy without any systemic treatment thrown in, there will be metastatic deposits which are not visible, will become visible later on. So you need to have that sort of a frank discussion with the patient about the micrometastasis which are there, and the pace of disease is such being seen on the repeat scan. So number is important. And on that note, Alan, do you, for that very reason that there are deposits which are not visible on the scan, do you undertake open thoracic surgery, or you just still go with VATS and take out what is visible on the CT scan?
Yeah, we would go indefinitely with VATS for all of these cases. And part of the reason is that we half expect that there could be future recurrences as well. So we for each step, I think it's a metasectomy anyway, we would do the minimal harm to the patient, and doing VATS and doing wedge resections will give us the scope for future resections. Within our own MDT in Hong Kong, it would be surgery only. Our oncologists don't offer any systemic therapy before or after surgery for these cases.
Asking, will you do a PET scan?
Yeah, I think we would consult with the original orthopedic surgeons. whichever scan or whichever method they use to exclude primary recurrence at a primary site, if that's excluded, we'll accept that. And with just a couple of lung mets, we'd go in and do the surgery.
Peripherally, which is pretty much amenable to VATS resection. And there is another lesion which is quite central, which will not be possibly palpable with the VATS. For example, this was little 1 centimeter more centrally. And could we say, okay, we will take the 2 peripherally based lesions and can you give SABR to this one? Lesion situated centrally, and we say we can refer this patient to you for SABR. What is your take on that?
I mean, these cancers, I mean, sarcoma, they're quite chemo, well, not particularly sensitive to chemo. Regards to radiotherapy, again, they're not, for conventional radiotherapy, they're not particularly sensitive either. And I think on the first scan, you've got 2 metastases. And as long as there's been a disease-free interval of 6 months or more and the primary controlled, at that point, we would have offered SABR if they weren't surgical. Now, the second scan, I think, is 4 months following the last one, isn't it? And so actually, the worry here is they have got quite extensive micro-mets, and they're just going to pop up another metastasis quite quickly. And therefore, you've got to think about actually what is the benefit from metastectomy at this point. Now, there's another lesion that's appeared quite soon. If we were looking at this second scan and there were 3 metastases, we could SABR them all because they're all outside the no-fly zone because there's 3 or less metastases. We have obviously used a kind of a surge if there is a very central lesion. We have used an approach where you guys would take out that more central lesion and would SABR the more peripheral lesion, either in the same kind of time period or waiting for the post-operative recovery.
Alan, to you is that often the students get asked this question, the evidence. What is the evidence for metastatectomies? And we have certain clinicians, even in the MDTs, who will question that. So where do we stand with that evidence, Alan?
The level of evidence, as we all know, is very low. I think what we're talking about are just limited case series. There have been no really randomized trials. I think what has been identified in the case series is that the risk factors we normally consider are the number. In this case, it's very few. The ability of the surgeon to assure that you can get a complete resection, and also to some extent the disease-free interval. I think if the patient actually meets all these criteria, then at least there's low-level evidence to support that. And the alternative, as Robert says, I think for these chondrosarcomas, non-surgical therapy has been shown to be very limited in efficacy, and that's one consideration.
Yeah, I think with regards to metastaectomy, you've got to think about the primary, haven't we? There's decent evidence for metastaectomy in colorectal cancers. It's quite mature data for SABR. I mean, in the UK, we had something called the Commission's Reevaluation trial. Well, it wasn't really a trial, but it was looking at patients whose primary was controlled for more than 6 months, 3 or less areas of metastases. And there has been shown to be benefits from giving stereotactic radiotherapy to brain metastases, bone metastases, lymph node metastases, and lung metastases. The data is not particularly mature, but we've had, it's been collected prospectively, been continually evaluated, but it has formed standard of care for a lot of patients with oligometastatic disease. That's for SABR. But surgical metastectomy has been proven, hasn't it, Prof, for particularly colorectal cancer?
Well, Thymic eventually got across the line.
Lift your mic up.
Yeah, I mean, Thymic eventually got across the line. But, you're never going to get a trial with this. It's rare. I mean, I think 2 years out, standard of care for operable disease would be an operation. You know, they don't respond systemically. I mean, they've got a few targets, but it's like any of these things, you know, whether they're going to be actionable or not is a question mark. They get, some of these have IDH2 mutations, and at ESMO last weekend, there's actually some really quite good data in cholangiocarcinoma using IDH inhibitors. So again, trials of IDH inhibitors for those with IDH mutations, I think would be very reasonable here. And some of these patients also have amplification of a particular chromosome that includes CDK4 and MDM2 on it. And there's actually a lot of interest in MDM2 inhibitors at the moment, which, as you all know, inhibit P53. And chondrosarcomas are pretty genomically straightforward. You know, they've got a bit of copy number change, but, you know, it might be that some of these things actually are reasonable drivers. And I think resecting is personally a no-brainer here. And if, you know, you get a relapse with multiple deposits, well, the patient probably knows that's going to happen. At least you gave them the best crack of the whip. And at that point, you know, referral for a targeted therapy trial after, you know, sequencing. And all these patients in the UK now getting whole genome sequencing, so you get a shed load of information about them, seems to me quite a sort of reasonable way forward.
So truly, MDT discussion is what is required in this in these patients, and pertinent discussions can be taken place. Okay, next one. Loading the one, Dr. McGann has made a very pertinent point about Herder score and Brock score, that they don't take in consideration the growth or lack of it as a criteria, and I think that's important. Probably that should be looked into in future. Can we have a next page?
So. With a few months history of chest infection, which did not resolve with antibiotics, he has comorbidities of hypertension and diet control, diabetes mellitus, current smoker for 20 to 30 years, and exercise risk tolerance is good with performance status of 0. FEV1 of 75% predicted, FVC of 100%, KCO 95%, transfer factor of 99%. And the residual volume of 126%. CT scan is done, which is shown here.
We've got a coronal reformat here to make it easier and quicker. So you can see a soft tissue mass in the right upper lobe, which is adjoining the mediastinal pleura. It's reaching all the way to the periphery, the subpleural region, which always makes you wonder as to what kind of tumor we're dealing with. It's at least a T3 or T4 tumor we're looking at based on the appearances there. So if you go to the next slide, please. So you can again see there is a little bit of fat plane between the SVC and the tumor itself. Resectability and mediastinal invasion are difficult to be 100% on CT scans. This is something which we try and help our surgical colleagues with.
Ghazi, are you around? Can you unmute yourself? I will make you unmute. Where are you? Yeah, there are you. Yeah, okay. Can you hear me?
Yeah.
Look at the CT scan and what is going on in your mind apart from what Madhav Tijaraman has said. So there's a lesion which could be T3, possible mediastinal invasion. What else do you see on that scan?
So what I'm looking at is looks like a superior surface. What looks like a superior surface tumor in close proximity to the great vessel. So I'm thinking on those lines. So here I'm thinking about resectability, and then I'm gonna assess the patient for operability.
What do you want to? What do you want? What do you want to? What do you want to do next?
I want to do a PET scan. So an avid lesion. Can't see any other no mediastinal lymph nodes. So again,
Look at the green stuff in front of the carina.
Okay. So it look like station 7 node is also a bit. So it's an so it's a T4 and 2. So it doesn't look like a candidate for. So I want to take a biopsy from. Want to do an EBUS and take a biopsy from that node, and I'll take a CT guided biopsy as well from the. Okay, so from the tumor cell. So pre-clan, okay, negative.
Ghazi, hold on. So if you have a choice to biopsy this lesion, what will you do first, EBUS or a CT guided biopsy?
EBUS, because you go for the higher staging lymph node. Because if it is
EBUS was done, and that's what EBUS results are.
Okay, so I'll proceed now to do a CT guided biopsy of the tumor cell.
Biopsy tells us it is squamous cell carcinoma.
Okay, so so in terms of so there is a role for radiotherapy in shrinking those tumors before I resect them.
Hold on, that's good idea. But are you worried about that mediastinal lymph node?
EBUS can give you a false negative result. I'll consider cervical meat to make sure there is no the lymph node in the midtime negative basically.
We agree on this that if EBUS is negative, we should do mediastinoscopy.
Just on the view that if you're going to do that radical resection, I just wanted to make sure it's not a very advanced disease.
Will you undertake cervical mediastinoscopy if EBUS is negative in this patient?
Yes.
Yeah. 1.8 centimeter size precrinal and 4R lymph node. If the EBUS is negative and with that size tumor, it may not be a bad idea to undertake cervical mediastinoscopy to take more tissue and be very confirmatory about it. But can we go to the next slide, please? Well, treatment before operating on this patient and why?
Sorry, the voice is cutting. Hello?
Will if you have done EBUS and it is negative, right, and you have done cervical mediastinoscopy and it is negative, right, will you give neoadjuvant treatment to this patient before operating on him? That's what you suggested. So why will you give that?
So I could hear that you asked me whether I should give chemoradiotherapy as a neoadjuvant for operate. Yeah, and I would say yes because it might shrink the tumor and downstage the tumor basically.
please. What is the role of adjuvant treatment for these patients?
So I didn't catch all that, Melinda, you went off, but I think you're asking what's the role of neoadjuvant concurrent chemotherapy, is that right?
That's right.
Yeah, so it's got multi-stage N2 disease, it's not resectable. So, I mean, obviously you've got to determine right being either resectable, potentially resectable, or not ever going to be resectable. So you're resectable for multi-stage N2 disease, you could enter them into a trial looking at neoadjuvant immunotherapy, which is open. I say NICE have said that we should be using neoadjuvant concurrent chemotherapy. That's a lower dose than 60 and 30. It's actually 45 and 25 to see if you can downstage. Or the other alternative would be that if they're PD-L1 positive, highly PD-L1 positive, you certainly be erring towards concurrent chemoradiotherapy as definitive treatment, followed by durvalumab. So this approach, obviously, you've gone concurrent chemo rads definitively. I'm assuming because it was multi-stage N2 disease.
Written this down because that is the now standard which we are aspiring for these patients who have got mediastinal lymph node enlargement and the size of the tumor or the invasion where you are worried that the patient resectability may be compromised. Taking on for surgery directly. Rob, before I let you go on this one, could you just highlight that in neoadjuvant setting, the radiation dose is different than if you are treating it with a radical intent straight away?
Yes, it is. It's a lower dose. In the original trials, it was 45 gray. I think it was 45 and 25. So it is a lower dose. So certainly to reduce the toxicity and the changes you see in the mediastinum when you go in for surgery. If it's still inoperable after neoadjuvant chemotherapy, chemorads, then you can then top up the dose rather than surgery to make it a radical dose. It's technically difficult, but it's achievable. So that's a nice recommendation to do that. But in the multi-stage N2, we would err towards the concurrent chemorads definitively.
Okay. For that matter, we did give concurrent chemorad to this patient and had a follow-up scan. Have you got the next scan? Can you just show that?
It's shrunk down. The mediastinal nodes are looking much smaller, and you can see a nice fat plane around that lymph node, which was merging before with the various structures.
The tumor is much more manageable in this case. So, on for surgery, is there anything else you would like to do?
So I'll do a tripartite assessment for this patient, including dyspnea, post-op, cardiovascular risk, and mortality risk.
I think that is important, Ghazi, as well, that if you are going the neoadjuvant route, you would have done that assessment. So the assessment now will be just to make sure that the chemorad did not have any deleterious effect on the patient and makes him inoperable because of that reason. Otherwise, that assessment should have been done beforehand, that he will actually go through neoadjuvant treatment and for surgery. Yeah?
I see.
Anything else you will do?
I will discuss this patient in high risk NDT. So you can.
From the investigation radiology point of view, you would like to do?
MRI.
What?
Yeah.
Shilpa?
Since it's a pan coast, I think we should complete the imaging tool by doing MRI.
Time.
We have already.
Mother, what will you suggest?
Already restaged it.
Is MRI or any brain scan
Right, so I think it's more the MR brain to ensure that there's no extra disease, which is extra thoracic. We need to establish the FDG PET sometimes does not show you everything that you need to see. So you need the MR brain. In terms of Pancoast tumors, obviously, this one I don't think is truly a Pancoast tumor. So I don't think you need MR of the thorax, but certainly for this one, you do MR brain, make sure that is clear and proceed.
Okay. Right.
But would you say the MRI would have a certain role in the posterior compartment,
so you
rather than the anterior, which is the vascular one?
If you have tumors more posteriorly, which are going to sit on the nerve roots and the vascular structures, then an MR will give you more detail and tissue delineation.
Can we go to case MB, last one? So, okay, we got a time for one more case. Alan, before we discuss, is there anything different you will do in Hong Kong for the patient we just discussed?
No,
earlier?
absolutely same. Totally agree.
You wouldn't have gone for a primary resection, Alan?
No. Definitely pre-op concurrent chemoradiography.
Okay, so this is an interesting case. Carry on, Akshay.
So this is a 65-year-old gentleman, not particularly comorbid, P in 2014 and hypertensive, and had hemoptysis in 2014. So underwent a CT scan, which showed this, 2 axials views, showing the most personal finding.
Yeah.
And you guys can see that nodule at the right lower lobe posterior basal segment.
Okay, next one.
He then subsequently underwent a PET scan below, and then these are views of the upper thorax and neck and the mediastinum on PET.
Right, okay. Florentina, are you there?
Hello, yes, I am. Hello, can you hear me?
Very good, okay. So, you saw the lesion and you've seen the PET scan in front of you. So what's going on?
So, there is a lesion in the right lower lobe and metastasis maybe in the neck.
Let's look at this one. No, next one. Okay, so that's the, there is a disease in the neck, okay? There are lymph nodes in the neck, there are lymph nodes in the mediastinum, okay? So that's what it is. For the paucity of time, we're going to rush. So what are you going to do? What is the next investigation? Forget about operability. He's operable, so we're not discussing that. I'm talking about resectability and further management. What will you do?
Cervical mediastinoscopy.
Why you want to do cervical mediastinoscopy?
To get a biopsy.
The lymph node in the neck.
What about CT guided biopsy for the right lower?
What do we biopsy first? The highest
nodes.
The neck.
I can't hear, sorry. I can't hear.
Okay, can you hear me now?
Yeah, I can now.
Okay. So what will you biopsy first? Previous slide, please.
Well, whatever it's easier to get to, isn't it? So
well, one is easier, and number two is we go for the higher stage. Okay.
Yeah.
So you do a cervical mediastinoscopy, and then you find that 4R is positive. What about the one which you are seeing in the neck? You want to know that first, isn't it?
Yeah.
So is everybody with me that we need to biopsy the easiest one and the highest stage one, which in this one is the neck lymph node, okay? Right, Florentina, the neck lymph node is positive.
Mm-hmm.
And it's squamous cell carcinoma. What is the stage, TNM?
Is it T4?
T4?
Let's say it's about 2.5 centimeters.
Okay, so
T1C, yeah?
Okay.
T1C. And the N staging will be, it's extra thoracic. So
Yeah.
you're thinking N3.
Okay, right. Islam or Shilpa, whoever.
Yes, yeah.
What are you going to do now? So this is a patient who has got T2 and 3 disease. What is the management?
This patient would be stage 3B. So he would be for definitive chemoradiotherapy.
Good. Okay. Next slide. Okay, so yeah, I think.
So this gentleman, randomization to chemotherapy as part of the Keynote 024 trial in 2015, and then maintained on chemotherapy alone. He was then subsequently scanned. Same right lower lobe lesion, axial view on the left, and then higher up. They had a very good response, downstage nicely. And then the left panel here, the coronal view, shows the scan 18 months post-maintenance, and then on the right, 2 years post-maintenance of that same initial place where the right lower lobe lesion was. Years post, axial view.
Very important point. Somebody had suggested that you can give concurrent chemo rad, and Robert said you cannot give chemo rad for such an extensive disease. From Rob, can you just clarify that?
Yeah, I mean, we do give concurrent chemo rads in some circumstances. Say you've got a high mediastinal node, but the primary is nearby, so they're close by. But when you've got a primary in the right lower lobe, and then you've got extensive mediastinal neck nodes, the volume is too big. You'll be over your constraints for the mediastinum structures like the esophagus, probably the spinal cord, heart. So it's something we can't do with such extensive disease.
No. So yeah, that's the important bit, guys, for you to learn. Okay, next. PET scan done 3 years down the line, 3 or 4 years down the line, and this shows that there's an activity in relation to the previous slide, please. In relation to the lesion which was treated in the lung, and next is the mediastinum, which is clean. Okay, so this is 4 years down the line. Anybody, Islam?
Yes. Sorry, sir, I couldn't hear the question.
He had a chemotherapy, remained well. The PET scan done recently has shown increased activity in the lesion which was treated in the lung, but the mediastinum is clean.
Okay, I need to restage him again.
You restage him. How do you restage him?
So the tumor size is still 2.5 centimeters, so he will be still T1C, Y T1C, and the N, if it's clear, it will be clinically N0, but we need to confirm it with an EBUS, plus or minus mediastinoscopy if it's negative. And for the M stage, we need to do a full PET scan of the body and a brain MRI as well.
Good. And then if everything is negative, will you offer him surgery?
Yes. Hello?
You've gone again, Melinda, I think.
Oh gosh, Alan.
Oh, there you are. You're back now.
Alan, can you hear me now?
Yeah, I hear you. Yeah.
Do you agree with that approach?
A little bit hesitant because
that's why. So let's have a
stage
debate.
3B. Yeah, it's 3B to begin with, and the evidence for surgery for 3B is still pretty much non-existent. And nowadays, I think with 3B, I think we have so many good alternatives to Valuemab, et cetera, et cetera.
I think that disease-free interval of nearly about 4 or 5 years will sway your decision, because it's a disease is pretty much localized now to the lower lobe, with the mediastinum being clear on EBUS.
Yeah, I mean, certainly from a technical point of view, it's certainly operable. I would defer to the entire MDT decision on this one. It's so off-label.
Yeah, I agree. But I think we've had quite a few cases like this in the past few years, where I've had a patient who was metastatic at diagnosis. He had brain mets, and he had a similar good response, and ended up having a small, I think it was about a 2 centimeter nodule in the left lower lobe. It was node positive, so it was PET positive, biopsy proven. He went through MDT, decided not for surgery, but he had SABRE, and we are now another 3 years on and know it's a recurrence, and other cases where they've had surgical resection. So although we've not got any long-term, randomized controlled data for these kind of cases, some people do extremely well. And I think if they have got solitary areas of disease which are resectable or amenable to SABRE, and they've had such a good response to, systemic therapy and a good disease-free interval, I think almost it's a disservice in a way not offering it to the patient, because we do know some patients do extremely well in these situations.
True.
With the fantastic targeted and immunotherapies coming on board, I think we'll be seeing these patients more often now. And I think probably we need to have that again, multi-physician approach to just make a decision which could be life-changing for the patients. Well, actually, thank you very much. I wish I can carry on. We have got a few more cases, but I think we have run out of time. It is very, very important you guys get off your chairs. But before you do that, please fill in the feedback form, email after you finish the course, and we will send you the certificate. But it is very important for us for the next year, when we are going to be face-to-face, to see how we can make it better. And thanks a lot to the panel. It was absolutely fantastic discussion. And as I said, this is the only CPD I do in the whole year. And thanks to you, everyone. Thanks.
Thank you.
Back at
11 o'clock.
11 o'clock sharp, okay? Thank you very much.
Okay, shall we play those videos?
Yeah.
We can move.
Hi, Hazem. Can you hear me at all?
You hear me?
I can do, yes, but it missed off a couple of words at the start of that. Can you just, when I stop talking, can you just say hello and introduce yourself for a second?
Hello, I'm Hazem. A second.
Yeah, so
Yeah,
it's
is that all
working.
right? Works okay?
Yeah, I'm just hoping that it's going to be a little bit better at the end.
Sorry, I counted to 25 and then I forgot to unmute, so it's working fine, I think.
Awesome. Okay.
All
Right, I'll
right.
mute this one back off. I'll come back to you. Thanks.
Brilliant. I can mute it from here as well. That's really good.
Hello, this is Paul van Schil. Can you hear me?
Hi, Professor. Yes, thanks for joining. We will be going live shortly.
Yeah, okay, thank you.
Clive, can you hear us?
I can do, yes. I have myself muted there as well.
Yeah, I think we need to take off the running video now and go back on camera.
Okay, I'll come back through. Give me a second.
Do you want me to? Yeah, good. And we will be... Professor Van Schil, thanks very much for joining us. We have slight alteration in that your talk will be streamed on CTSNet. Do you have any issues with that?
No, I don't. Thank you. No problem.
Okay. All right.
But it's still at now at 11 o'clock for you?
It is 10 for 11 o'clock for us. Yes.
Yes. Okay.
So we'll be starting shortly.
Shortly. Okay. Thank you.
Hassan, do you want our camera back on there?
Yes, I think we go back on camera shortly. Right. So I think, yeah, it's gone 11 o'clock and welcome again, everyone. Hope you had a restful short break, and we have an exciting session coming up. We'll be talking about the thoracic malignancy and joined by really truly eminent faculty here. And we're starting with Professor Paul van Schil. Very little, so much can be said about Professor van Schil in the short period of time. To give him justice, he's a professor at the University of Antwerp and leading thoracic and vascular surgery. He is an ex-president at EACTS, and he's the president-elect of the IASLC. He's a keen educator and a great friend to the Birmingham Review course, and also an avid musician. We can't wait to have you, Professor Van Schil, to talk to us about the GGO workup and treatment.
Okay, thank you very much for this kind introduction, and it's my pleasure to participate again in the Birmingham Review course, and I hope next year it will be a live event again. I will share my screen and go to the slides. I go to slideshow. Okay. Okay, can you see my slides?
We are not able to see them at the moment, I don't think.
Clive, is there anything? I don't think it started sharing.
For me, it looks fine.
Does it?
No. I'll try again.
Yeah, let's try that. Clive, if you can hear us.
I don't know whether I'm allowed to share my screen.
Are you having a problem? Yes, it's allowed. Can you see them? No. So if you go to security, make sure it didn't trip itself or anything. Actually,
It's all active.
and this is a different.
Yeah, when I click on share screen, I think nothing happens.
Right.
It's
Okay.
green. I think I'm not allowed to share screen. Is that possible?
Just to go to security. Yeah, just give us. Sorry about that. No. Just I think go to security to the far pane. The onto the left hand side. That one. Enable. It's not. It's someone else is sharing still or something that is not allowing. Are we sharing our screen? Is that why? It worked yesterday or quite okay, didn't it?
Yeah, I get an error code. It's 105.135, but I don't know what that means.
I think Professor Van Schel's presentation is on the.
Yes, I sent in my presentation 2 days ago. So
if we have any issues, we
it's
can.
It's within thoracic.
We can go
My
on
name. Yeah. The name of the presentation is BRC 21 GGO Van Schil.
Yeah.
Can you just try and share again, please? I've just made you a co-host temporarily.
Yeah.
See if that lets you.
Professor, could you try one more attempt at sharing your screen?
Yes.
Well, that's just some.
If you want me to share. Just open.
If we give it another.
Yeah. No, I
What
still
is the
get the
error
same
code?
message. Yeah, screen sharing has failed to start. Please try again later. Yeah.
And the error code was
105.135. Sorry, 105.035.
okay. Why don't we just play this from?
Yeah.
Let's try to share. Hopefully, it's not shared across the whole.
Just opening.
Please have it.
Is this the right presentation?
Yeah,
Rob?
that's the right presentation. That's it.
I'll
Okay.
run it for you. If you just tell me when to change slides, I'll
Yeah,
do.
okay, that's fine. So it's false start, but we go on. So I'm Paul Van Schil from Antwerp University Hospital, and my disclosures are listed over here. Next slide. So in fact, what is really a GGO, ground glass opacity or ground glass nodule, is defined as a focal nodular area of increased lung attenuation, usually seen on chest CT, through which normal parenchymal structures, this is the airways and the vessels, can be visualized, as you can see below. And on pathology, this represents a predominant lipidic or butterfly component. Next one, as you can see on the chest CT. Next one. Usually this corresponds to adenocarcinoma in situ on pathology. There's no consolidation. Next one. and no solid part. So in fact, there's no invasive part. Next one. Next one. So when we look at the evolution, it is possible that we start with a pure ground glass opacity. So in fact, what is called a 100% GGO lesion, then go to a mixed lesion, a part solid lesion, where there's a solid part within the GGO or around the GGO, and then evolution to a solid lesion. This means that there is an increased malignant potential with an increase of molecular abnormalities that is seen. So for a surgeon, it's important to have a complete excision of such lesions for the pathologist to exactly determine what is GGO part in situ or an invasive part, which corresponds to the solid part of the lesion. Next one. So mixed lesions and pure ground glass opacity are together called subsolid lesions, meaning there is part of the lesion that is solid and part of the lesion is GGO. And when you have a 100% GGO lesion, as on the left side, this is a pure ground glass opacity. Next one. So looking at pathology, this is the adenocarcinoma classification introduced in 2011 by a common working group of the ISLC, ATS and ERS, and adopted in the 2015 WHO classification and recently confirmed at the 2021 classification. So distinction is made between pre-invasive lesions, minimal invasive adenocarcinoma, and invasive adenocarcinoma. Pre-invasive lesions are atypical adenomatous hyperplasia, or AAH, adenocarcinoma in situ, AIS, with a maximum diameter of 3 centimeters. Most of these lesions are non-mucinous lesions. Then we have the minimally invasive adenocarcinomas, or MIAs. Most of those are also non-mucinous, with a maximum diameter of 3 centimeters and a lipidic predominant tumor with a maximum of 5 millimeters invasion, so no more than 5 millimeters. And then we have the invasive adenocarcinomas. And when we talk about subsolid lesions, usually it's a lipidically predominant variant. So as mentioned, an extensive sampling is needed to exclude invasion, particularly in larger tumors. Next one. So looking at the 8th edition of the TNM classification, regarding this T size, we only look at or only consider the invasive part. And as we'll see, in contrast to other criteria, the maximum unidimensional measurement is utilized, and on CT scan, lung window settings are used. So looking at the different subclassifications, so this is first the invasive part. When there's no invasive part with the maximum tumor size of 5 millimeters, on pathology, this is usually an atypical adenomatous hyperplasia. When we have no invasive part with the maximum tumor size of 3 centimeters, this usually corresponds to AIS, adenocarcinoma in situ, and is for the T factor, this is a PTIS. When the invasive part is maximum 5 millimeters with a total tumor size until 3 centimeters, this represents a minimal invasive adenocarcinoma, and for the T classification, this is a PT1A MI. Next one. When we have a larger invasive parts until 1 centimeters, again with a tumor size maximum 3 centimeters, this represents an invasive adenocarcinoma lipidic predominant and is a PT1A. With an invasive part until 2 centimeters, there's usually an invasive adenocarcinoma or a lipidic predominant tumor. So larger than 1 centimeters but smaller than 2 is a PT1B. When we have lesions with invasive part until 3 centimeters, maximum tumor size until 3 centimeters, this is PT1C, so invasive adenocarcinoma, and some parts with a lipidic component. Next one. So how should we now manage? So we have the diagnosis, we have seen what is the classification. How should we manage those pulmonary nodules? And that's, of course, a hotly debated topic at the present time. I think we have to make a distinction between screening and incidentally found pulmonary nodules on chest CT. Regarding screening, this has to be defined which criteria you use in each screening program. For example, NLST used a diameter of from 4 millimeters on but had positive ratio of 24% with a positive predictive value of only 3.8%. The Nelson trial used volumetry, and positivity was present in 2.1% only, with a positive predictive value which was much higher, 43.5%. And recently, as you know, we have computer-aided detection and also artificial intelligence to help the analysis of pulmonary nodules. When there's an incidental finding of such a nodule on chest CT, we usually use the updated Fleischner criteria, where a distinction is made between solid and subsolid nodules. The dimensions are the average of the long and the short axis, which is in contrast to the TNM classification. So not used in patients less than 35 years with a history of cancer, could be lung metastasis, and immunocompromised patients. The follow-up is based on an estimated cancer risk of at least 1%. High-risk patients are those of higher age, heavy smokers, a large nodule size, irregular or speculated margins, and upper lobe location. Next one. So these are the Fleischner criteria. Of course, it's too large to discuss extensively, but I give you some examples related to GGO. Next one. So when we have a subsolid single nodule ground glass, until a diameter of 6 millimeters, no routine follow-up is necessary. From 6 millimeters on represents more than 100 cubic millimeters. A CT scan at 6 to 12 months is recommended to confirm persistence. And then a CT is performed every 2 years until 5 years. Next one. When we have a subsolid single nodule that is part solid, until 6 millimeters, no routine follow-up is necessary. From 6 millimeters on, the CT is now recommended at an interval of 3 to 6 months to confirm persistence. If unchanged and the solid component remains smaller than 6 millimeters, an annual CT should be performed for 5 years. Next one. So what is important, especially for surgeons, how can we predict the prognosis of such lesions preoperatively? We can look at CT characteristics, and nowadays, usually the CTR is used, is a consolidation over the total tumor ratio. The Japanese also use the tumor shadow disappearance rate, comparing lung windows with mediastinal windows. And what is less on the mediastinal window is usually the solid part, so represents the invasive part, what is seen on the mediastinal window. You can also calculate the numbers of Hounsfield units and perform a histogram analysis. PET uptake is usually not always very reliable, as we're usually talking about smaller lesions. And for the future, probably liquid biopsies and circulating tumor cells can be detected to have a more precise diagnosis. Next one. What is the natural history of pulmonary subsolid nodules? And this is a prospective multi-center study from Japan, looking at almost 800 patients with 2,229 subsolid nodules. Pure ground glass nodules were 1,046, heterogeneous ground glass nodules 881, meaning that they define it as a solid component was only visible in the lung window, but not on the mediastinal window. And then the part solid nodules were 102. The mean prospective follow-up was 4.3 years. From the pure ground glass nodules, 1.2% developed in heterogeneous ground glass nodules and 5.4% in part solid. From the heterogeneous ground glass nodules, 19.8% became part solid during the follow-up. Next one. So almost 1,000 pure ground glass nodules. Of those, 35 were resected. 5 were atypical adenomous hyperplasia, 21 AIS, 9 MIA, and 0 adenocarcinomas. Of the heterogeneous ones, 7 were resected, 2 were AIS, and 5 MIA. 174 part solid nodules, 49 were resected, 1 was AAH, 10 were AIS, 26 MIA, And in this group, there were 12 adenocarcinomas. For the pure ground glass nodules, the mean period that they became part solid was 3.8 years, so rather long interval. In contrast, for the heterogeneous ones, the mean period to become part solid was 2.1 years. Invasive adenocarcinomas, as shown above, were only seen in the part solid nodules, but this represents in this prospective study only 1% of all subsolid nodules. Next one. And then there's a huge discussion going on regarding sublobar resection for stage 1 non-small cell lung cancer, and especially the ground glass nodules or the part solid nodules. This is a meta-analysis of sublobar resection versus lobectomy, published in Seminars of Thoracic and Cardiovascular Surgery in 2020. So they looked at the oncological outcome of lobectomy versus segmentectomy versus wedge resection. They included T1A non-small cell lung cancer. So this is in fact from the previous TNM classification, which is a pity, until 2 centimeters. They retrieved more than 11,000 studies and 28 papers were included. Regarding the PT1A tumors until 2 centimeters, there was no difference in 5-year survival rate comparing 15,000 lobectomies versus 2,200 parenchymal sparing resections. Next one. So they found an equivalent 5-year overall survival, which was a bit surprising, with a relative risk of 1.08. The 5-year overall survival and disease-free survival after segmentectomy was the same as for lobectomy. In most comparisons, wedge resections yielded the same results as segmentectomy and lobectomy. So they concluded that for T1 non-small cell lung carcinomas, parenchymal sparing surgery may yield the same results as lobectomy, although there was a concern about nodal upstaging when you have performed a sublobar resection. They said we have to wait for 2 more trials, the GCOC 0802 and the CLBG trial 140503. Next one. I can show you the result, but probably other speakers will also address this. Of the recently presented GCOC 0802 study at the AATS conference, also discussed at the World Lung Conference last week. So they included patients with ground glass opacities and CT ratio, consolidation over total tumor diameter of at least 0.5. So only very small parts of GGOs. For example, this is a CT ratio of 1 point, meaning that it's a completely solid nodule. So the patients were randomized during the operation to lobectomy, more than 550 patients, and arm B segmentectomies. And the results of this study are a bit surprising. Primary endpoint was overall survival. Next one. So first of all, in 2019, the safety results were published. And in fact, there was no big difference in complications between lobectomies and segmentectomies, although air leaks were more demonstrated, 6.5% in the segmentectomy group compared to 3.8% of the lobectomy group. And this resulted in reinsertion of chest drains. In lobectomy group was only 1.4%, segmentectomy group, as shown below, 3.8%. Next one. And these are the results which have not been published yet as a full paper. So the overall survival for segmentectomies was better, significantly better than for lobectomies. Initially not, but at the end tails you can see that segmentectomy has a better survival than lobectomies. Next one. Regarding the subgroup analysis, almost all the subgroups had a better overall survival. This is overall survival. And in the segmentectomy part. So segmentectomy performed better in almost all the subgroups. Next one. Regarding the relapse-free survival, there was no difference, however, between lobectomy and segmentectomy. And looking at the breakdown, the recurrence patterns on the right side, you can see that for the lobectomy group, the total recurrences were 7.9%. And for the segmentectomy group, 12.1%. So looking at the proportion of local recurrences, this was significantly less for lobectomy compared to segmentectomies, 10.5% versus 5.4%. So more recurrences after segmentectomy, although they had a better overall survival. Next one. Looking at the causes of death, regarding the lung cancer deaths, in fact, there was no difference between lobectomy and segmentectomy. But looking at other cancers, including second lung cancers, this was much higher, 5.6% in the lobectomy arm versus 2.2% only in the segmentectomy arms. So this needs further analysis and more detailed analysis of these causes of death, because the reasons for this are not very clear. Next one. So in conclusion, that's from the authors themselves, from Professor Asamura, the GCOC 0802 is the first phase 3 trial to demonstrate the benefit of segmentectomy with significant differences in overall survival. And they concluded that segmentectomy should be the standard surgical procedure instead of lobectomy for patients with small-sized peripheral clinical stage 1A non-small cell lung cancer with a maximum diameter of 2 centimeters and a consolidation to tumor ratio more than 0.5. But of course, you can discuss about it due to the fact that there were more local recurrences in the segmentectomy group. And the question, of course, how were those treated? This is a nice summary, I think, presented by Dr. Sashi at World Lung Conference last week. So for looking at the consolidation to tumor ratio and the maximum tumor diameter, when its CTR is a maximum of 0.25 with a maximum tumor diameter of 2 centimeters, wedge resection is probably enough. Is the CTR larger for tumors until 3 centimeters, you should perform a segmentectomy. For consolidation to tumor ratio greater than 0.5, looking at the GCOC 0802, segmentectomy can be advised, but this still remains a discussion point. And for tumor larger than 3 centimeters, of a higher consolidation to tumor ratio from 2 centimeters on, the standard resection remains lobectomy. Next one. I just want to show that to make it even more complicated, this is a recent paper from Dr. Fu looking at CT density for pure ground glass nodules. And this was not associated with pathological tumor invasion. So this is a retrospective study of operated patients. They enrolled more than 400 patients. And rather surprisingly, 23.4% were invasive adenocarcinomas, for which most of the time lobectomies were done. There were no postoperative recurrences. And they concluded that CT size, but not density, was the only independent factor for tumor invasion. But in fact, is a retrospective study, and only operated patients are considered. But results are quite surprising. Next one. Next one. So lastly, I can recommend this paper from Dr. Si, who is also on this faculty. He asked the question, should sublobar resection be offered for screening detected lung nodules? So as we have seen, we detect more GGO lesions. Fleischner Society usually advocates a conservative approach with serial imaging, but is CT surveillance really reliable? Also looking at the last study I present from Dr. Fu. So we now have the option for early surgical therapy, and sublobar resection by minimal invasive approach has been found and rather easy to perform procedure with good long-term results. So Dr. Siu concluded that the risk of inaction may be larger than the potential harm of surgical intervention, and that a more proactive approach should be considered with a lowered result for resection. And lastly, next one, my conclusions. So we make a distinction between pure 100% GGO lesions, part solid lesions with a percentage of GGO, and completely solid lesions. We have a new adenocarcinoma classification. Next one. So the term BAC, bronchoalveolar cell carcinoma, is not used anymore. Regarding the TNM classification, we look at the invasive size. Due to the screening programs, we detect more GGO lesions, but there seems to be a difference between Asia and Europe and North America. Regarding CT imaging, usually the CT ratio is now used, but we can also look at TDR tumor shadow disappearance rate, and histogram analysis. So anyway, when there's an increasing size of a GGO during follow-up, of the solid component becomes more predominant, then resection is advised with frozen section analysis. And then we have the choices between wide wedge excision, segmentectomy, and lobectomy. And I will stop over here. Thank you for your attention.
Thank you, Professor Van Schell, for this well-awaited talk, and it was, as ever, concise and very informative. If you have any questions for Professor Van Schell due to the time, please feel free to text to ask him in the chat function on Zoom, or send the questions to us and we will forward it to him. And I think a complimentary on the same topic talk from Mr. David Waller, who is been a part of this review course since its beginning, and he's a consultant thoracic surgeon at Barts in London, having moved on from Glenfield, where I had the privilege to be his registrar towards the end of my training. He's taken a leading role in developing guidelines for lung cancer, both the British guidelines and ESMO. He's very well known for his high value educational talk with always an entertaining twist that is a must. We are just grateful for your presence, Mr. Waller, and we're looking forward to you talking to us about the treatment for early lung cancer, and obviously the hot topic, segmentectomy versus lobectomy. Thank you.
Thank you, Hazem. Can you hear me okay?
Yes, we can.
Thank you. I'm going to try and share the screen.
We were able to see your screen shortly, David.
Can you see the screen now?
We've lost it now. We had seen it on a PowerPoint main screen rather than a slideshow, and then it disappeared. So I think try to share it one more time. Probably want to share your desktop rather than the app itself. If you like us to play.
No, I think I can't do it. You'll have to share. You'll have to do it for me.
We can see it now.
I can't go onto full screen. I'm sorry. We'll have to just.
We can see it now.
Okay.
You just need to get a slideshow and we'll be good to go.
Yeah, I'm sorry. I can't do that. So you'll have to do that for me.
Down there.
Okay, we'll play it from. We'll share. We start it from here. Okay, I think it's disappearing on his.
Okay, can you see the full screen now?
Yes.
Thanks. Okay, thank you for letting me speak. So first of all, I am not a talking, can you still hear me?
Yes.
Yeah, okay. So first of all, I'm not a talking textbook. And so what I'm going to do is give you my personal opinion, having been a thoracic surgeon for 30 years, as to how I assimilate the evidence. Now, I hope that you will disagree with me, and we can then discuss the reasons. So I don't see any benefit in me just reading you all the evidence, because you can do that yourself. So I'm going to try and put it into context and try and explain what I do for early lung cancer and why I do it. And I hope that you won't agree, because then we can discuss it. Okay, so I'm going to talk about the definition. And Paul has already spoken about the evidence. He hasn't really made any opinion. He's just presented the evidence. So we'll go over that and I'll try and put it into context. We'll talk about, do you need a preoperative diagnosis? Do you have to do a lobectomy? Can't you just do a wedge resection? And what do you need to do if you're going to do a segmentectomy? So I'm going to try and answer the practical questions that you will be faced with in your practice, possibly an exam, but who cares about the exams? It's what we do with the patients we should be thinking about. So I'm not going to tell you how to pass an exam. I'm going to tell you what to consider when you're faced with these patients, particularly in the MDT situation. Okay, next slide, please. So you'll get confused by subsolid and part solid because they all sound the same. And certainly oncologists don't know the difference. And so they'll use them, and physicians will use them interchange. So what you're used to are solid nodules, and everyone knows what those are. But part subsolid, so they're not straight solid lesions, can either be part solid or pure ground glass. So obviously a part solid lesion has some solid component and also a ground glass component. But what are we actually looking at? So people have tried to correlate what you see on the radiology with what you see under the microscope. And you can see on the right there that the solid lesion at the bottom is invasive carcinoma, usually adenocarcinoma. That the ground glass component can represent either adenocarcinoma in situ or minimally invasive adenocarcinoma. Now that's where the results of surgery get confused, because no one's really certain what they're actually operating on. And Peter Goldstraw used to get really exasperated when he would be shown survival curves of nearly 100% 5-year survival for resecting so-called lung cancer. And obviously he just said, well, this obviously wasn't cancer. And it is true that if you resect adenocarcinoma in situ, for example, you are unlikely to see cancer-related death from that sort of lesion. So it's important to try and correlate what you see on the radiology with what you're going to see down the microscope. Next slide. So the 8th TNN classification is a way of attaching a prognostic value to the size of the solid component, okay? And that's all it's for. It's to give you some idea, and this is all from, of course, databases of resected specimens, and so there is some selection bias, of course, and we have to accept that the major part of the data may not come from the population of patients that you're operating on, in terms of the ethnicity of the patients. But on that basis, the TNN classification was changed on the understanding that the larger the solid component, the poorer the prognosis, even after complete resection. And so when we talk about T1 tumors, we're talking about T1, A, B, and C. And it's just simple to remember, if it's less than 1 centimeter, it's A, less than 2 centimeters, it's B, and less than 3 centimeters, it's C. But the important thing to remember is there's a 5% reduction in 5-year survival between resecting a T1A and a T1C, assuming they're all M0. So if you let the tumor grow by 1 centimeter, you're effectively reducing the patient's 5-year survival by 5%. Now that, you have to think about that, put that in the back of your mind when we talk about watch and wait policies. Next slide, please. And as I say, the important thing is the invasive component of the tumor, because that's the solid bit. So the solid bit of the lesion is important. And so the conclusions now are that it's the invasive size rather than the total size of the nodule that's important. So you're really looking to see what happens to that solid component if you are looking and observing, because the GGO component is not described. As it doesn't necessarily mean it's invasive carcinoma. So what we're looking for is the size of the invasive component, which we correlate with the solid component on the CT scan. Next slide. Now, I think you've touched on multiple nodules previously in the MDT. Suffice to say that when you have multiple ground glass or part solid lesions, then your T stage is according to the highest T lesion with a single NNM, and you record all the lesions collectively, and rather than trying to count them, you put a bracket M for multiple. So you would stage it as, for example, T1B brackets M if there were some smaller lesions that were T1A. How you deal with them, we'll come on and talk about, but what you're interested in all of these is the solid component. And what I would also encourage you all to do is when you're presented with the CT scan in one plane, which is usually the axial plane, always ask for the sagittal plane. And you should really now be looking at these small lung cancers in at least 2 planes, but preferentially in 3 planes with the coronal plane, to get a full understanding of the morphology of the lesion. And what we all should be working towards, and hopefully we will be in further TNM staging systems, is the volume of the lesion. And when we see screen detected part solid lesions, which we do in our practice in London, we always get a volumetric measurement. And importantly, we get the percentage change in the volume of the lesion. When we get down to these small lesions, measuring it in one plane is probably not adequate. And we should really be looking at volumetric analysis now in all of our CT softwares. Next slide, please. So in the MDT, I saw you discuss a peripheral nodule, and everybody was talking about how they would get a preoperative biopsy. Well, let's take it through that. So would you get a percutaneous biopsy of a very small lesion? If it wasn't so peripheral, you have a very low hit rate, it's part solid, and often these patients have emphysema, so there's a risk of pneumothorax. There is a trend now towards navigational bronchoscopy to obtain a tissue diagnosis, but the same things apply. We are talking about very small part solid lesions, and I have yet to see what the hit rate is for navigational bronchoscopic biopsy. What we see, and of course there is a publication bias in all of these techniques, are the results for larger, usually metastatic lesions. And don't forget that navigational bronchoscopy will require a general anesthetic. And ironically, even if the patient's having, is thought to be too high risk for a lung resection, albeit a small one, the patient will often require a fiducial placement for radiotherapy. This always seems a bit strange to me. You're going to anesthetize the patient to not operate on them. What about getting the intraoperative VATS biopsy? Well, again, that's all very well if you've got a peripheral solid lesion with a puckered visceral pleura, and you can clearly identify the lesion. But we're moving now into the territory of screen-detected impalpable lesions. So how are you going to get an intraoperative VATS biopsy if you can't localize it? Well, of course, the people with a lot of money and technology will try and put a marker in it with navigational bronchoscopy, and then do an image-guided biopsy, which again I assume will be a wedge. But often these lesions are so central that it will be an extremely large wedge crossing all anatomical boundaries of segments to obtain a biopsy. Oh yes, you can then send it for frozen section. Well, I would challenge you that all pathologists would be able to commit on a frozen section analysis of a part solid lesion. The temptation then would be, oh, well, let's wait for the H&E analysis, but then you've got to come back for a second operation. So if you put all this together, you could finally make the diagnosis, but you may have put a chest drain in for a pneumothorax induced by a percutaneous biopsy needle, and you then may have given the patient 3 general anesthetics, 1 for the navigational bronchoscopy and failed biopsy, 1 for the VATS biopsy and frozen section, which was inconclusive, and then 1 for the final definitive operation. Now you think I'm being funny, but that's actually true. Because lung cancer screening is identifying earlier lung cancer, so it's difficult to obtain a preoperative diagnosis in these part solid lesions. And so there may then be, as we've spoken about, the temptation to delay the intervention pending growth of the lesion. But if you leave it too long, you're going to negate the benefit of the screening program and the early diagnosis. It probably is safe to wait for a solid component to be visible and wait for volumetric, remember volumetric growth, over a 3-month period. I think, as one of the radiologists alluded to in the MDT, and for me, who can remember the onset of PET, it was a staging investigation, not a diagnostic investigation. So it was useful when the primary had avidity, because then you could look for secondary metastatic disease on the basis of the avid primary. But most of these really small part solid lesions won't have avidity. So it's not very useful. It can't be used for staging in that respect. And you may get the, as we know, the occult avidity in neck nodes or in the abdomen or in the thyroid that are just red herrings and will just delay the definitive treatment and may lead on to many unnecessary diagnostic procedures for the patient. So the guidelines will say do a PET in all cases you plan for resection, but of course those guidelines need to be updated now in relation to how early we are detecting potential lung cancer. Do you have to do a lobectomy? No, of course you don't. You'd like to do a lobectomy because it's a nice operation to do by VATS, and you've all learnt, taken many months and years to learn how to do VATS lobectomies. You're comfortable doing it. You can do it through a single port. You don't really want to change that. And you can always fall back on the lung cancer study group study. Oh, everyone says that. That's the gold standard. That's why I do a lobectomy for a T1A lesion. Well, if it is, then you need to think carefully, because that was conducted over 25 years ago. And one would have hoped that clinical staging and assessment has changed since then. There clearly have been advances in surgical techniques. We're not doing thoracotomies anymore. And that group didn't identify what the experimental group was, whether it was a wedge or a segment or what. And so it was a fantastic study that was conducted by some excellent surgeons of its time. It is not of our time now. And we should have respect for it, but we shouldn't guide our practice. Now, Paul's just presented the JCOG 0802. It's a suggestion. I think it's wrong to say it becomes the standard of care, because you do need reproducible results for anything to become standard of care. And we need to understand what the recurrence patterns were. Clearly, if you leave more lung behind, you're more likely to see lung cancer. And if you wanted to reduce all local recurrence on the ipsilateral side, you take the lung out. But clearly that isn't sensible, and it's not a sensible logic to follow, to take everything out so you don't get local recurrence. We don't know these weren't new primaries, of course, and so we do need more data. But the important point I think that I took from this study was the danger of lobectomy. not the benefit of segmentectomy. The next slide, please. But we saw there was no difference in relapse survival despite high recurrence, and that needs further understanding. It probably relates to the type of treatment that was given for the recurrent disease, and that will come out in a published paper. Next slide. So I took from that not the benefits of segmentectomy, but the dangers of lobectomy. That removing more lung tissue is detrimental to survival, and you start to die from the operation rather than the cancer. And we knew this for pneumonectomy. This is a simple principle that we followed from the comparison of pneumonectomy with sleeve lobectomy, that the more lung you took, the more dangerous it was. And that's what I took from this, that the survival curves were different because lobectomy was more dangerous than segmentectomy. And as you can see there, the patients started to die from non-malignant disease, including more respiratory disease and cardiovascular disease. Quite what these other cancers were, we'll have to find out. But I would counsel you to remember that the lung is not just full of air, it's full of blood. And I'm not really interested in what happens to the FEV1 after you take lung tissue away, because that depends on what lung tissue you leave behind. But every piece of lung you take away more of the pulmonary vascular bed, and therefore you increase the pulmonary vascular resistance. And you'll find that the patients that die long-term after lung resections are starting to go into right heart failure. We know these patients terminally from COPD, compounded by taking pulmonary vascular tissue away, will deteriorate with swollen ankles, large livers, and congestive heart failure. So I think that JCOG trial for me highlights the danger of taking too much lung tissue. So I can't just do a wedge. Look, that's a nice, easy operation. I can do that without the consultant there. I can do it by VATS. It's easy. It must be the best thing to do because it's easy. Well, you might be right if you're doing surgery for borderline cancer, shall we say. So minimally invasive, pure ground glass, you can do a wedge if you can find it. How are you going to do a VATS wedge if you can't feel the lesion? But there is a suggestion, of course, and again, there's no randomized data yet, but large database analyses such as the SEER registry found that adjusting for the propensity score, segmentectomy was associated with a significant improvement in survival and lung cancer specific survival, particularly compared with wedge. And a similar analysis of the US cancer database found that for T1A and 0, that segmentectomy had a similar 30-day mortality, but improved long-term survival compared to wedge, especially and even for those patients with no comorbidities. Now, quite how that's defined, because all lung cancer patients, of course, will have comorbidity. And that's the reference for that. So you can see where I'm heading, that I believe that segmentectomy probably is the best. It's like the Goldilocks and the Three Bears story. The lobectomy is too much, wedge is too little, and segmentectomy is just right. Now, there are some people who will say, look, you can't do a segmentectomy if you've got M1 disease. Now, we could talk for hours about the lack of logic in that, because that really based on the understanding that cancer is an infection and you can cut it all out. And so if it's gone to the lymph nodes, you want to cut more out. But clearly there's no logic in sacrificing parenchymal lung tissue and its pulmonary vasculature for a disease that's into the lymphatic system. As we understand now, cancer is a systemic disease. And again, analysis of the National Cancer Database have found no difference in overall survival in N1 disease between segmentectomy and lobectomy, but that would be an interesting trial. Of course, the JCOG study excluded it at source and did a frozen section analysis to exclude N1 from those randomization. That would be a more interesting study. So what margin is needed? Well, that is very difficult to determine. And the only sort of evidence for that is that an arbitrary decision to take a margin to tumor diameter greater than 1 had a significant reduction in recurrence rate. That is going to be difficult to analyze. Usually, of course, if you've got a T1A tumor, you're looking at a diameter of about 1 centimeter, so segmentectomy clearly is feasible. Okay, that's the next slide then. So we don't like segmentectomy because it's difficult to do. It's nasty. If you don't do it open, it's difficult to do it by VATS because you've got the lung inflating everywhere and you can't really see where to divide the lung tissue. This is probably, for me, the only reason to get a robot. I don't think there's any benefit in doing lobectomy by robotics compared to VATS. There is compared to thoracotomy, of course. But for segmentectomy, and I can tell you, having done hundreds of both, nearly 100 of robotic segmentectomies and well over 200 of VATS segmentectomies, that it's much easier by robotics and more accurate. It allows for bimanual dissection of the individual segmental bronchovascular structures, and getting down to the segment 10 bronchus is pretty difficult by VATS. You have to be an excellent surgeon to do that. You do need to include in the specimen the segmental bronchus and the segmental artery, or you've just done a wedge. And some people will say they've done a segmentectomy and that's all they've done is a wedge. We use the Firefly application in the XI robot, which is a near-infrared thoracoscopy, with after the injection of the ICG designing green fluorescent agent, which in that light you can see where it goes in the vasculature. It's very easy then to identify the unperfused target segment if you divided the segmental artery correctly, and that makes it much easier. And interestingly, it's interesting how small the segment looks in that. And I'm sure when I was doing that segmentectomy, based on inflation, I was actually doing a much more extended operation. Just to comment on the nodal situation, there's still no excuse for not doing a systematic nodal dissection. I know you don't like it, and it's much easier at the end of a difficult VATS operation just to do a little bit of sampling, but there's still no real excuse not to do a proper, at least lobe-specific nodal dissection. I know it adds on you when you're tired at the end of a VATS segmentectomy, you really just want to get out of the operation, but you really do still have to stay there and do the nodal dissection. So here's a clinical example. There's part solid lesion in the apex of the left upper lobe. And of course, you do have to, if you're going to do lung surgery, you do have to know the anatomy of the organ you're operating on. You wouldn't expect cardiac surgeons not to know the coronary anatomy. So you do have to know that there are 10 segments in the right lung and 9 in the left. You need to know where they are. And it's useful to number them. And this is something that the physicians have problems with, and certainly the radiologists, and I'll talk about all the apicomedial, posterior, basal, but it's much easier to learn a number for them. So this lesion was in segment, well, actually, you can see where it was. It was close to the border of S1 and S2, and so I took both out. And actually, on the histology, it was only minimally invasive carcinoma. How interesting was that? But it was sitting very close, and I wasn't happy doing a unisegmentectomy. There is going to be software become commercially available, which will help us, but even then we have to have a degree of suspicion about that. And I think the importance, again, coming back to what I was saying about lobectomy, it's not what you take out, it's what you can leave behind. So for me, all I can do looking at that is think I can safely leave behind segments 3, 4, and 5 of the left upper lobe. And that will help the patient because I won't be taking away more pulmonary vasculature than I need to without compromising oncological principles. So when I'm looking at these scans, I'm not thinking what am I supposed to take out, I'm thinking what can I safely leave behind. Next slide. So this is my approach to surgery for early lung cancer. I hope that you disagree with it because then we can debate it. for stage 1 suspected lung cancer with evidence of volumetric growth, I wouldn't do a CT PET in T1A tumors. I would consider a diagnostic, minimally invasive segmentectomy without getting a preoperative biopsy for the reasons I've explained, and without doing intraoperative frozen section analysis of either the lesion or the lymph nodes. I would obtain a margin greater than the diameter of the solid component, and I would do a systematic mediastinal lymph node dissection. Thank you for your time. Look forward to your comments.
Thank you very much, David, for this, as ever, thought-provoking talk, and I would have loved to take you on some of those things, which I actually, put everything aside, is I share a lot of those thoughts, the role of segmentectomy as a standard for T1A. But I'm just going to sneak in a very quick question, because I was intrigued by your comment about the danger of lobectomy and the fact that there is a recurrence rate in the JCOC data. Would you now safely say you would do a segmentectomy for all T1A lung cancers, full stop? Young, yes. Normal lung function.
Well, the only proviso for that is Hazem. That obviously what I'm trying to do, the principle of what I do when I go into a lung cancer operation is trying to preserve functioning lung tissue. But as you know, I do a lot of operations, nearly as many lung cancer operations for emphysema. So there's no point, in fact, as we know, it may be beneficial to take out non-functioning lung tissue. So for example, in that MDT case, I was surprised that nobody asked for a perfusion scan, because it may have been actually better to take more lung tissue. So I need you to start thinking more like physiologists and not like a bovine orthopedic surgeon just told, I'm going to cut this out. That's great.
It's on YouTube.
What you need to find, because that's the important. In some ways, that's more important than what you're taking out. So yeah. I would qualify that about segmentectomy Hazem, that yes, I would do a right upper lobectomy if a SPECT scan had shown me that the function of that remaining, say, S3 was of no use to the patient and they were hyperinflated. So it'd be better to take it out and leave it behind.
That's very clear. And actually, to address your question about the MDT, the patient did have plethysmography and VQ scan, but for the sake of time and the discussion didn't lead that way, but we definitely can take in the lung volume reduction effect in him in decision. Okay, well, thanks very much. Swiftly moving on because we're running a bit behind, and the just next we have the program.
So the next is
next is Alan still with us here?
Yeah, I'm here.
Hi,
yeah,
Alan.
I'm sharing my screen. Can you see
yes. it? Great to have you again, Alan. Quick introduction for a very long credentials, consultant thoracic surgeon at the Gleneagles in Hong Kong and a guest professor at Tongji University in Shanghai. And Alan has been a great friend, always been there for the Birmingham Review course, great educator, absolutely entertaining talks as ever. Great avid for uniportal VATS with huge experience. I can't wait for you, Alan, to talk to us about surgery for advanced lung cancer.
Thank you so much. Everybody can see my slides? Yeah?
Yes.
Okay, great. So thank you so much for having me here again. You've given me a huge topic, advanced lung cancer. I've got too many slides, so forgive me for talking kind of fast through this presentation. So let's get stuck straight into it. What is advanced lung cancer? Well, this is what's not advanced lung cancer, as you know. We're not going to talk about that. This is one of the examples of advanced lung cancer, the N2 positive 3A disease. Again, we're not going to talk about that because there's enough on this topic to fill up an entire conference by itself, and there's still a lot of controversy, as you all know. I refer you to this particular paper if you want to know more about these stage 3 N2 positive cases. As you can see, even the international guidelines have no strict consensus on how to manage these. Instead, today, I think we'll focus on advanced lung cancers in this bracket, which I think is a little bit more interesting. And within this bracket, I think I'll divide this into two separate groups. The first group is this group, the M1 positive distal metastasis group. Is there a role for surgery in these cases? Of course there is, and you probably heard of this already. And this stems back to studies that go back over 20 years. And it's been shown in a lot of case series that even with these stage 4 cancers, if there are just limited metastases to the brain and to the adrenal glands, you can do surgery on these cases, and you do end up with a proportion of patients with decent 5-year survival rates. It's not that bad. And this has become so well recognized that I think even our oncology friends have coined the terms oligorecurrence and, of course, oligometastases. I think relevant to our discussion here today are these oligometastases. And you can see that if you only have 1 or 2 or 3 to 5 metastases only in the brain and in the adrenal glands, you can have relatively favorable outcomes if you do surgery for these oligometastatic lesions. I think most of us actually recognize that by now. However, things have still moved on from that, from this period in time. And I think more case series have been presented over the years, looking at other potential predictive factors of good outcomes for stage 4 lung cancer resection. And these include looking at nodal status. Obviously, if you don't have any lymph node mets, you have better results. You look at the site of those metastases. If it's contralateral lung in this particular case, better results. Here's another similar study, again, showing a different range of factors to consider. T status, if it's T1 or 2, better results. The site, again, pleural metastases, brain metastases, better survival. And of course, if you have effective TKI plus or minus chemotherapy postoperative. However, these different studies, you can notice they're relatively small. So I don't think there's yet a consensus on these other factors, but do bear in mind TNM status, the site of the occurrence. These are things that I think a lot of researchers are thinking about today. We as surgeons, what can we do to influence survival of stage 4 metastatic disease with surgery? Well, the surgery we do is important. Lobectomy is better than sublubar section. It's been found in this retrospective review of the SEER data. Nodal dissection was said to be important, but again, I don't recommend this with a lot of certainty because this is ultimately just a retrospective database data analysis. However, what is certain, if you do go back to the data, is that if you do surgery for stage 4 disease, you do end up with better outcomes than if you don't do surgery in these selected patients. Now, again, take this with a pinch of salt because this is not a prospective randomized trial. This is just retrospective analysis of the SEER database full of biases. But what it does show that if you do have these biases and you select patients selectively for surgery, if they have stage 4 disease, you do end up with better patients. It's just a matter of how you select patients. That's not being well defined yet. Here's another very often quoted paper from 2016 using the California Cancer Registry. And again, they show you in stage 3B and stage 4 disease that if you do surgery, whether or not it's combined with chemotherapy or chemoradiation, you do end up with better outcomes than if you don't do surgery. So there obviously is some scope for surgery in stage 4 disease. How we select patients other than brain and adrenal limited metastases, that's still a field that's still evolving. So that's what I'm going to say about that particular bracket here, because I want to move on to the locally advanced disease, the T3, T4 tumors. We've got a bit more to say here, but I think we should start off by saying that despite all the advances we're seeing in oncological therapy, in the chemotherapy area, you do improve median survival. But nonetheless, for these advanced cancers, look at these median survivals. They're You're talking even with the latest therapy of just about a year. So these patients without surgery, they do face pretty grim prognoses. And so when we look at some of the data I'm going to present in just a minute, this is the baseline from which you're starting. So within these locally advanced tumors, I'm just going to look at two particular categories. The first category we're going to look at are the superior sulcus or thoracic outlet tumors. So this is the region. You don't need me to explain what these are. Now for these particular lesions, surgery is definitely possible, but it's all down to patient selection, whether or not you have good outcomes. So there are three areas of consideration. The first one is lymph node status. I think it's been shown in many studies. This is just one particular study. It's been shown that having an N0 status is significantly correlated with better survival. Here's another study from Walter Kopecko's group, again, showing you the same thing. If you have N0, that's definitely a better predictor of good survival after you do surgery for these superior sulcus tumors. Look at that hazard ratio. It's a huge difference. And therefore, it's enshrined in the guidelines, grade 1C level of evidence, that involvement of mediastinal lymph nodes or other metastatic disease is a contraindication for surgery for these thoracic outlet or superior sulcus tumors. The second consideration when you consider this is whether you give induction chemoradiation and you get a good pathological response. See that huge difference in the survival curves if you give effective chemoirradiation. And again, in this systematic review, this best evidence topic paper that was published a few years ago, they looked at the best available evidence. And again, you can see that if you give trimodal induction chemoradio instead of just RT before surgery, you can see a very significant differences in 5-year survival. And it's concluded that induction chemoradiotherapy is beneficial. And again, this is enshrined in the guidelines. It's suggested that preoperative concurrent chemo and radiotherapy should be given before surgery if you're going to contemplate surgery for these complex tumors. And the final part of the puzzle is you need to do effective R0 resections, radical surgery. Again, you get a nice separation of your survival curves. If you don't do effective surgery, you're not going to last very long. The patient's not going to last very long. So this is a key element. And again, you have other case series, again, showing you that the radicality of resection wasn't significant in this particular study, but there was a clear trend here. And if you do have just R1 or R2 resections, you're not going to have good long-term survival. So this is the third leg of the tripod. You need complete resection. And to that end, if you are contemplating surgery for these pancreas tumors, these superior sulcus tumors, it's essential to do good preoperative imaging, such as MRI, et cetera, to make sure that you're going into surgery with a good confidence that you can actually resect everything. Now, how you resect it, I'm not going to go into that. There are different approaches you can use, either from posteriorly or from anteriorly. The point I want to make with this is that whichever approach you use, these are really traumatic operations, far from minimally invasive. So you do get decent 5-year survival. You can see in this systematic review, you do get actually decent survival if you fill those 3 criteria that I talked about. But don't neglect the fact that you are harming these patients to some degree. Now, nowadays, I think in experienced hands, mortality is acceptable, but don't underestimate the morbidity risks. I mean, you're getting up to 50% morbidity. Some of these morbidities are pretty severe. Don't forget, you're operating near the vessels, the brachial plexus. You can run into serious trouble with some of these patients. And therefore, it's recommended, again, in the guidelines that these operations should really be done in the larger centers. If you're only seeing these very infrequently, we should probably take a pass when considering operation for these patients. Now, even in the guidelines, you can see, yeah, the surgery mentioned here, but there's also an escape clause here. You can always refer patients for durvalumab in this day and age. And the key thing here, is whether a patient is resectable or not in an MDT, it's the role of the surgeon to say whether it's unresectable or not. So don't be a hero if you're not really experienced with such complex operations. The other category of locally advanced tumors I want to talk about are these, the ones that have cardiovascular infiltration. So you will see many papers available that talk about, reconstructing the SVC, reconstructing the aorta. And even if you do with or without CPB, you can actually resect it even if the tumor is invaded into the heart itself. So there have been reports that this has been done. Now, if you do these kind of operations, for example, if you do the surgery with this SVC reconstruction, what results do you get? Well, you'd actually get, well, again, decent 5-year overall survival reported. But look here, the mortality is really quite high. A lung cancer operation with a mortality rate of over 10%, this is really significant. And this, remember, are the results reported by the really experienced units that are doing this more than the average surgeon here. So yeah, you do get some decent survival. If you talk about the left atrial involvement, the survival is obviously even lower. And if you look at the mortality here, it can range up to 50%. In fact, in several of these studies, the mortality of the surgery is even higher than the 5-year overall survival rate. So if you are going to embark on such difficult operations, bear that in mind and remember that these are experienced units. It's not only the mortality we need to think about. For example, in this study, the mortality was 9.7%, but also the morbidity. Again,
give me one Coco Cappuccino, hot, grande.
Can I have a coffee as well?
And then another one is signature chocolate.
Okay. Anyway, you can hear me now. Okay, so you're also talking about the morbidity as well, up to 50%. And these morbidities aren't small morbidities either. Look at these rates here of things like AF, AMI, stroke, pulmonary embolism. So you are causing harm to some of these patients in return for an oversurvival of about 30%. Is it worth it? Well, it's debatable. Now, again, another thing that you have to take into consideration when you consider these operations, none of these are minimally invasive. These are massively invasive, and you do get significant pain. I think in this day and age of VATS and robotic surgery, we're forgetting how much pain we're inflicting on some of our patients. And it also reflects in terms of their physical and also emotional and mental status as well. So are we really helping a lot of our patients that much? Again, you have to be careful when considering surgery for these patients. Now, if you don't do surgery for these patients, what are your options? Well, not too bad. Even before the advent of things like durvalumab, even in modern chemoradiotherapy, you're talking about in these locally advanced tumors, a 5-year overall survival rate of up to 41%. That's as close as some of those surgical survival rates I just showed you. With TKIs and target therapy nowadays, you're talking about 36-month survival of over 50%. Again, you know, this is as good as or even better than some of the surgical series I've shown you. And of course, don't forget, we have immunotherapy nowadays, and you all know the Pacific trial with a 24-month overall survival rate of 2/3 of patients. This is as good as any kind of surgery you're talking about nowadays. So don't think necessarily that you always have to be the hero and do massively heroic operations. At the end of the day, whether or not a patient in an MDT is defined as resectable or unresectable is down to the surgeon and a realistic evaluation of what he or she can offer the patient. And if you do think it's unresectable, don't underestimate our oncology colleagues. They can offer quite effective therapy as well in these patients. So in future, things might change. I think there are so many studies looking at the use of induction immunotherapy, for example. A lot of these trials are going to mature over the next few years. We're going to see the results. Maybe that would change the picture in future. Another area where things might change is salvage surgery. Patients that were decided by MDT long ago that they were definitely not for surgery. And yet, after a good target therapy, if patients have recurrent or residual tumor, you are seeing emergence of a few scattered reports of some good long-term survival when you offer salvage surgery. This is something we should be keeping an eye on in future. For today, I think what we can conclude on is this slide. I think 2 types of advanced lung cancer, stage 4 disease. Be aware of the oligometastases. For brain and adrenal oligometastases, I think the evidence is not huge, but it's well accepted nowadays. And there are evolving considerations, things like considering the TNM status of the lesion, the site, whether effective target therapy can be offered. For the locally advanced tumors, for the superior sulcus tumors, the 3 key considerations are nodal status, whether you're given good, effective concurrent chemoradiotherapy preoperatively, and whether you can achieve a good radical R0 resection. For the cardiovascular invasions, I think there are good case series that show the surgery is feasible and successful in selected patients, but whenever you consider surgery for these patients, you always have to weigh the benefits against the potential harm, which can be higher than you think. And if you're not confident in offering effective, safe surgery, then non-surgical options should still be considered. They're not as bad as we think. And at the end of the day, first, do no harm. Thank you very much.
Thank you very much, Alan. Many questions. I guess I'm going to have to move on because we're running about 20 minutes late and we eaten into the time for the seminars. If you have any questions for Alan, I definitely do have many. Could you please text him on the chat function, either in public or privately, wherever you're comfortable with, and Alan, I'm sure, will be delighted to answer them. Moving on to the next talk is Elizabeth. Is Elizabeth with us? She is.
Yes, I am.
Hi, Elizabeth. Thank you very much. Quick introduction again for Elizabeth, who's been almost a very loyal feature in this course. Elizabeth is a consultant thoracic surgeon in Oxford, who is a keen educator. I've been taught a lot by her in different seminars and lectures all over the specialty facility. She's a member of she's an advisory, a member of the Special Advisory Committee for Cardiothoracic Surgery at the Royal College of Surgeons in England, and she's also an examiner at the Royal College of Surgeons. Can we mute whoever is, sorry about that. Okay, well, Elizabeth is going to talk to us today about the mediastinal malignancy, which will be followed on by the seminars after that. So just give us an introduction onto how to approach them. Thank you.
Oh, thank you. And it's a pleasure to be asked to speak again at the Birmingham review course this year. I have no disclosures. Pathology of the mediastinum covers a wide range of diagnoses. And in the seminar which follows this session, you'll have the opportunity to undertake case-based discussions into a wide range of mediastinal conditions. But for the purposes of this talk, I will focus on a review of mediastinal malignancies and provide a framework for you as thoracic surgeons in order for you to manage mediastinal conditions. And so during the next few minutes, we will review the anatomy of the mediastinum and understand why compartmentalization of the mediastinum allows us to narrow the range of diagnoses in patients with mediastinal masses. We can discuss the clinical features of patients with mediastinal tumors and how to investigate a patient with a mediastinal mass. And then finally, we will briefly review pathology-specific management of individual mediastinal malignancies. The anatomy of the mediastinum is such that it extends from the thoracic inlet superiorly to the diaphragm, inferiorly and laterally to the pleural cavities. By compartmentalizing the mediastinum, we can narrow the range of possible diagnoses in a patient with a mediastinal mass because each compartment has its own most common pathology. And classifications were first devised based on the lateral chest X-ray and divided into either 3 or 4 compartments by a variety of surgeons, anatomists, and radiologists. Surgeons tended to use the Shields classification described in 1972, and Gray described a 4-compartment model which divided the mediastinum into with a superior component based on an imaginary line from the manubrosternal joint passing posteriorly to the T4-5 thoracic intervertebral disc. But the lateral chest X-ray is now less commonly used and has little place in the modern imaging era. And it's certainly much easier, I think, to request a CT scan than a lateral chest X-ray nowadays. Moreover, I think the creation of a superior compartment along an arbitrary and imaginary line is certainly not respected by pathological processes in the mediastinum, such as malignancy and infection. And so for all these reasons, this has led to the development of classification systems based on boundaries identifiable on cross-sectional anatomy. And the International Thymic Malignancy Interest Group have proposed a 3-compartment model based on cross-sectional CT images. And so you can see here, the pink area represents the anterior mediastinum from the back of the sternum to the anterior surface of the pericardium. The middle mediastinum passes from this line to a vertical line drawn 1 centimetre posterior to the anterior border of the thoracic spine. And the paravertebral, the yellow compartment, is a potential space that runs from this line to a line drawn down the transverse processes of the thoracic vertebrae. And by compartmentalizing the mediastinum in this way, then we can understand the major contents of each compartment. The anterior compartment contains the thymus, fat, and lymph nodes, and the visceral compartment contains the heart within the pericardium and the great vessels. It contains the esophagus, the trachea, the mainstem bronchi, the thoracic duct, and lymph nodes within this area. The posterior paravertebral compartment, this potential space, contains the sympathetic chain, the spinal ganglia, and the azygos and hemiazygos veins. So by dividing the mediastinum into these compartments, then we can understand the likely malignancies that will occur in patients. Slightly more than half of all mediastinal masses occur in the anterior compartment, with around 25% each occurring in the middle and the posterior mediastinum. The most common malignancies encountered in the anterior compartment include thymic malignancies, followed by lymphoma, germ cell tumours, and thyroid and parathyroid tumours. Tumours of the middle mediastinum that we are asked as thoracic surgeons to diagnose usually are lymphomas. Also, we see tracheal and mainstem bronchial tumours, esophageal tumours, and cardiac tumours, but we tend not to think of these as mediastinal tumours when we manage those, but they are actually tumours of the middle mediastinum. And finally, tumours in the posterior paravertebral space, 90% of those are neurogenic tumours. So how do patients with mediastinal tumours present? Well, they may present with non-specific features of malignancy, with malaise and weight loss. Particularly patients with malignant tumours of the mediastinum are likely to present with symptoms of compression, and it's quite common to see patients presenting with superior vena cava obstruction and with stridor and breathlessness due to compression of the SVC and the airway. However, they may present with features associated with the particular pathology they have developed. So patients with thymoma may present with features of myasthenia gravis. Patients with lymphoma may present with type B symptoms, and patients with germ cell tumours may present with testicular mass. They may also present with features related to active substances that they are secreting. I see quite a lot of intrathoracic parathyroid adenomas and sometimes carcinomas that are sent to me by our endocrine surgeons. And these patients are almost exclusively diagnosed with symptoms of hypercalcemia related to high parathyroid hormone levels. Also in the posterior mediastinum, paragangliomas are similar to pheochromocytomas, and they can present with features of catecholamine production. So how do we investigate a patient who is sent to us with a mediastinal mass that may be malignant? Well, in addition to the CT scan, then we should consider, in addition, biomarkers, further imaging, and whether or not to biopsy these patients. So for tumours, particularly in the anterior mediastinum, then tumour levels such as alpha fetoprotein, beta HCG and LDH can be particularly useful and may be diagnostic on their own if they are more than 500 milligrams per mil. Patients with a thymoma, whether they do or sometimes do not have myasthenia, or have antibodies to acetylcholine receptors. Patients with lymphoma require a blood film, and as I mentioned, patients with parathyroid tumours usually present with high calcium and PTH. Do you need additional imaging for your patient with the mediastinal mass? Well, PET can be useful in determining whether these tumours are benign or malignant, and it's also useful to look for extrathoracic disease, because it may be that these patients don't require invasive mediastinal biopsy if we can find an easier route somewhere else. MRI is particularly useful in the anterior mediastinum for differentiating between thymic hyperplasia and thymoma. We can use chemical shift MR imaging, looking at in phase and out of phase sequences and ratios, and that's particularly useful for the radiologist to tell us whether this is a thymoma or not. In the posterior mediastinum, MRI is important to look whether neurogenic tumours have intraspinal extension through the vertebral foramina. And patients with germ cell tumours require ultrasound of the testes. It can be a bone of contention whether the patients with mediastinal tumours need a biopsy or not. Essentially, biopsy is not required in patients with thymomas and neurogenic tumours where the diagnosis is not in doubt and where they do not require extended or higher than average risk surgery. But where biopsy is required, then we have the usual escalating invasive techniques of FNA, core biopsies, EBUS, and then surgical approaches. And whether we undertake mediastinoscopy or mediastinotomy or VATS depends really on which compartment the tumour is in. So what about some of the individual pathologies that we see? Well, thymic tumours are the most common malignancy of the anterior mediastinum and account for around 20% of all mediastinal tumours. And they range through a variety of histological types of thymic tumour. In Oxford, we are a national referral centre for myasthenia gravis, and so we have a steady stream of patients with thymoma coming through our service, and the majority of these are resected at VATS. But clearly not all of them can be excised in this way. The bottom image there is a patient that was referred to me with symptoms of cardiac embarrassment due to this huge tumour in his anterior mediastinum, which I removed, and that was a thymic carcinoid tumour, which had grown to 20 centimetres in size. Thymomas may present, as we said, with paraneoplastic syndromes. 50% of patients with a thymoma have myasthenia, and 15% of myasthenia gravis patients have a thymoma. The treatment is surgery in most stages, with the idea of removing all the thymic tissue between above the innominate and into the cervical horns, down to the diaphragm, and between the innominate vein and the pericardium and the sternum. It's important to have an understanding of the classification and staging of thymoma. The WHO classification of histological subtypes of thymoma is used to differentiate from more indolent medullary thymomas through to thymic carcinoma. And staging of thymoma has changed throughout the decades. Initially the Masaoka staging in the 1980s, and then the Masaoka-Koga staging in 1994, and most recently the Ishel and Itmig TNM staging. What is the effect of all these changing stages for thymoma? Well, the effect of restaging really has been to move surgically resectable disease to the lower stages now compared to the original Masaoka staging. And surgery is used in most stages of thymoma, in isolation in the earlier stages of stage 1, 2, and 3A, and as part of multimodality therapy in the later stages 3 and 4. And we can discuss thymoma more in the seminar that follows this session. The mediastinum is the most common site for extragonadal germ cell tumours, and they account for around 15% of all mediastinal tumours. Around a third are incidental, but others may present with symptoms of compression. 85% of them are benign, and surgery is curative. In the remaining 15%, then these represent either seminomas or non-seminomatous germ cell tumours, and these commonly occur in young men between the ages of 20 to 40. Imaging and tumour markers are the key to diagnosis, staging, and management of these patients. Approximately 10% of seminoma patients will have slightly elevated beta-HCG levels, but otherwise normal markers, compared to 90% of non-seminomatous germ cell tumour patients who have elevated markers based on the cellular components of their particular tumour, and over 50% of them have mixed tissue components. Seminomas are diagnosed by FNA, and they're extremely chemosensitive, and surgery is usually not required in these patients because post-chemotherapy they develop a dense fibrotic residue. However, patients with non-seminomatous germ cell tumours, they receive chemotherapy, and surgery is indicated in these patients in an adjuvant manner for any patient that has macroscopic residual disease. And this is undertaken both to avoid complications of growing teratoma syndrome and malignant somatic transformation, which occurs in around 2 to 8% of these patients. Unfortunately, the outlook for patients with primary mediastinal germ cell tumours is not as good as those with primary gonadal site disease. This is because there is reduced sensitivity to chemotherapy. They often present with bulky disease with compromise, and they are associated with a 300-fold risk of aggressive hematological malignancies. And this was a 20-year follow-up of patients who underwent multimodality treatment for primary mediastinal germ cell tumours. And you can see the outlook is best for seminomas with an 87% 5-year survival, but much worse for those patients with non-seminomatous germ cell tumour. The best outlook for those patients is if their tumour markers normalise after chemotherapy. What else do we find in the anterior mediastinum? Well, don't forget the thyroid gland. Most of the patients with intrathoracic thyroids represent multinodular goiter and is benign, but you can see malignancy in the in the mediastinum from the thyroid. This was a patient who presented with stridor, with a 4 millimeter trachea that was stented, and then we undertook excision of that via cervical incision and stenotomy in order to remove the tumour from the great veins. And also I had to undertake repair of the anterior wall of the trachea there with pedicord pericardium and sternocleidal mastoid muscle over the stent in order to remove that tumour. Lymphomas we commonly see in the anterior mediastinum, and they are responsible for around 15% of all primary mediastinal masses in adults, but almost half of the tumours that are seen in children. In where we see the C lymphoma in the mediastinum, in 90% of patients, we also see it in extrathoracic sites, and it may be that the patient does not need a biopsy of the mediastinum. We may be able to access other lymph glands. In 10% of patients, however, the lymphoma is primarily of the mediastinum, and they're usually Hodgkin lymphomas. And symptoms are related to local compression, as you can see in this patient that was referred to me. They've got airway compromise, and I performed a bronchoscopy and Y stent in this patient, but there's no tumour within the airway because it's predominantly anterior mediastinum, and I performed an anterior mediastinotomy in order to biopsy that for him. He responded well. That was a T-cell tumour, and as he was responding, I was able to remove that Y stent for him. But lymphomas have a predilection also for the middle mediastinum, and we can see here that this is clearly in the middle mediastinum, again with significant airway compromise, and you're not going to be able to biopsy that by an anterior mediastinotomy. Now, in most of these cases, there is endobronchial disease, and you get an invasion through the station 7 node, through the splayed carina, and you can obtain enough tissue here without further biopsy. But it's often difficult to see that on the CT scan because of the degree of extrinsic compression. So, and again, we mentioned the other tumours of the middle mediastinum that we generally manage under other conditions. But do we need to be performing all these surgical biopsies in the era of modern biopsy by our respiratory physician friends? Well, this is a paper from MD Anderson, which showed they had a good sensitivity and specificity for lymphoma using EBUS, which is firmly established in staging and diagnosis of primary lung cancer. And they had good results here, and obviously a large centre. I think in the UK and certainly in Oxford, where I work with our pathologists, they like surgical biopsies, particularly in de novo lymphomas. A lot of these patients in this series, where they had good results with EBUS, were recurrent lymphoma, and I think that is a bit easier for the pathologist to diagnose at EBUS, but for de novo presentations, you often still need a surgical biopsy. And finally, what about the posterior mediastinum? So in the paravertebral compartment, neurogenic tumours form 20 to 25% of all mediastinal tumours, and 90% of posterior mediastinal masses are neurogenic tumours. They are usually not malignant in adults. Around 2% of tumours in adults are malignant. They usually they fall into 3 categories. Peripheral nerve sheath tumours, either schwannoma or neurofibroma, are common in adults, as are paragangliomas, and sympathetic ganglionic tumours are usually more common in children. MRI is important to understand whether there is intraspinal extension, in which case a spinal surgeon may be required to provide laminectomy to enable safe resection. Around 10% of schwannomas can become malignant, and surgery is recommended where the patient is otherwise fit. And this can usually be done via VATS. The top left image there is a patient we had in Oxford who we thought had a thymoma with an anterior mediastinal mass, but actually was an adult presenting with a ganglioneuroblastoma. So although we can learn these compartments and they give us a good idea of what is the likely likely diagnosis. Sometimes within the mediastinum, you do see tumours out of the compartment that they're meant to be in, and sometimes very rare tumours. So in summary, it's important to have an understanding of the anatomy of the mediastinum, to understand how compartmentalization allows you to narrow the likely range of diagnoses, and how understanding the individual pathologies in these patients will help you appropriately biopsy, diagnose, and treat these patients. We often need to palliate these patients with stents in order for them to receive the radical treatment that may provide a cure. Thank you.
Thank you very much, Elizabeth. Again, we are indeed eating into the mediastinum seminar, but this is where we will take on all this discussion, hopefully, and apply all this into real life cases. We still have another talk before that by Mr. Apo Nakas, who's the lead cardiothoracic surgeon at University Hospitals Leicester. Again, I'm privileged to have been trained by him and watch him do a lot of mesothelioma, EPD surgery. He definitely has made a name for himself in this surgery, being one of the highest recruiters for Mars-2 trial. And I can't think of many better people to talk about the pleural malignancy. Over to you, Apo.
Thank you. The only disclosures I have is that I have been part of the working group that developed the British Thoracic Society mesothelioma guidelines, and I do support surgery for mesothelioma in case somebody's not clear about this. I will be speaking about pleural malignancies, and when we're talking about pleural malignancies, you will not be surprised to know that the majority, to the right column, 58% metastatic non-small cell lung cancer, and non-Hodgkin's lymphoma, 8%. So in most of the cases with the pleural malignancy, this is going to be metastatic right in the primary. From the primary ones, the most frequent one is malignant pleural mesothelioma, which is 28%. Then you have a range of rare tumors, and at the bottom of the left-hand side column, you can see that SFTPs make up for 5%. So if you add the two blue of the primaries and the two red from the secondaries, that's more than 99% of your malignant pleural tumors. So the rest 1% for the primaries can be primary adenocarcinoma, which we say that it's the most frequent from the very rare ones, and which occasionally we see, but it's difficult to differentially diagnose from metastatic lung adenocarcinoma. It can be a desmoplastic tumor, blastoma, synovial sarcoma, and then angiosarcoma, hemangioendothelioma. And from the secondaries, obviously, we know that breast cancer, leukemia, melanoma, liposarcoma, and thymoma will spread to the pleural cavity. So to keep it simple, we're not going to deal with the secondary ones, and we're not going to deal with the very rare ones. We're going to deal with the ones that compromise the majority of the primaries, starting from the less frequent solitary fibrous tumors of the pleura, or SFTPs, as their nickname. So SFTPs were first described in 1931, and for a long period of time, there was confusion between what SFTP was and what mesothelioma was. So sometimes SFTPs have been called benign mesotheliomas because they had a different biological behavior. They were not diffuse, and because they were, and the patients lived longer, and because they were not diffuse, sometimes they were also called localized mesotheliomas. Nobody really knows, before the introduction of flow cytometry for the diagnosis of SFTPs, how many of the mesotheliomas were SFTPs or the other way around. SFTPs can occur everywhere in the body. They make up for less than 2% of all soft tissue tumors and less than 5% of blood tumors, as I said. Up to 2005, there were only 900 cases reported in case series in the world literature. The peak incidence is of the 5th to 7th decade of life. There's no association with environmental exposure, and 30% will occur in the pleura, 30% in the abdomen, 20% head and neck, and you can also have meningeal SFTPs. If they present, the most common paraneoplastic syndrome they're going to cause hypoglycemia, so pleural mass with hypoglycemia, think of SFTPs. That can cause obviously pain, shortness of breath, pleural effusion. The mainstay of diagnosis is CT-guided biopsy, and the main differential diagnosis over this FTP would be with synovial sarcoma or sarcomatoid mesothelioma or desmoplastic mesothelioma. We don't know exactly which ones, or from radiology, we can't tell which ones are going to be malignant and which ones are going to be benign, but there are some criteria developed mainly from England, whose pathologists who developed the first diagnostic criteria for FTPs, introduced flow cytometry, and try to classify them. So we know that if they have more than 4 mitotic figures per 10 fields, if there's necrosis or hemorrhage, if the tumor is large is vague, not necessarily determined accurately. If they have increased cellularity, nuclear pleomorphism, stroma or vascular invasion, then we say they are malignant. But with the exception of the anaplastic solid perifibrous tumor, there's no strict dichotomy between what constitutes a benign and what a malignant fibrous tumor of the pleura. In the risk assessment for recurrence or metastasis, we know that incomplete resection has an increased risk of recurrence, subsequently metastasis. If you have metastatic disease presentation, then it is likely that even if you resect the bulk of it, it's going to recur. If the tumor size is more than 10 centimeters, if you have high mitotic rate, or if you have tumor necrosis. So when you apply the England criteria, and that was a large series of 233 patients, 55% of the patients with malignant fibrous tumor eventually died from the tumor. The Pleural had another classification based on a series of 88 patients, by which pedunculated tumors only recurred in 2%, whilst the sessile malignant tumors recurred in 63%, but that was the risk of recurrence based on the morphology of the tumor. So in localized disease, the aim should be R0 resection, and if you resect completely, the 5-year survival can be as high as 86%, the 10-year 77%. There's no evidence that any adjuvant treatment is effective, and I'm not aware that any palliative treatment is effective for that. And that's the SFTPs, which is the second most common primary tumor, and now the most common primary tumor of the pleura, at least in the bigger part of the Western world, which is malignant pleural mesothelioma. So mesothelioma is something that has been around for quite some time, and we all now know that it's associated with asbestos exposure, but it took an awful long time for the causation link to be established. So the first relationship of pleural malignancy with asbestos exposure was first recognized in 1906 in textile workers, and it was 1920 that Dubreuil first used the term mesothelioma to describe pleural malignancy. It was not until 1986 that a famous paper by Wagner demonstrated the epidemiological relationship between exposure and mesothelioma. And it was not until 1992 that Clerk and Armstrong reported the significance of the type of asbestos fiber in the development of disease. And if you think that 1992 is ancient times, and 1992 is when I qualified, I graduated from medical school, and also 1992 is when asbestos was banned in the EU from the brake pads. In 2002, we were registering 563 new cases every year in the UK. And at the time, and at the turn of the century, we're saying that the annual number of mesothelioma deaths has increased from 153 in 1968 to 1874 in 2003 and to 2,500 in 2014. So you can see that there's a discrepancy in the numbers of the new cases that were registered and the deaths from the disease, because in most of the cases, the new registrations are very, very closely associated with the deaths, as the 1-year survival of the disease for all comers is 40% or less, according to the National Mesothelioma Audit. All the projections, and these projections are largely by the health safety executive, is that the disease will peak at around about 2,500 deaths per year in the UK until 2030. And to illustrate the problem that we have in this country is that in the US, they register the same number of cases with a population which is 4 to 5 times larger. In the Western Europe, the projection is that over the next 30 years, we're going to have 250,000 deaths from mesothelioma. And we know that it is associated with asbestos fibers, and especially the amphibole fibers, which can cross the lungs and cause whatever they cause into the pleura. We know that blue asbestos is worse than anything else of these types, but we also know that white asbestos can cause it. Some people say because it is contaminated with asbestos fibers, other people say that in itself it can cause it. The serpentine fibers are more likely to cause lung cancer. Mesothelioma can be caused by other silicate fibers, and there's a case of a village in Turkey where erionite is used as a building material, and people are exposed to it from birth. It has a small population. People who develop mesothelioma in their 20s and 30s. But there's another theory about the incidence in the village, that because of the infamy of the early incidence of mesothelioma, there's not much dilution of the genetic pool in the village because other people will not marry into people in the village. So there might be a genetic predisposition to the disease which is contained there. Less common causes can be radiation exposure, beryllium, liquid paraffin, TB pleuritis, recurrent lung infections, shoe industry, petrochemical workers, stone cutters, and genetic predisposition. I certainly have seen cases of frequent pleuritis in many years before mesothelioma. The peak is the 7th decade of life, male to female ratio is 5:1. The 20 to 60 years latency period exists, and it's longer now the lower the exposure was, and can occur in childhood. So as I have just received the request to speed up the presentation, I will quickly show you the epidemiology slides, which show that this was the prediction in 2014 that the incidence would plateau around about 2010. But what happened in reality is that we had a continuing increase, and we think that the plateau is now, and actually the decrease is going to be even longer. Half of mesotheliomas are epithelioid, a third of the biphasic, and 16% are sarcomatoid. Almost always you will need immunohistochemistry to diagnose them. We don't know why asbestos causes mesothelioma. There are various theories. One of them is that it can cause a release of free radicals, which cause damage and hence limitation. There might be overexpression of PDGF, and there was a query about the role of SV40, which was contaminant to polio vaccines in the States, but this has never been established. Symptoms: cough, dyspnea, because of the pleural effusion, chest pain, more rarely anything else that you can imagine from the chest. Most frequently it's going to be diffuse, presenting with a pleural effusion, in rare cases as a localized tumor. Radiologically, the telltale sign is mediastinal pleural thickening, which is a telltale sign of malignant pleural disease. You can have rib crowding, loss of volume, nodularity, or invasion of structures. CT, thorax, abdomen, pelvis is essential in diagnosis and staging of mesothelioma because you will need to stage the abdomen because you can have concurrent disease in the abdomen. CT PET is useful for assessment of distal disease. It's not very useful in assessment of local regional disease, but it can be useful as a prognostic factor if you evaluate the total glycolytic volume of the disease. There is lots of work on that, but we don't have any definite results about this. Thoracentesis can establish a diagnosis with cytology. The problem is that you cannot subtype the disease, and no one will give chemotherapy unless you subtype the disease nowadays. So you will need to have a biopsy. Very quickly with the staging, this is the 8th revision, and you can have the slides and you can go through that, but basically T1 is the tumor in the pleural, T2 is diaphragmatic muscle or lung parenchyma, T3 anything else that's resectable, T4 unresectable, N0 is N0, N1 mesothelioma is what is N1 and N2 in lung cancer, and N2 mesothelioma is with this N3 in lung cancer. So this is what changed the new revision. M is the same, and the stage group is that, again, it will be available. I will not even, we don't have time for that because we're running late. So the treatment options for mesothelioma can be active symptom control, including NIPC, pleurodesis, chemotherapy, surgery, radiotherapy. And other largely not necessarily experimental, but very, very limited treatments like PDT, intracatheter chemotherapy, and immunotherapy. Radical surgery aims to remove all macroscopic disease and deal with microscopic disease with any other modality, and that's what Sugar Baker has dictated back in 1995 when he kickstarted the modern era for surgery for mesothelioma. And then non-radical surgery, you can do it for diagnosis, staging, infusion control, dyspnea control, pain control, and survival benefits. 5 procedures for mesothelioma, 5 procedures that in the late noughties we used to say that we can employ: vascular biopsy, perirectal decodification, non-radical perirectal decodification, extended perirectal decodification, and pleural pneumonectomy. Vascular biopsy, pretty much everyone can have it. Single ports in the line of incision, please, because we have to resect that incision if we do radical surgery. You drain the effusion, you take biopsies from 3 or 4 different areas, and you put in talc. 8 might cause more problems than 3. Minimal surgical insult can be tolerated by most of the patients. You can do radical surgery at a later stage and it's easier, but the median survival is going to be the same. It does not affect the survival of the disease. And if the lung is trapped, it's not going to do much, and talc is not going to do much. Vascular decodification is something which we thought that had a role back at the time. We were doing EPPs for mesothelioma because we could do it in older patients. The EPPs in older than 65 patients had significantly high mortality. It is a procedure which does have significant risk and morbidity. Mortality is around about 5% in many reported series, and it does take a considerable amount of time. The problem is that with Mesovats, the trial, it has shown that it does not really improve symptoms much. It does not prolong survival. The open non-radical perirectal decodification is what is probably being done by most of the people who have a go at mesothelioma, and that means that they don't resect diaphragm or pericardium, they don't try to get an R1 resection, and they aim to debulk disease and re-expand the lung. You can get clearance in very, very early cases. The problem is that, at least to our experience in retrospective studies, this was the disease with, this was a procedure with the worst outcomes. The group of patients had that procedure had the worst outcomes. There is a selection bias to that because the group of patients had the procedure were either infected or they had too bulky disease, making a radical procedure impossible. But again, it does not have great outcomes. EPD, the definition is that removes all macroscopic disease, meaning that you will need to leave no disease that you can see in the chest. You will have to remove the pericardium and the diaphragm in most of the cases. And it spares the lung, achieves macroscopic clearance, has significantly less morbidity and mortality than an EPP. It is more suitable for elderly patients. We know that. We can do octogenarians with that, or people in the who are 80. But it might have prolonged their leak because you do skin the lung from the disease. You do have significant blood loss. Mortality is really dependent on the experience of the center, and there's various mortalities from 1 to 7%. And the selection of patients. The patients need to be fit for surgery. An EPP is what has been used 10 years ago, and has gone largely out of fashion, still used by a few people. People claim that if you have very bulky disease, you need to do an EPP, otherwise you will never get clearance. I have a different opinion to that. The problem, the advantage of EPP is that you leave an empty shell, so you can give very high dose of radiotherapy to treat the residual disease, and this is what we've done in the original Mars trial. The problem with that also is that you have a very high risk of late BPF, as we have seen in the Mars trial. The disadvantage is that the mortality and the quality of life makes it pretty much prohibitive. So I will skip the trials because we don't have much time. I will just briefly mention that for Mars 2, we have completed recruitment. We are on the complete first year of follow-up. So at some point, summer of 2022, September 2022, we expect to have the results. We will stop the follow-up and we'll start study analysis of the results, and then we will see. I don't have any inside information. I can't tell you if surgery for mesothelioma, if EPD is indeed beneficial for patients in the Mars 2 trial. I can tell you that we do not have significant adverse outcomes, otherwise they would have stopped us long before we completed the 283 patients. So Hazem, I think I shall stop here trying to catch up. Is that all right?
That's yeah, I mean, we have not been fair to you. This is a topic that you can never give it any justice in that allocated time, never mind cutting it even shorter. But I am keen to get the delegates some experience in the breakout rooms for the thoracic seminars, which you are, I believe, taking part in some, which is going to be around the mediastinum. And one a couple of points before we go, you will suddenly find yourself transported, if everything works well, into your appropriate breakout room, where you will have mostly 2 members of the faculty. These are meant to be interactive, similar to the morning session, even more. It's all about the delegates talking. You will be given the opportunity to put your hand up. You have paid for that in part of the course, so please take the full advantage. Get practicing to talk about the cases for the exam. This will apply for everything else. I'm not going to talk much about it, but this is a huge effort has gone into trying to recreate the seminars that we had in the live sessions, and if it all works well, I think you will have good experience if you volunteer. Otherwise, you will be picked on. Well, we'll see you virtually in the room next door in a minute. One more thing, sorry. I think we might overrun for about 5-10 minutes over the 2:30 to allow more time for discussion, which will eat into lunchtime. As much as I hate doing that, I think it probably the delegates might like it. So let's do that now. Let's go to the breakout rooms. People are disappearing, but not everybody. Join in breakout room 4.
We can't make them join. We've allocated. They have to join for themselves.
It's saying join in breakout room. I'm not.
I cannot hear you.
Here we go. Who is with me in breakout room 4? Oh, Elizabeth.
Mr. West, I cannot hear you.
Right. Yes, I'm here. I haven't got a headphone with me. Right, let me try to go into a different room. I should have. Right. Yeah. Great.
Mr. West, I cannot hear you. Are you running?
Right. So I've just. Okay.
It is what it is.
Hi, Apple and Elizabeth.
Hello.
Hi. Right. I think you've done this last year. Yeah. Let's see how we can do that. And if you need any help, let me know.
The good thing about this is you don't need to wait to arrive in the room.
Yes.
Transport it to your room.
Well, it worked better than last year where we had the random assignment. This time is everyone should be assigned. My breakout room 4 is what level again? Is the right? So we've got, I think, the majority of our group are, if I'm right to say, ST3, ST4 level for the people who've actually put their levels over. But I think it'll be useful for the delegates who are on and listening. Whoever may not be ST3, ST4 and has got an exam coming, I would strongly recommend you put your hand up so we can pick on you and give you the opportunity. Other than that, I guess whoever is keen to take a plunge, please put your hand up. Otherwise, we will be randomly picking on people.
That's right, and I can see we've got junior fellows, ST1 foundation here, doctors and cardiac, I think advanced clinical practitioners, but we want everyone to join in, whatever level.
Right.
So we'll try to get us back onto the right. Yes,
that's Alan's list, but use it for now if you want. That's your group.
What did you want to say?
Who, me?
No, I've got there's someone with a hand up, to start with.
Right. Are you able to unmute yourselves?
Oh, I've got a message on the chat. So you are.
Yes, you should be in the room.
Yes, don't worry. We can run it at all levels.
Yeah, you should be in the room. You probably, as a senior cardiac trainee, you're going to be taking the exam. And please unmute yourself and speak.
Oh, okay. Thank you very much. It's just I didn't understand if this room was for the other people or for me.
No, you're distributed. Yeah.
I think, Hassan, I'm right in saying that because you're a review course, you're not an exam course. You're not allowed to group people taking the exam into groups, are you? And if you were, I wouldn't be allowed as an examiner to teach on it. So
correct.
You have to mix the lessons.
That's correct. And it's not an exam endorsed question. It's just to practice talking to your colleagues, maybe, and your senior colleagues. And it's the skills that you would carry on with you. Definitely it'll help you in any exam you take in, not the FRCS, not the European board or whatever, but it'll help you throughout. Okay, I'll leave it. You've got some cases, Elizabeth, that are.
Yes. And I will answer. I completed some outstanding mediastinal questions in the chat. I will get to those, I promise, and I'll just share my screen. We've got some images for this mediastinal section. While I find
Gustavo, are you taking any? Where are you? Are you cardiothoracic? Do you have? I know you're senior cardiac fellow. Where are you based?
Hi, I'm based in Bristol.
Okay.
And I'm hoping to take the exams next year.
Okay, I think get ready for some fun then. We'll pick on you. Mohammed Musab, I see your hair. You're probably going to be next if you don't put your hand up.
Okay, Mr. Bell, I can hear
you. Right, can everyone see that first image?
Yes.
Yes, okay. So I'll start with case one. And so this is a 62-year-old patient who's a forensic scientist who presented with cough, which resolved with antibiotics. But because of that, she'd undergone a CT scan. So, do you want to pick on people if you on the list, or
no? I think we've got. Yeah, I think we've already
described what we're seeing here.
Gustavo, you're on. I think. Gustavo, you're on. Do you want to describe what you see?
Thank you. So yes, so we're here. We're seeing here plain contrast CT thorax, and what immediately comes to catches your view is an anterior mediastinal mass. It seems to be in front of the aorta and SVC. Some calcification in the mass as well.
Yes, that's correct. There is calcification there. So, and that's what the report said. The report said the patient's got some right middle lobe and some upper lobe bronchiectasis, and that probably explains their chest infection symptoms. And they said there's a 3.9 by 2.4 centimeter anterior mediastinal mass with a degree of cystic component and calcification. So what do you think is the likely differential diagnosis?
So one thing could be at thymoma.
Yes.
And
why would you choose thymoma first? Why do you puncture thymoma?
I think because of the location. Second, it's probably the most common tumor in that location.
Yes.
And also, it looks like a well-defined mass.
Yes, so I agree. If you can't see a scan and someone says there's a tumor of the anterior mediastinum, then you should choose thymoma, shouldn't you? Because that's the commonest tumor you see in the anterior mediastinum. And I know that it remains, doesn't it, in the differential here. Is there anything about this that doesn't usually fit with thymoma? Something about this that we don't normally see in thymoma? You mentioned it already.
So that it's well-rounded, well-defined.
And something else you said.
The calcification?
Yeah, it's calcification. You don't usually see that, do you, in thymoma? But either. So what would you do next?
Okay.
What do you want to ask? Shall we ask someone else? We've got lots of people here.
Sure. I mean, another differential would be a lymphoma.
Yes. So what are all the possibilities of an anterior mediastinal mass?
Someone is helping me. Someone raised in the chat to check for the tumor markers.
So far we've got thymoma and we've got lymphoma. Does anyone else want to say what are the other possibilities of an anterior mediastinal mass in terms of differential diagnosis? Sorry, I didn't catch that. Say that again. Yes, the teratoma. Absolutely. That's right. And it doesn't, it could be a thyroid, it's not connected to the thyroid cancer that you can get above it. You can get separate thyroid tumours that are disconnected in the anterior mediastinum, but that's pretty rare. So we think this is either a thymoma, a lymphoma, or a teratoma. So what other investigations should we do, or should we do any other investigation? Should we just decide to remove it?
I think we should look at all other possibilities, as you mentioned, the differential diagnosis, doing blood tests to see the thyroid level, the calcium level, the BTH level, do the blood for tumor markers, AFP, BTHG.
Yes, I agree. And all of those were normal.
Looking to if there's any chance we have a biopsy, CT-guided biopsy if possible.
Yeah, so if you remember from my talk, I had 3 other types of investigation. I had biomarkers, other radiological investigations, and then biopsy. Right. Are there any other radiological investigations you might do in this patient before you decide whether you need biopsy?
PET scanning as well?
Yeah, so you can get a PET scan. There's not an awful lot of disadvantage in getting a PET scan because we can see this is slightly unusual. It's not entirely fitting into absolutely sure of the diagnosis. So I think a PET scan is a good idea. So hit PET scan. So does someone else want to tell us what this PET scan shows? Don't know, Apo or Tazam, can you pick someone from the list? Have you got the list of people in the group? If not, I have. So we've had Gustavo Guida. So have we got Mohammed Azmi? Mohammed Azmi, have you joined us? I can see you there. I can see you're there. Can you say hello? No. Okay.
Hello.
Oh, hello.
I didn't catch the question.
That's all right. So we've just seen this CT
Right, everyone. To go back. Right, everyone. Thank you very much for joining us for this morning. It's obviously lunch session, and get ready for a loaded cardiac afternoon. We'll see you tomorrow afternoon for more thoracic.
Are you good?
Good day, Mr. Fallu.
How are you?
Afternoon, Richard. That sounded bad.
Oh, you can't see us because we're on the epicardial valve at the moment.
Oh, no, you can't see us.
We're the epicardial mitral.
So when are we going to
Good afternoon, Mr. Sten.
Good afternoon, Omar. All going well? Oh, you're on mute. Hi, Clive.
Can you hear me now?
Yeah, I can hear you. Going well, I think.
Yeah, everything going very well.
You've got to have your laptop muted, Omar.
Hi, Clive. Two computers open in the same room, naughty boys.
Yeah, I know. I noticed. Sorry about that. So we're only live streaming it to YouTube as well. So
Might be really good. Tomorrow and Saturday as well.
I'll be around for tomorrow. So.
Yeah. All right. Okay. Great.
Good afternoon, Richard. Good to see you again. I hope
It's good to see
your
you,
hand
John.
next time we do this.
Delighted to see you. You see, they've been missing not having me there running the tech side, I hope. Actually, I believe they've been doing quite well without me, unfortunately.
I often say to my colleagues, leaving middle-aged men alone with technology is always a bad idea.
Because the whole rest of the team is here. And tomorrow,
Tomorrow we'll come back in the afternoon, maybe?
no. Yeah, the first session, the whole of the first day till night.
Yeah, we'll have to come back tomorrow because Les is still on chair.
Actually, we got an extension.
Yeah, he's on.
We have an extension. It's a very small one. And we are running a speaker system.
For today.
Charge my other one, the reception.
What we need to ask them.
Yeah, where did you answer this one?
Reception.
Put it to medical engineers and get them. Okay, okay.
And if we go, then we need to ask live and who will be letting the people in and if we need it.
Guys, your mic is still live in the education center.
Thank you, Mr. Stone. We'll just unmute it, Stone. Thanks.
Okay. Feedback there.
Sorry. Good afternoon, everyone. Welcome to the afternoon session of the 2021 Birmingham Cardiothoracic Review course and the first cardiac session. So this session is on something which all trainees, delegates need to know about, coronary artery disease. I'm delighted that we've got 3 speakers and we'll have 5 members of faculty forming an MDT. And I'd encourage you to ask questions. If you're asked questions, then please answer them. If you have any specific questions which are burning as you're ongoing, then please enter them to the chat. We're grateful to CTSNet for the advertisement that they've given us, and this session is live streaming on CTSNet at this moment in time and will be available online. So in this session, we have Siddhartha George, who is a consultant interventional cardiologist at the Queen Elizabeth Birmingham, telling us about how to investigate the patient with coronary artery disease. Mr. Michael Lewis, who is a consultant cardiac surgeon from Brighton, who will tell us in a very short space of time what to do with the guidelines. Umberto Benedetto from Bristol, who's going to talk to us about conduit. And following that, we have an MDT with those 3 members, Saib Kigali, who is a consultant interventionist from Wolverhampton, and Eshan Sinanaika, who is a consultant cardiac surgeon from Birmingham. So without further ado, welcome to everyone. And Siddhartha.
Aaron, thanks for that. So let me just share my screen. So hopefully you can see that, Aaron.
Yeah, I can see that.
Okay. So this is Mason Soanes, who did the first coronary angiogram about 70 years ago. So he's a pediatric cardiologist, and that first picture is a right coronary artery that that he's injected, and which is the first recorded coronary angiogram. And apparently he first did this inadvertently whilst trying to do an LV-gram. But anyway, moving on to the title of the talk. Aaron was very specific in that he didn't say investigation of the patient with chest pain or investigation of an outpatient. It was investigation of coronary artery disease. And I took that to mean people where we know they have coronary artery disease and possibly where we're planning intervention. So most of the talk is going to be just about coronary angiography and what we do in the cath lab, the normal views, if you like, what the vessels should look like, and then some of the pitfalls that I've come across in the last few years, as well as a quick case for someone to have a go at, and then some of the limitations of coronary angiography. I have a small amount on pressure wire assessment and some intravascular imaging, and then finally just a couple of slides on CT coronary angiography. So this is the cath lab setup. I think many of you probably have been called down there in an emergency situation, but usually the patient's lying on the table in the middle. We can see the screens and the physiology. The X-ray source is underneath the patient, and then you have an image intensifier above the patient. And we hear about some standard views, and people talk about cranial views or caudal views. And in that top cartoon, we can see that in a cranial view, the X-ray source is actually going towards the tail, towards the patient's feet, whereas it's the image intensifier going towards the head. But that's a cranial view. And below that, a caudal view where the X-ray camera and the intensifier move in the opposite direction. The other thing you'll hear people saying is a PA, which is that shot in the middle where the X-ray is directly below the patient, and then either RAO, which is the picture on the left, or LAO, and we can see the directions that the camera moves in those situations. Just move on. So in terms of the coronary arteries, as you all know, but a very quick slide on it, there's a left main stem, which arises from the left aortic sinus, and this supplies 70–80% of the blood supply to the myocardium. And it's made up of a left anterior descending artery, which gives off some diagonals and some septals, and a circumflex artery, the branches of which we call obtuse marginals. In the caudal view, so first we have an RAO caudal there, then a PA caudal and an LAO cranial. In these caudal views, the left main stem is seen very clearly, as well as the proximal LAD and the circumflex artery. The caudal views are less good for the mid LAD, less good for the distal LAD. And for that, we tend to take the cranial views, which show us the LAD very clearly and also show us the branches, the diagonals and the septals. The right coronary artery, in the majority of people, is dominant and supplies the inferior surface of the heart. It supplies perhaps 25–30% of the total blood supply to the myocardium. And the standard views for the right coronary artery are an LAO projection. This is a PA cranial projection, and then the RAO projection. So the LAO projection is good for the proximal and the mid body of the right coronary artery. It's less good for the PDA, which usually is best seen in an RAO projection. And then that crux and the bifurcation of the PD and the PLV, usually they're separated best in a PA cranial or a LAO cranial projection. So in terms of some cheats for what you should look at when someone shows you a non-selected angiogram, the spine and the catheter, as well as the diaphragm position, can help you to orientate the view if the computer hasn't already got it in there for you. So in an LAO shot, the spine should be on the right of the image, whereas in an RAO projection, the spine is on the left. And importantly, in a cranial view, you can usually see the diaphragm. So it's really important, if someone has shown you a coronary angiogram, that you ask to see, if someone shows you one picture of an LAD or an RCA, it's very difficult to comment because you need to take orthogonal views, because if you have an irregular lesion, otherwise, if you don't take two orthogonal views, you can be caught out. And this diagram from the publication cited shows that, if you have a straightforward spherical kind of lumen with totally even atheroma, then one shot is enough, and one shot from different angles is going to show you the same thing. But that's rare in real life, and very complex shapes. Actually, sometimes you can never find a projection that shows you how bad it is. The general advice is that if you've seen something in a couple of different views, the one where it looks worst is probably the most realistic for the coronary artery disease. In terms of the things I've been caught out by, certainly as a registrar and even as a junior consultant, someone else has taken the pictures and the arteries look very small, or there's an apparent lesion. Did they give nitrates prior to instrumenting the coronary arteries? The other thing is osteal lesions. Sometimes your eye is drawn away from where the catheter is engaging the coronary, and you can miss them, especially if you're not the one who's done the coronary angiogram. So if you are doing the coronary angiogram and you're looking at your catheter pressure carefully, you might see some damping of the pressure or ventricularization of the pressure, which would be a clue that there might be a problem at the ostium. The other thing that can be helpful if you suspect an osteal lesion is to disengage the guide and take a non-selective picture, which often, especially for the left main stem, can show you osteal disease. The other thing is in the mid-LAD, occasionally you get myocardial bridging, perhaps with a little bit of atheroma, that can masquerade as disease that isn't as significant as it appears. And finally, and importantly, very occasionally we see people with aberrant coronary arteries. And the important thing when you're looking at coronary angiogram is to make sure that you've convinced yourself that every territory has an adequate blood supply. So this is Aaron, if I can ask you to pick out a delegate. This is a picture I took a few years ago as a registrar. I don't know if any of the delegates can be picked out by you to comment on it.
Yep. So unless anybody wants to chip in, could we have Mr. Higgins, Patrick Higgins? Are you there?
Yep, I'm here.
Fantastic.
So it's RAO. It looks like there's disease in the proximal circ. It's kind of hard to see because it's speeding along.
Any other problems, do you think?
Yeah, I'm not sure what is that a single lead for a pacemaker?
Yeah, I mean, it looks like a defibrillator. And Dr. He was one of my trainers when I was at New Cross. I don't think I did this there, but this is at Stoke. And can you see here that the guide catheter is pointing up into the roof of the left main stem?
Oh yeah, so it's non-selective, is it?
Well,
it's not cannulating well.
Yeah, it's not coaxial. So I should have put back on the catheter and engaged the left main stem properly. So what I've done here is dissected the ostium of that left main stem with my catheter. So this is an iatrogenic dissection. So I did, one of my surgical colleagues did come down and said, look, you probably should just treat it with an angioplasty. So we did put a stent in, but it's just, clearly the things wrong here are my catheter's pointing into the roof of the left main stem, and I was not paying enough attention to the pressure trace. And if I had been, I wouldn't have injected there. So again, you probably are not, or many of you are not going to be in the cath lab when they're taking the angiogram, but the pressure is really important. So on this left-hand diagram, the purple line, the pressure trace there is initially how it should look. That looks like an aortic trace. And then here, it's suddenly ventricularized. And usually that's because your catheter's dived into some disease or there's some osteal disease that you're into. And then over here on the right, this pressure's damped where the pressure trace is not right. And the cause for this can again be osteal disease or disease that you've poked into, or it can be things like thrombus in the catheter that you have not flushed appropriately. Okay, I'm just going to go show a quick case. This is someone I treated a couple of years ago. A quick case. I'm going to show the initial angiogram. And again, Aaron, if you could pick someone else out to have a look at all the pictures and then comment. So this is a 56-year-old man. He's got some cardiac risk factors, so he's hypertensive and he's known to be a smoker. And he's phoned through by the paramedic team with clear inferior ST elevation. So he was loaded with aspirin, and I think at the time it was clopidogrel. The ECG, I think, convincingly shows some inferior ST changes, and there's also some reciprocal anterior depression. So this was the shot of the right.
Okay, I think Aravinda Page, are you there?
Yes, Mr. Ranasinger. So this is a LAO view of the right coronary artery. It seems to show a subtotal occlusion of a chronic total occlusion of the right coronary artery proximally.
I mean, you could think that, but actually I think this is just a recessive right coronary artery. So I think this is the whole vessel. I can see why you think it's an occlusion, but this is, there's no PD here, and it's just a recessive right. So in this situation, what would you then expect?
So I'd like a different view as well, but then also to look at the whole series of images looking at the right. But in this case, you'd look for a left dominant system.
Yeah, so I did take obviously an orthogonal view, but I haven't. I won't waste your time by showing it to you. But just to say, it was a recessive right, and then this is a shot of the left system. So tell me when you're happy, and I'll move on.
Yeah, you can move on.
We'll move on to the next one. And this is an LAO cranial.
Do you have a non-selective shot as well? Or?
I don't. What are your thoughts so far?
So it was difficult to see a true takeoff of a circumflex artery. So just to see the...
Yeah, so that's absolutely right. And that was my concern as well. So this is not a very long left main stem. This is all just LAD, and we don't actually see the circumflex. And you asked for a non-selective shot. We can see contrast here in the coronary sinus, and you can see there's no circ coming off there. So actually, this was an unusual case where the circ came off. There was a dominant circ that came off the right coronary sinus, and that's occluded proximally. And then after treatment, this is how it look. So it was a massive dominant circumflex that came off the right coronary artery. But exactly as you noticed, every bit of the myocardium should have a blood supply. And there was a big, infralateral wall in that last angiogram that I showed you, which didn't have an apparent blood supply. So well done. So just quickly moving on to the limitations of coronary angiography, you get some good anatomical information, but you have no physiological information as to whether, a lesion which might be moderate, so maybe 50 to 70%, is significant or flow limiting. You can assess that non-invasively, so a patient could have a myocardial perfusion scan or a stress echo or a stress MRI, or you can assess it during the coronary angiogram with a pressure wire assessment. Occasionally, you also find that, especially if the lesion is complex or if there's a lot of overlying vessels, that you don't quite see the ostium of the LAD or the takeoff of a diagonal. And in that situation, intravascular imaging can be helpful. Finally, as all of you have probably sat through multidisciplinary team meetings where there is just variation of opinion as to whether a lesion is moderate or severe or moderate to severe, and because it's a it's a subjective visual assessment, you rarely get different people agreeing on absolutely every angiogram that they assess. So quickly on pressure wire assessment, because it's talked about relatively frequently at our MDT, and I'm sure at MDTs around the world. So an FFR, or a fractional flow reserve, is essentially it's looking at pressure as a surrogate for coronary blood flow, and the mechanism by which we do that is relatively straightforward. So there is a pressure sensor in the catheter, and then there's a pressure sensor in this top left-hand picture. That's the guide catheter engaged in the left main stem. That opaque end of the wire is a pressure wire, and the proximal end of that wire also has a pressure sensor. So initially, where the catheter and the proximal end of the wire are next to each other, if there's no lesion between them, where here there shouldn't be, then the FFR will be 1.0. If there is a lesion in the LAD and you move the pressure wire distal to the lesion, then if the lesion is causing an obstruction to flow, that FFR, the fractional flow reserve, should come down, particularly when you induce hyperemia with an infusion of adenosine. We tend to use 0.80 as the cutoff for significance. So if it's over 0.80 on an FFR, we would say that's non-significant, whereas if it's less than 0.80, then on a pressure wire assessment, that's significant. More recent technology, and you may have come across this, is instant wave-free ratio, which is a way of, again, a pressure wire assessment, but without the need for maximal hyperemia, so without the need for an infusion of adenosine. So here, this is an obtuse marginal branch with a couple of serial lesions, and they have positioned, or I haven't added the picture of it, but they've positioned an IFR distal to the lesion. And on the IFR, the cutoff's a bit more arguable, but we use 0.89 as a one-off cutoff. And then finally, a little bit about intravascular imaging. Sometimes you'll just get a lesion, whether it's the ostium of the left main stem or an ostial LAD, where you are just unclear from the angiogram just how significant it is. So you may have a distal left main stem, which however many angles you use, you just can't show it clearly. And in that case, intravascular imaging, either with IVUS or OCT, can be helpful, because there you can measure the area and use different cutoffs. But for example, if a distal left main stem is less than 6 millimeters squared, if the effective orifice area is less than 6 millimeters squared, we would say that's significant. OCT is a later technology, and it's, as you can see here, it's a much more high definition. They each have their pros and cons, and most cath labs would have both available, and different imaging modalities can be better in different situations. So this lesion here that we're looking at, this is a calcified lesion, which on the left we can see on OCT, the calcium just looks like a dark shadow, whereas on the IVUS it looks very bright and easy to see. And in both cases you get artifact behind the calcific lesion. And then finally, just a couple of slides on something that we're certainly using much more at our hospital, which is CT coronary angiography. Unfortunately, the pictures are rarely as clear as this. So this is a slim model who's able to hold their breath and, you know, has an appropriate heart rate. But certainly in outpatient investigation of non-selected patients with chest pain, CT coronary angiography is used preferentially to invasive coronary angiography. The advantages of CT coronary angiography are that although it does, of course, use contrast and radiation, it's non-invasive. So there's no risk of death or a stroke or an MI, which I have to quote every time I do an invasive coronary angiogram on someone. The other times it can be useful are if someone perhaps has a chronic total occlusion of the LAD or another vessel, and you're not sure if there's this distal target. And CTs can be very good at identifying the size of the distal vessel and the anatomy of the distal vessel. Again, more recent technology, you can also, using some complex maths, do FFR measurements on a CT scan, which currently we don't have available in-house, but we can send it to a company called HeartFlow to assess it. The disadvantages of CT coronary angiography that it's limited by heart rate. So if the heart rate is very difficult to control, then you get a lot of artifact in the images, and quite often they're not diagnostic. The rhythm can also, particularly in the older generation of CT machines, the rhythm can also be important. And if someone's in atrial fibrillation, then it can be very difficult to analyze the images. And also you need a relatively cooperative and patient who's not too unwell and who is able to hold their breath when they're asked to. Clearly, you also have radiation and contrast, as you do with CT, as you do with normal invasive coronary angiography, and intravascular imaging isn't possible. And again, maybe we can explore this later during the MDT, but certainly it's very good at ruling out coronary artery disease. And I think our unit, if a CT showed possibly significant disease, we still tend to do an invasive coronary angiogram if the surgeon is considering bypass grafts. I think I've just about finished on time. So I don't know if anyone's got any questions, or Aaron just wants to move on.
Okay, Delegate Soon. This is your course. This is your chance to ask questions from Dr. George. Has anyone got any questions for him? Raise your hand, put something in the chat if you'd like to. I've got a question, Sadaka. Something which I always found very confusing when I was a trainee was the concept of ventricularization of the trace. Can you explain it for a surgeon?
Yeah, I mean, it is. Firstly, it is not a very technical. It is not very technical, and you're going to be very disappointed in the answer. So, sorry, let me just go back to the appropriate. So, on this screen here, on the cartoon on the left, that purple line on the left is a nice aortic trace. Whereas this purple line, even though the catheter is not in the ventricle, it looks like it's in the ventricle. So that's all people mean by ventricularization of the pressure. It's that the guide is not in the ventricle, but it appears as if it's in the ventricle.
And I'm going to take the opportunity to ask Dr. Kagalia a question. I'm not, because Mr. Page has got his hand up and he's paying for this. So Aravinda?
Just a quick, thanks, Dr. Just a quick question. I don't have much experience with IFR, but from a surgical registrar's point of view, what do we need to know about IFR and when IFR would be indicated over FFR?
Well, IFR, the benefit of it compared to FFR, there's a couple of things. One is that you don't need an adenosine infusion, and quite often in terms of the cath lab, it can be then quicker. The other thing is it can help you to separate serial lesions. So, for example, one of the problems with FFR is, say you have a lesion in the proximal LAD and a lesion in the mid LAD. All you can say, actually, if you put the pressure wire distal to the more distal lesion, is that in totality, those lesions are significant. My personal practice in that situation with serial lesions when I was using FFR was you would put the pressure wire distal to the distal lesion, and then you would treat the one that you think is more severe, and then you would re-pressure wire to see if the other one is still severe or not. Whereas the IFR, you should be able to, by pulling back and looking at where you are in relation to the lesions, assess each one independently.
Thank you.
I was going to ask Dr. Kikali a question. Saib, how much do you use FFR and IFR at your institute?
Yeah, we use it quite frequently. I don't know if you can hear me. Can you hear me all right? Yeah.
Yeah, I can hear you fine.
Yeah, we do use it, and I think, as Siddhartha said, actually, you've got borderline cases where even angiographically, you're just not quite sure. And I think what we do know is stents work, but you also don't want to put a stent in if you don't need it. I think the important thing is not to be fooled by, if you're using the FFR, that's not, and you've got a lot of disease in that vessel, you're treating the tightest one, and then you're going to reassess, which is important. I have to say, IFR we do use as well. We've not used it as much, and at times it's been misleading. I don't know if you've seen this, Siddhartha. Sometimes it's been misguided, misleading. I don't know what the word is really, and I think others have experienced this as well. So sometimes it can be difficult, and I think we're learning about it. It's much more in vogue now. We're using it more, and I'm sure more papers will come out about how to use it more consistently and reliably. But FFR is really helpful. It's very easy. I think the point about the adenosine, as Siddhartha said again, it's quicker without it using the IFR. And also from the patient point of view, they get chest pain, they get breathless and so on, but it's pretty well proven, it's pretty damn good. And sometimes I just resort to that rather than the most modern thing, because the most modern things confuse me.
Yeah, and we're with you, Saib, in that our hospital, we don't actually have IFR, we have RFR, which is a different brand from a different maker, but which does have less evidence than the IFR. So actually we have a low threshold, even if they've had the RFR measurement, because it's on the same wire, to then start the adenosine and see what the FFR is. And there's quite if you use the official cutoffs for IFR or FFR, it's quite a big gray zone of like 0.86 to 0.93, where you're supposed to then use adenosine anyway.
You've got a couple of questions on the chat, Siddhartha. How do you differentiate between atherosclerosis and thrombosis?
Well, it is, sometimes it can be difficult. I suppose there are typical angiographic appearances, but this is where intracoronary imaging, particularly OCT, can give you much more information. So, if you want to see if there's an acute plaque rupture with some thrombus adherent to it, then you'll see that on OCT. And of course, there are, you can, I suppose, guesstimate on the angiography, but, even experienced people, I've seen them get caught out where something you think is thrombus, actually you try and balloon it, it turns out to be calcium. Whereas when you image it, then with either IVUS or OCT, you get much more information.
Okay, and so when is IFR unreliable?
So IFR, I suppose, unreliable in terms of, as Saib said, occasionally you have technical issues, but I suppose there's a big grey zone. And also, as someone has pointed out, I think it's Yasser who works at our hospital, with Ripcord 2 trial results where we see less use of FFR. And, I guess this is an ongoing debate in cardiology and cardiothoracic surgery, whether it's ischemia or atheroma burden that requires treatment. And, with FFR, we're looking at ischemia, whereas with coronary angiography, CT coronary angiography, I think the most recent kind of direction of travel is that actually, as we have probably known for a while, total atheroma burden also predicts outcome. And actually people with, even if your FFR of your LAD is negative, if you have a long segment of, atheroma, then you may well benefit from a lima to the LAD. I don't know what you think, Saib.
Yeah, no, I agree. And I think the hard thing, taking away the technical difficulties, which we may all have experienced, I think the hard thing is it's a relatively new technology where if you're not sure, you said it already, Siddhartha, you go and check with an FFR anyway. So I don't think we're there where, you see a lesion, which let's say you think it is significant, but we're going to check it out. And then the IFR isn't quite right. So, well, actually, is that really right? And then you go to the FFR. It's not the unreliability, I suppose. It's more trust. We're more trusting of the FFR, I suppose, excluding technical difficulties. So our backup is that. And then if that tells us it's 0.85, for example, fine, leave it. If it doesn't, if it's lower, then you're more likely to go and treat it. So I think it's probably not fair to say, and if the companies were here, they'd probably want to lynch me. But I think it's more, we trust the FFR more. We've used it for a lot longer. We know how it behaves, and it's better verified, I think, well verified.
Okay, guys, thank you very much. We've got a little bit of a technical issue with one of the speakers. So I am going to ask Dr. George just to continue for one moment with a couple of cases whilst we sort out the computer problem that we've got with one of the speakers. So is that okay, Starker?
Yep. Is this for the MDT, Aaron?
Yeah, so if you just press on with the first case and while we sort out the computer problem.
Yeah, sure.
And we'll get things working from there, okay?
Yeah. So these are all genuine cases from the last few years from our own unit. And, you know, I think I've picked out a range of things to try and bring out some different things in the discussion. And we'll tell you what we did, which isn't necessarily what other units would have done. And, you know, I look forward to hearing what Ms. Lewis in Brighton thinks on some of these as well. So the first case is a person I saw in clinic. So they're 62. They've got class 2 symptoms of angina. So mild to moderate exertion. They get, you know, chest pain, which is relieved by rest. Their ECG doesn't show any abnormalities, and their echocardiogram has shown no valvular abnormalities and good biventricular function. So he was on a couple of anti-anginals. So I thought it reasonable for him to have a coronary angiogram. So again, Aaron, I'll show the pictures, and then maybe if you could pick out a delegate to talk us through what they think.
So Dr. El-Shafi from Hull, if you could just crystallize your thoughts.
And again, these are on a loop. So when you tell me that you've seen enough of this, I can show you the next picture if you need to see any more.
Yeah, go ahead.
What are your thoughts so far?
Yeah, so see there is a left main disease involving the ostium of the third and disease in proximal area B and ostial intermediate. And I could see the right is retrograde filled as well.
Yeah, excellent. Yeah, exactly as you said. So it looks like 3-vessel disease, doesn't it? There's left main disease. There's a lot of disease in the LAD, that diagonal bifurcation, calcific disease at the ostium of that circ, and it looks like the right is also occluded. So I think probably seen enough pictures, and as you said, it's a dominant right that's occluded. So what are your thoughts on what do you think they should have?
I was going to ask Dr. Curran from Australia. Are you there?
Yes, I am. Diabetic patient with quite diffuse coronary disease. I would recommend coronary artery surgery for this man. Lima to the LAD, probably vein grafts to somewhere in the occluded right territory, the PDA perhaps, and also the obtuse marginal.
Yeah, so, sorry, go on, Aaron.
So I was going to say, Dr. Farmer, do you agree? Do you have from the US, do you have a different opinion? Would you do anything different in your MDT or have any different recommendation?
I had a little bit of difficulty seeing all of the coronary angiography images, but from what I saw and heard, it looks like, yeah, bypass surgery probably would be feasible.
Siddhartha?
Yeah, so exactly as you said, you know, he's fit, but he's diabetic. He's got multivessel coronary artery disease with a high syntax score. So he had straightforward, well, I don't do the operation, so I shouldn't call it straightforward, but he had surgery that went well. Okay, moving on.
That's okay, Siddhartha. We've sorted out Mr. Lewis's computer problem, I
okay.
believe. So we'll save the MDT till the end.
Yeah, I'll stop sharing.
So Mr. Lewis will tell us about the what guidelines we should be using to decide for treatment for these patients. Michael, have you recovered?
I have, thank you.
No, thank you.
Stressful afternoon, sorry. For some reason, the IT system at the hospital decided just at that moment that they needed to get us into a position where we were, I was unable to log in from remotely to see any of my files. So apologies for the stress. I might be needing revascularization myself at this stage, but let's see how it goes. Thanks to you and to the rest of the organising committee for asking me to talk this afternoon. I'm honoured to be asked back to the review course, having attended it as a trainee on many occasions and then subsequently as a consultant. I think it's a fantastic educational resource for trainees as they move through towards delegates taking, thinking about taking the exam or just brushing up on the knowledge of the specialty. So thanks for asking me along. I'm hoping this is now going to play. Yeah. So I've taken the liberty of just sort of diverting slightly and talking about the exam in general, because as past exam chair, I suspect that folk would want me to mention what it's like doing the exam. This is Daniel in the lion's den. I do think that I recognise that as someone sitting there doing the exam, it feels somewhat a bit like this. You've got the sort of rather grumpy looking one there. That's probably Mr. Graham. Another one here, Mr. Rajesh. All of our old favourites turn up, and I recognise that it's not an easy day out or a couple of days out doing the exam. I thought I'd probably just do 2 minutes on this and then move to the guideline talk. But essentially, first thing I'd like to say is don't ask what should I say in the exam, because the exam is a test of what you would do day to day in your practice. So you're looking at whether a candidate sitting in front of you is safe, and you should therefore, when asked the question, say what you would do in that scenario, whether that's clinic, ward, MDT, etc. You will need to explain why you've decided what you're going to do. Sometimes, it's quite self-evident, but sometimes you will have made a decision that, other people may not have made, but that's entirely reasonable as long as you've got a reasonable explanation for it. And so therefore there are often several correct answers when asked a question, and you just need to explain why you have chosen that particular way of thinking. And it's obviously a chance for you to demonstrate knowledge of guidelines, literature, etc. The questions are always structured. In fact, they always start off with relatively straightforward things in general. They start and then they move up to the more complex. So if you feel like you're being pushed, don't panic. It's the way the structure of the question works, and it should allow you to demonstrate the breadth and depth of your knowledge. And therefore, you need to practice being asked questions under pressure. I've often seen candidates come forward for the exam who clearly, they know it. You can feel that they know it, but just struggle to get the answers across and tell you all about it. And then sort of final point on the exam is, it's a professional exam. It isn't a fashion parade, but you do need to be mindful that you're being examined as a future consultant colleague. So I can now move on to the guidelines talk. Now, this is an enormous task, and thanks to the faculty for asking me to deal with this one. You can see Erin giggling in the background there. So if you go in across the NICE website and look up coronary artery bypass grafting guidelines, there are 76 documents there to look at. This is a 15-minute talk, and there's clearly no way that I'm going to even be able to scratch the surface of what's out there. I've collected together from that website and then from some of the other places around a selection of, I think, the pertinent, up-to-date, relevant guidelines for revascularization, and that is on the Dropbox shared folder, so you should now be able to access that, and I hope that is helpful to you in terms of guiding your reading and knowledge that will take us through to sort of being level of the exam. So just to focus on that, we need to think about what level we are trying to get to. So the exam is graded that you are expected to have the knowledge and clinical skill of a day one NHS consultant. And when the questions are written and devised, there is a rigorous, what we call standard setting process that is referencing that particular point or level of knowledge. So you, to pass, need to achieve that level of knowledge and skill. And if you get more than that, then you will score more highly. And clearly, if you don't make the standard, then you will score lower than the pass mark for that particular question. So that's an important thing to recognize, that we're not expecting you to know the finest and minutest of detail in every single aspect of the curriculum, but we are expecting you to be equivalent to anybody else who's starting as day one as an NHS consultant. And that's an important way to guide your knowledge. So, you know, it's the same as when you've done exams before. It's very easy to fall into the trap of thinking about one particular issue and going into the absolute minutiae of that, but then finding that you haven't covered the breadth, and therefore when you get to a subject that is perhaps not one of your favorites, that you don't actually have the level of knowledge you need to get through the exam. So let's just focus on those main headings and where we might find the relevant data. Since I started as a consultant 15, 16, 17 years ago, it's changed. The way that we look after patients has become a lot more formalized, and whereas previously it was much down to the individual and their decision making, we're now in a position where we, and I'm sure you use the heart team in a structured way, and that has to obviously have some key members of the team within it, which I've listed on the slide there. And often decisions, particularly about in chronic patients who have long-standing conditions that need looking after in terms of revascularization, it's these patients that come to the MDT, the heart team discussion, where you will need to know what the guidelines show and understand why those guidelines are guidelines. They're principles for the management of patients, but what they would help you with in terms of making decisions around how you best care for the patients who are being discussed in front of you. So the MDT is a key part of that, and obviously you need to have an accurate assessment of the patient, not just looking at the investigations, but know about the background for the patient, understand the investigations, make sure that they've been done to a rigorous level. So previously, we would look at angiograms and say, well, that's a moderate stenosis. We now have, as we've heard, lots of tools for looking at the degree of stenosis and what that might mean in terms of prognosis for that lesion and for the patient. Understand who should be discussed within your MDTs and understand why they should be discussed in that way, and then record that discussion well so that you have a clear record of what you not only decided, but what you discussed. For example, where you're going to graft a patient, what targets you're going to consider to try to revascularize. And so to help us, there are some recently published guidelines. This is the most recent document that I'm going to be talking about today, published only in May of this year, a joint publication from all the august societies that are really involved in revasc in the UK. And this is a sort of key document to understand and help us plan and use the MDT to deliver best care for our patients, how we should structure them, what we should do, etc., etc. So that's in your pack of guidelines. Once we've got MDT together, we then need to sort of work out the who, when, how of revasc, don't we? We need to establish the diagnosis, think of the more complex decisions with regard to who needs revasc and when they might need it, make decisions between the various modalities of revascularization that are available, understand the emphasis for surgery towards more complex coronary disease, so multivessel disease, left main stem potentially. have we got a recent myocardial event, an STEMI, an MI that might impact on our decision making? What are the indications with regard to diabetes, heart failure, etc.? And of course, since the last time I gave this talk a couple of years ago, gave a talk on Revasc a couple of years ago, we've had a major change around in that we're now in the world of COVID. How do we regard COVID within the management of our patients? I know that we probably all understand what we would best like to deliver for our patients in terms of care, but at the moment, certainly locally down in the southeast, our provision is markedly limited by availability of facility in terms of ITU beds, ITU staff, theatre staff, etc., etc. And so we're having to make some very difficult decisions with regard to what would be in inverted commas best treatment versus what is available treatment. And sometimes making that balance is difficult, but that again is something where the MDT should be able to help you. And so there is some guidance within the pack that I've given you on how to sort of the impact of COVID on decision making in the modern world. You need to consider revasc in the face of other conditions, so valvular heart disease, peripheral vascular disease, including carotid disease. Redo surgery, revasc for arrhythmias, including sudden cardiac death. And then, as we've already got another talk about it, but around our best evidence on graft choice, and then how we best look after our patients after surgery. So there's lots of guidance out there to help us. And as I say, I've condensed down sort of the relevant stuff into a pack that you will now be able to have a look at. I'm sure much of it you've already seen before. So in terms of the sort of big hitters within that pack, there is the American Heart Association ACC guidance that actually published a while ago now, and I suspect a new version will be along before very long, because this was 2011 and the world has moved on quite a lot since then. So I'm in many ways going to skirt over this one and focus mostly on the most recent sort of overarching guidance, which was published in 2018. As a joint venture between the European Society and the EACTS. And so much of the rest of the talk will be from this particular set of guidelines. This is really the key picture, isn't it? And this is one that I'm sure that you're all very aware of. Who should we be revascularizing, and what's the level or class of evidence that we've got for that? Well, this is pretty much the bread and butter of what we do all day. And so this is the stuff that you need to be aware of and understand and be able to explain what each of these categories mean and what you would why you would make a decision for revasc in these particular cases. But this is really sort of the absolute bare basics of what we've got out there in terms of guidance just now. We've also got to consider things like heart failure. What are we going to do with patients who arrive with heart failure to reduce ejection fraction? What we might consider as best practice for them, how we might look at those. And so there is some guidance within the guidelines which tells us what we should be doing in these patients, how we should assess their viability, etc., to allow us to plan their further treatments. Unfortunately, this is going to be a sort of fairly unconnected scoop through of the sort of the key highlights, focusing on those headlines that I've picked out for you on what we think are the sort of the key aspects and what you might be expected to be asked about in the exam in a few weeks' time. So how might we arrange to assess lesions? Well, we've heard, I think, a little bit about that during my computer hiatus. I'm sorry, I probably missed the absolute detail of that, but I think you've probably touched on that. I heard Sadako talk about his, that he was going to talk about it, so I assume he did. But how we assess those complex lesions where not quite sure, not quite clear what we've got. And then sort of going down into the detail of what we should be doing for each of the, in terms of the different treatment modalities, whether we should be focusing on coronary surgery or PCI for each of the different treatment different patient subsets. Obviously, in general, the more complex the disease, the more multifocal, the more far-reaching in terms of the different coronary territories, the more likely it is that surgery is going to be your better bet. And then with the more straightforward, lower syntax patients, it may well be that PCI is what you go for, but that's the purpose of the heart team, to discuss those things in the context of a patient and not just in terms of an angiogram, so that you've got a far-reaching and overview of the patient, and you can make a plan. As we've probably discussed already, we've got diabetes as a key determinant of treatment modality, and in general, certainly locally down in Brighton, patients who have diabetes and multi-vessel disease, our first thought is for surgery if they are suitable for that. How do we look after patients immediately after their NSTEMI? What do we do? How do we, as a surgeon, you often get served up the patient after the initial management phase has occurred, but you need to understand what's happened before that, how the patient has been graded and categorized, have they been risk scored, have they been put forward for an immediate angiogram because of unstable issues or what. So you need to understand all of that so that you can then help to make decisions with regard to planning your care for that patient. When we talk about patients in our MDT, we are trying to find clearly the sort of the best way through for that patient. And so we need to have as much information as we can about what's going on with them, both in their medical background, but also what their investigations show. And so things need to be up to date, and we need to have them to hand so that we can see them. And then between bringing all those things together, we can then make a plan for the patient. And this is a fairly sort of self-evident slide, which allows us to see what we need to do for these particular cases. So my slides are now frozen. There we are. And then with more emergency care, you've also got to try to understand what it is that we can offer in terms of surgery. Certainly, that's something that's changed an awful lot. In my time as a surgeon, we were doing a lot of emergency revascularization when I first started out. It's really not something we see a lot of now. It's rare that the teams are unable to sort out the emergency patients in the lab, but occasionally we get asked to get involved where there's either a difficulty with a PCI or something that they're unable to get properly treated. And so you need to have some understanding that when you get that phone call in the middle of the night, what it is that you should or could be doing and what the evidence base for that is. So there is, again, helpful guidance within the European document to help you make certain plans around those particular patients. I mentioned peripheral vascular disease as an issue, and again, this is something that's changed quite a lot in my time. We were much more aggressive when I first started as a consultant in terms of treating patients with carotid disease. There was a strong vogue for either joint procedures, doing carotids and bypass grafts at the same time, or treating carotid disease prior to surgery with the view that it might protect people from neurological insult during their surgery. I have to say that certainly locally where I work, in Brighton, the tide has completely changed. We very rarely treat carotid disease for patients prior to surgery now, and really only those in whom have had very recent carotid attributable symptoms and with an associated stenosis, do we offer treatment. But again, there are some bits of guidance, not very well evidenced. I have to say there isn't a huge amount of randomized data to help us make these decisions, but there is a bit of help in the guidelines to help us plan care for these complex patients. And again, it's quite a favourite one for the exam, because it's something a bit more just above the sort of standard guidelines of what we should do for a patient with triple vessel disease or something. It allows it to be a sort of a more nuanced discussion. So it's something that it does crop up from time to time. So I would certainly recommend looking at those that section of the guidelines. We've had a talk, or about to have a talk, about graft strategies and which grafts we might use and when we might use them and how we might use them. And I think that's clearly a sort of a whole another talk, but and I'm sure that you all have views on when you would use which particular grafts or which particular revasc strategies. But I think that, again, you need to be able to answer why you would choose what you would choose and why that would be the right thing for the particular patients that you're dealing with. And then finally, what's the treatment modalities for patients after surgery? When should you be giving aspirin? What sort of timing you would give that post-op? Why you would want to consider perhaps dual antiplatelet therapies and so on. And again, there is some detail in the guidance there as to what we should do. And then perhaps thinking more widely about how structure of care is delivered, so that again, when you're talking in the exam, you're sounding like a day one consultant rather than somebody who's just learned how to do the heart operation. It's good to understand the framework that all of the cardiac surgery units in the UK are now having to work within as to delivering best care, and GIRF has been an important modality of influencing the way that we deliver care in the UK, chaired by Dave Richards previously, and now just about to go through its next iteration under Doug West. But essentially the first round came up with a series of guidelines that we need to implement for your patients. And so it's good to understand that these things are out there so that you can, again, mention it when you're talking about the care of your patients in the exam. So because I think this is the key one, I've gone back to it right at the end. Essentially, this is the one that you need to have in your head day to day in your practice, and I'm sure you already mainly do, but it's certainly something that is a good one to have there, so you understand when you're in an MDT what you're arguing for, and understand the basis of why these particular recommendations have been made. The guideline documents go into that and also reference things widely, so you'll understand if you read this particular section and read back from the references, etc., from that section, the rationale for the decision making that is being decided on the patients that you're looking after. And I think that's the sort of stuff that we use all day, every day when we're in sort of at work, and therefore is inevitably what you're going to be asked about in the exam, because firstly it's important, but secondly because it's what the people who are examining you will be familiar with. It's what they're doing all day, every day. So they're going to want to examine you if they can on stuff that they're familiar with, rather than the sort of real esoteric minor points that they may not be so happy to discuss. So that's a whistle-stop tour through our sort of current guidelines. I've got, as I say, a pack of information that is, or should have been, or will be shared with you, which has sort of the most relevant, up-to-date pieces of information for you to have a look at. I'm afraid it was only possible to really skate through things with 15 minutes, but I hope that the advice with regard to getting the best out of yourself for your exam and how you might, and understanding the sort of the preparation and so on that you need to make. As I say, don't forget you're being examined as a day one consultant. You're not being examined as a professor of some particular fine art of ventricular restoration or something. It's the day one consultant level, and that's the pass. So be reassured by that. It is, as Professor Bonza said to me, it's a complicated exam in straightforward cardiothoracic surgery, and I think that's actually a very reasonable assessment of it, and I wish you the very best of luck. Thank you.
Thanks very much, Michael. Thank you for condensing that into such a short space of time. And as you said, you can only really scratch the surface, but I think you've given people resource to look at. As always, you've exceeded expectation. I've got a question for you from the chat. In your practice, when do you send patients for a viability study? And then I might ask Saib to comment after that.
Well, we happen to have, we're very lucky, we've got some real experts in stress echo in our hospital. We're just starting to use MRI. We haven't used it traditionally for our patients, and that's mainly because we have a fantastic local resource of stress echo. And I don't know, just from my own experience, I found stress echo to be a more helpful indicator of that pickup of LV function that you're looking for. I think that's probably just because it's a more functional test rather than a sort of theoretical one that you might see with MRI. And certainly if you see good pickup with stress echo, then I would be very keen to to consider discussing surgery with the patients. In terms of who we send for it, again, that's probably changed over time. We were perhaps more aggressive in getting patients some sort of viability assessment more previously. If patients do not have angina and they have poor LV function, but have significant coronary disease, then we will do some sort of viability assessment. That would be, I think, a sort of the headline stats for us locally. If patients are more troubled by angina, or their LV function isn't too bad, then we don't tend to use it so much. Of course, the worse the LV function, the more you're going to need to see that the LV is going to pick up. And we've probably again changed our practice from, whilst of course the data is good to show that surgery in terms of the stitch data, 10-year outcomes, shows that revascularization for these patients gives them a better outcome. Revascularization with surgery gives them a better outcome. We have decided at times to take discretion as the best part of valor in the really poorly ventricles where they haven't got much reserve, then we would consider stenting for those patients to allow us to try to get the patient to be a life certainty rather than a dead problem.
Saib, any comments about viability studies?
Yeah, very similar to Mike, to be honest. We've been very fortunate in that we've got a great imaging consultant who's, or a couple of them actually, who's into MRI as well. And so both modalities, both debuting with stress echo and MRI, has been very, very helpful. I think for both aspects, one is what Mike was alluding to, which was the pickup of the LV, because there are LVs that are poor or impaired, appear to be so, but actually are hibernating and they'll pick up with a bit of low dose. And there are others that are dead, of course, and we don't really know whether they are properly dead or not. So, and it helps both ways, not just surgical and PCI. And that case that Sudhakar showed very nicely with 3 vessel disease with a chronically occluded right, we don't know because we didn't go into that. But if the inferior wall and the inferior wall is really down, you want to see how much is viability there. Or if it comes to the point where, okay, if you're going to graft them, are you going to be able to put 2 or 3 grafts on there, or is it just 1 graft? So it is very helpful, actually. And the viability is important because you want to know that you're going to be grafting onto whatever, or stenting onto something which is actually alive. Otherwise, it may look good on angiography, but it's not going to last. And in fact, the patient could be worse off at the end of it. So both modalities are really, really helpful. And we've been very impressed, to be honest. And MRI has been made simple to me because of a great colleague who can just explain those lovely pictures and you can just see it. That's dead and that's alive and that's picked up and that's moving. And I know that sounds simple and I'm not being facetious here. It really has sort of opened my eyes. Whereas previously it was sort of like something, it's like a Back to the Future sort of thing. Whereas now we use both modalities commonly. In the impaired left ventricle, of course. Yeah.
Thanks very much. There's a question about Beamer and Lima versus vein grafts. I'm hoping that Mr. Benedetto is going to answer that question for us very soon. So we'll just leave that for a moment. But Umberto, I'm sure you will have that in your talk. And if you haven't, then you need to do your talk again. How far back would you? Yeah, I think this is particularly relevant in the times of COVID. How far back would you accept the echo and coronary angiogram date?
We tend to say for an angio a year. I mean, it's completely arbitrary, but we've in general gone for a year. And then for an echo, assuming no recent events, then we'll go for 3 months. And it's been interesting, actually. COVID has probably changed our thinking around it, because we've certainly seen patients who've had COVID but no other ostensible cardiac event, but have had a serious change in their LV function in the intervening period. So yeah, I would include a COVID infection in that definition of an event. If they've had either a cardiac event or COVID, then we would do an echo as a repeat, just to check that things haven't changed markedly. I don't know what the others would do.
So I would do the same for an echo. I think coronary angiography has become more of a problem now because of COVID, because of the, I'm sure you remember the days when we were trainees, Mike, the bad old days, when people were waiting well over 2 years and they were getting repeat angiograms. We will consider doing a repeat angiogram if it is 12 months out of date.
Mm.
If a patient has stable symptoms, then I probably would not. But when it gets to 18 months, I would generally ask for it to be repeated, especially.
I think it depends what's on the angio as well, doesn't
Yeah.
it? I think if it's already got, 3-vessel nasty disease and there hasn't been an intervening cardiac event, then, realistically, it's going to show this, the 3-vessel disease won't have gone away. And so it's unlikely to have, very much in the way of import for the way you plan your care. If, and rare that we see a patient nowadays, unless it's sort of as a combined procedure with valve surgery or something. If it's 1 or 2 vessel, then there may be a slightly increased imperative to look again to make sure that other vessels haven't become diseased in the intervening period.
Revascularization of the patient with PCI within the last 3 months. Siddhartha, when are you happy to stop dual antiplatelet therapy to allow us to operate?
I think I suppose it depends on the urgency of the situation, and it's just weighing up the risks from bleeding versus the risks of a further cardiovascular event. My personal practice is to say that if it's non-critical lesion that you've left, then I would say after 3 months you could pause the second antiplatelet, so the ticagrelor or the clopidogrel or the prasugrel, and operate. But we have had situations where, I think it was about 18 months ago, 2 years ago, we had a patient who came in with an inferior STEMI, and we stented the right, but there was complex left main disease with LAD disease and circ disease, which was not particularly amenable to PCI. And it was felt that needed doing earlier than 3 months. So I think the surgeon took it on after a month, and we paused the second antiplatelet after a month. And as it happens, they were fine. I don't know, Saeed, what do you do?
Yeah, I was going to say actually similarly. I think, to be honest with you, now with the stent technology that we've got as well, a patient who's been treated and is, as you say, symptomatic or not too symptomatic, not acute, who has been stable, after a month's antiplatelets, and stopping them then with a view to surgery is not a big deal now, not as much of a big deal, if you like. So I would be less so. A bit like the patients we get referred to due to have an operation, can we stop their antiplatelets perioperatively? It's much, you can't generalize too much, but we're much less anxious now than we used to be after a month of, as long as you've done good stenting, really optimized it, and antiplatelets, and they've been compliant. I think after a month, I would be less worried. And there are certain stents which actually propose that actually a month should be fine. You should be fine after that. I think the problem is in the end STEMIs and in the acute infarcts, we're slightly more anxious, of course, because we know there's a higher incidence of re-events, but I would be less worried about that. So to stop it at 3 months wouldn't be a problem for me, and then get on with surgery.
It's interesting. We're probably a bit more aggressive than that. We certainly, I probably would take a 3-month cut off as well. But if we're having to do bystander disease before that 3-month window, we use tirofiban quite a lot. We would admit patients for a tirofiban infusion, transfer them onto ticagrelor before they come into hospital, so that you've got the the shortest washout period for the oral agent, and then have them on tirofiban for 48 hours prior to their surgery. So we would then have them effectively on dual antiplatelet to within 6 hours of their surgery. Then we do their surgery, and then we would restart things immediately as soon as we can, as soon as they're not bleeding after surgery. So certainly by next morning, they'd have had their dual antiplatelet, they'd have had aspirin within 6 hours of surgery on the unit. In terms of, there's a question I see popped up about worry about protamine, full dose of protamine for those patients. We would give full dose of protamine in that scenario. That's how we would manage it. We would stop the tirofiban 6 hours before surgery, do the operation, treat them as we would do anybody else in the surgery, give them their aspirin as early as possible after, but within 6 hours, and then give them their oral agent, whatever they're on, as their second agent the next morning for surgery, after their surgery.
Thanks very much. I guess as Sudhakar said, it's the balance between thrombosis, stent thrombosis, and bleeding. Just quickly, two more questions. The question about specific guidelines for antiplatelet medications, there are EACTS guidelines on those, and those are available on the web. I don't know if that's in your folder, Mike.
It's actually touched upon the reference. It's referenced in the guidelines. So,
so
you will have it.
So that is there and freely available. And if a 30% anterior or akinetic but angina, do we do viability? I presume it's triple vessel disease. I would want to know about viability, because you'll be putting a lemur on that, and that's going to give you your prognostic benefit. If not, you might just stent the other two vessels. Mike, quickly.
Yeah, I mean, I think it would have to be on the basis of what the investigation showed. If there was some viability, if the wall was moving a bit, and it was a nice thick muscle on the echo, we would probably not get viability. But if there was any concern that somehow that might not wake up when we revased it or whatever, then, as you say, you are then perhaps moving into just two vessel stenting, and therefore an unnecessary risk of surgery.
Great, thanks very much, Mike. Thank you very much to all the delegates for their questions, and we're going to move on to Umberto Benedetto, who's joining us. I believe you've joined us from Italy, Umberto.
Correct, I'm in Italy, yes. Oh, nice. But I miss you all, So I share my screen. Okay. Can you see my screen? Okay. So first of all, I would like to thank Aaron and the organizer for this invitation. It's a great honor and pleasure to be here today. Thank you. My talk is about conduit choice for coronary artery bypass grafting. So first of all, I'll just try and, sorry. Okay. So first of all, I just would like to give a short overview of which conduit we can use in coronary artery bypass grafting. As we know, we have the internal thoracic artery, left and right, which can be used as a single graft or as a bilateral configuration. Then we have the radial artery, clearly the saphenous vein graft, and rarely used, there is the gastroepiploic artery and the inferior epigastric artery. Consideration to be made for conduit selection are clearly based on the conduit biology. And we know that arterial graft are supposed to be biologically superior to saphenous vein graft because they were born to be in a high shear stress and pressure system. Clearly, we make the assumption that biology is associated with the patency rate, and therefore we would like to select the conduit with the best patency rate. On the other hand, we know that patency rate is not only related to the conduit that we choose, but also by other conditions, and especially by the target runoff. If we use a conduit for, we can use the best conduit for the worst target. We know the patency rate won't be as good as we expect. And in fact, degree of native vessel stenosis and competitive flow are detrimental for conduit patency rate, especially for arterial graft. Moreover, we know that the location can be also influence the patency rate. For instance, we know that arterial graft used for the right coronary artery are associated with the poorer patency rates. Finally, one thing we have to consider is again the size of the coronary vessel, because if we use, for instance, a large radial artery, or also a large saphenous vein graft for a very tiny vessel, this will create a conduit artery mismatch, which can cause a low flow and ultimately can affect the patency rates. Other important consideration needs to be made in terms of patient comorbidities. For instance, we know that diabetic patient with COPD or obese patient are vulnerable to bilateral internal thoracic arteries. They are more likely to develop sternal instability and mediastinitis if we devascularize the sternum. Also, consideration is to be given to anatomical conditions such as porcelain aorta, where we are required to avoid aortic manipulation. And for instance, in this case, Y configuration or in situ configuration using arterial graft can be a solution. Again, same story when it comes to target location. Sometimes the target is particularly can be not optimal for a Y graft configuration. And finally, other consideration to be made is always the risk of injury during, for instance, ITA harvesting, the presence of varicose vein that we didn't expect, or for instance, when we use the radial artery, the presence of calcification or a positive Allen test, which are contraindication to the use of the radial artery. Focusing on the left internal thoracic artery, we know that this is a biological superior conduit to saphenous vein graft, and this is because the endothelium and the media of the left internal thoracic artery is producing higher concentration of nitric oxide and prostacyclin, and this clearly has translated into the best long-term patency rate reported, especially for the LAD target. Moreover, this excellent patency rate is maintained over long term, and the long term of the ITA to the LAD system is nearly 90% at 10 years. Moreover, there is a very strong evidence that using the left internal thoracic artery over saphenous vein graft, we have improved survival. However, things start getting a bit more complicated with the use of bilateral internal thoracic artery. We use the second ITA normally for the non-LAD territories, depending on the length of the conduit. Often the second ITA is used as a free Y graft configuration or as a free conduit, and most of the angiographic registry have shown that the patency rate is not as good as the Lima. This may be due to the fact that non-LAD territory have lower runoff, or for instance, the use as a free graft can affect the patency rate for the mismatch with, for instance, with the ascending aorta when it's used as a free graft. Moreover, the use of a second ITA, we know it's clearly associated with an increased risk of sternal wound complication. And finally, the clinical benefit observed in retrospective series, such as the one from Cleveland Clinic, were not replicated in randomized trial. This is the patency rate of the ITA graft versus the saphenous vein graft for the LAD target. As you can see, there is superiority from the ITA across all the range of proximal stenosis. However, the situation is different when we compare ITA to non-LAD target with saphenous vein graft. You can see that for intermediate degree stenosis, the superiority of the second ITA is not as clear, while high degree stenosis, and clearly when we have target with a very good runoff, we can still see some superiority using the second ITA. When it comes to clinical benefit, which is what actually the patient wants to know, we have been overwhelmed by observational evidence that showed in the past that using 2 ITA was associated with an improved survival at 10 years, after 10 years, and a reduction in the rate of intervention. However, possibly because the usage of the second ITA remained very low, we wanted randomized data to confirm this finding. Unfortunately, the randomized data are opposite to observational data, and the ART trial, as we all know, failed to show a clear superiority from the second ITA over single ITA graft. Moreover, there are additional evidence. This is the SAVE, the RIMA SAVE trial, which compared the saphenous vein graft versus the second ITA in Y graft configuration. And you can see actually the patency rate of the saphenous vein graft in Y configuration was comparable to the one using the second ITA. On the other hand, when we use beta, we should always consider the risk of sternal wound complication and mediastinitis, which remain significant even when a skeletonized technique is used. Therefore, to summarize, when the second ITA should not be used, clearly when we anticipate that the wound risk is particularly high, and therefore in obese, insulin-dependent patient, clearly a second ITA should not be used when we have a poor conduit or with poor flow in the context of an acute MI, because clearly can increase the procedural time. We should not be used with moderate stenosis, because we have seen that the patency rate of the second ITA is really much related to the degree of stenosis, and due to the possibility of increased morbidity, the second ITA should be possibly avoided in patients with advanced age. What can we do, on the other hand, to reduce the risk of mediastinitis? We know that skeletonized harvesting is associated with a lower risk. We don't need to take the whole length of the ITA, but we can save the last bit, which actually increase the sternal perfusion. Clearly, we can minimize the cautery. We can clearly keep basically keep the chest clean, and we can use several tight sternal wire for closure. Moving to the radial artery, we know that the radial artery has been reported to be associated with poor patency rate in the past, and this was mainly associated with vasospasm when this was first introduced. Following the introduction of calcium channel blocker and the observation of improved patency rate, the radial artery has regained popularity. Actually, the radial artery is the conduit where we have more evidence in terms of improved patency rate and some clinical benefit when compared to saphenous vein graft. There are 5 randomized studies. They are all small to reach a consistent conclusion. However, when we pull all this data together, we still have 500 patients with radial and 500 patients with saphenous vein graft. However, this patient-level meta-analysis has shown an improved patency rate with the radial artery, the trend towards some improvement in clinical outcome. Again, the radial artery remains a graft which is very vulnerable to moderate stenosis and a small target, and is a graft that is a conduit that can be affected by calcification, intimal hyperplasia, especially in the elderly and diabetic patients. So when we shouldn't be using the radial artery? Clearly, when we have an Allen test positive, that takes more than 5 to 15 seconds for the hand to flush. Clearly, when we have evidence of calcification, atherosclerosis, and in principle, when patient, which is very common these days, had recent transradial catheterization, which can affect the intima of the conduit. One aspect which is clearly is beneficial over the use of the second ITA is that the use of the radial artery is associated with a very low rate of complication. Actually, ischemia is almost zero, and most reported complications are minor, such as paresthesia, which is about 10%, and only 3% of patients present a superficial infection or dehiscence of the wound. What about the saphenous vein graft? Actually, this remains the most widely used conduit because makes CABG surgery much easier. Actually, using saphenous vein graft is a very safe procedure. And if you look at the most recent angiographic series, as I said before, the patency rate of saphenous vein graft is much better than the one reported in the past. And this is probably related to the fact that nowadays medical therapy with statins and antiplatelet is more aggressive and is more efficient in preventing saphenous vein graft occlusion. Moreover, the introduction of endoscopic harvesting has been shown to be safe and effective in reducing leg complication and achieving at the same time similar patency rate compared to open technique. And there is also discussion around new harvesting techniques such as the no-touch technique, which can further improve patency. Just to give you an idea how popular remains the saphenous vein graft, this is the STS database. You can see how the use of the strategy with a single ITA and saphenous vein graft is by far the most common approach. The use of the radial artery in the States has decreased over the time, and while the use of the second ITA remains stable around 5%, while most of the surgery are performed using a single ITA and the saphenous vein graft. On this other slide shows the proportion of multiple arterial grafting versus single arterial graft across age group, and you can see that also in very young patients with less than 55 years old, in the STS database, about 15%, no more than 15% of patients received a second arterial graft, while the vast majority still received a single arterial graft and supplemented by saphenous vein graft. So why the saphenous vein graft is still widely adopted? The most probably answer is that saphenous vein graft is very safe. Here is an analysis of the SCTS database, which showed that the rate of mortality or hospital mortality is increased when beta is used, especially in low volume center, and clearly the rate of sternal wound complication is significantly higher when a second ITA is preferred over a saphenous vein graft. On the other hand, when using the radial artery, we all know that the radial artery is much easier to be used and somehow doesn't need the surgeon to change his surgical technique. The use of the radial artery is associated with increased mortality only in low volume centers. So for instance, inexperienced surgeon using sporadically a radial artery, this can increase mortality and clearly doesn't affect the incidence of sternal wound complication. So I think the most likely explanation on why the radial artery, why the saphenous vein graft is still widely adopted is because these remain the safest option when we perform CABG surgery. Finally, a few words on the no-touch saphenous vein graft harvesting. This technique has been initially reported as a technique which can achieve similar patency rate compared to arterial graft. However, a recent study, randomized study, the superior SVG, failed to show an improved survival, an improved patency rate compared to the open technique. And on the other hand, the no-touch technique was associated with a much higher rate of leg complication. Therefore, the no-touch technique for the saphenous vein graft, the role of this technique still needs to be defined. In summary, the left internal thoracic artery is still by far the best conduit to choose for the LAD target, and the question about what is the second best conduit is still unclear. Retrospective study seems to suggest some superiority from the second ITA at the increased risk of deep sternal wound complication. However, as we said, these results were not replicated in randomized trial. On the other hand, the radial artery can be a valuable alternative, especially in high degree stenosis or patient at higher risk of sternal wound complication. My take-home message is that multiple arterial graft should be mainly considered in young patients. There is not enough evidence to recommend arterial graft in elderly patients, multiple arterial graft in elderly patients, because reduced quality of the arterial graft themselves, especially the radial artery, and clearly increased risk of complication with the use of the bilateral internal thoracic artery. Patients, therefore, should not be exposed to unnecessary risk of complication. And if we have diabetic patient, obese patient, or COPD patient, I believe the radial artery should be preferred of the second ITA. Multiple arterial graft remains vulnerable to runoff and competitive flow, and therefore should be considered mainly in case of CTO or high degree stenosis. Thank you for your attention.
Umberto, thank you very much for that run through. That's really good. While Sudhakar prepares himself for the MDT, there's a question with a couple of questions there, sort of, you think we can link them together. So you've talked about degree of stenosis for using radial artery. What sort of cutoffs do you recommend, and does it make a difference between if it's a left or a right-sided target?
Thank you, Aaron. So actually, there is a very elegant study from Joe Sabick from Cleveland Clinic, which showed that in reality, the patency rate of arterial graft to the right coronary is much lower. So in principle, especially the second ITA, should be mainly used for, according to this evidence, should be mainly used for the left system. The radial artery to the right system is should be considered mainly in case of complete total occlusion, so in case of CTO of the RCA. I guess these are the two main conditions where the right system can be considered for an arterial graft. In terms of degree of stenosis, clearly we know that these days it's hard to tell whether 80, 70, or 90 is different. I think it's we need to take an overall view of the target of the if we have a very good OM with a high degree stenosis, this can be used. We know that at the beginning there was some enthusiasm in terms of FFR, that FFR may have been used to guide us into this selection. However, two recent randomized trials failed to show a better outcome when CABG is guided by FFR. So in principle, the angiographic degree of stenosis still remain possibly the gold standard to guide us into graft selection.
Thank you very much. I can't see any other questions on the chat. I can't see any hands up either. So thanks very much, Umberto.
Thank you.
Siddhartha, you're back on.
I'll just share my screen again.
So I've got a quick question just while you're sharing your screen.
Yeah.
If the patient's diffuse bilateral varicose veins and Allen's test does not show enough by arterial perfusion, what is your option for graft?
I have to say that even an hybrid approach these days is not a bad option. Just using just doing a mid-cap Lima to LAD and then asking your cardiologist to complete revasc, I don't think is a bad option. These days, everolimus stents, they show patency rate as good as possibly saphenous vein, or even maybe a second arterial graft. So again, I think a good collaboration with cardiologists can help us in finding solution for challenging cases.
Thanks very much. Siddhartha.
Okay, I'll move on to case number 2. So this is a 65-year-old man. So he's got a history of smoking. He's also got a family history of ischemic heart disease, and he has inferior ST elevation on his ECG and ongoing chest pain. He has a bedside echo with the cardiology reg on call prior to the angio team arriving. And again, this shows good LV and RV function and no valvular abnormalities. And then this is his angio. And again, I don't know if you want to get one of the delegates to comment, Aaron.
Yeah, we've got a Dr. Khan from Cardiff. Mr. Khan from Cardiff. Are you there? Gone missing. Mr. Petra from Malaysia.
Yep. So it's an angiogram showing mainly on the RCA. The RCA is a diffuse disease. I think I can't see the PDA. I would like to have a left side view, but I would guess this is a non-dominant system.
Yeah, I agree. So I took a guide to the right, but it was a recessive right, and then this is the shot of the left. Can I ask you just to comment on that? The patient has ongoing chest pain and ST elevation.
Again, I think from the view, I think there's a stenosis at the osteoM. Again, it's a diffuse disease, mainly at the distal circ as well, and also the osteal circumflex as well. I can't appreciate the LAD from this view.
Okay. So this is a LAO caudal or a spider view.
Yeah, from the spider view, the left main seems to be not that diseased. Again, the osteal of the circ is quite diseased. There's a bit of this stenosis on the LAD osteal as well.
So what are your thoughts so far? So this is a cranial view which shows the LAD. The wire is a bit misleading. The wires in that branch of the diagonal just to help me keep the guide out of the distal left main stem and out of the LAD.
So I'm going to ask Mr. Hakzad, Yama Hakzad from Hull to comment on that. Are you there, Yama?
Yes, I am. Yeah, hi. So there is, I think there is a long, sorry, yeah. I think there is a long segment proximal LAD disease. There is also diffuse disease later on. The diagonal is okay.
And just again here, so remember this man's got, before he went onto the table, he had inferior ST elevation.
Yeah, so I would be expecting the PDA or, this is a dominant left side. So I was expecting a lesion in so there is a lesion in the proximal left circumflex. That's at the AV groove. Then it goes on, you got the first OM, and then later on, I want to see that PDA, which is given off from the left a bit better. Is there any other views?
I don't think I take enough pictures, but you're quite right. I mean, my personal view at the time was that this slightly hazy looking lesion in the proximal dominant circ is probably enough for the for the ST elevation and the ongoing pain. What would you do?
I think if he is having ST elevation and inferior MI, evidence says that we should treat the culprit lesion, which is the circumflex, proximal circumflex lesion in this case.
Yeah, I agree. So he had a stent of the circumflex. The ST change is settled.
Mm-hmm.
With this long segment of residual disease in the LAD that you'd identified, which goes pretty much from the ostium of the LAD right into the mid vessel.
Yeah.
So this is when the patient was then taken to the MDT. So this is about 3 or 4 days after his primary PCI to the proximal circ.
Okay, so we've treated the culprit lesion. If he is hemodynamically stable, STs have settled, then he discussed it at MDT, but the options would be probably let them cool off for about 6 weeks if he's stable, and then consider coronary artery bypass surgery for that proximal LAD. The evidence for proximal LAD is both, because it's proximal LAD, it could be CABG or PCI, so it will be a consensus decision. It's quite a long segment, so I would probably, offer a Lima to LAD for this gentleman.
Saib, you got any comments about that? Come on, you want to put a stent in that, don't you?
Yeah, how old, Suraka, sorry, I've forgotten the age.
He's 65, otherwise pretty fit.
His LV's good.
LV's good.
And his right is, yeah, I have to say that, I mean, this is a discussion, isn't it? I mean, it's as per the complete trial, if you like. I mean, I think you're talking about LAD disease in the context of an infarct. I think from a surgery point of view, certainly in our center, there'd be a delay before you would have a Lima on there. You'd want them to go home and come back and recover. And that's a pretty straightforward stent, I think. And I think the anatomy, you could treat it either way. I think surgery is, to my mind, is over. I don't think there's evidence here that surgery is better than just putting a stent in there. And also, surgery is not precluded at a later stage. So I think you can get a good angiographic result on this patient. I think angiographically, you would have to go into the left main. I don't think it's just osteal LAD. It's disease is a continuum. So whilst you can see the proximal LAD, I think in one of the views you showed, it might be this one, you can see there goes a tapering left main. So I'd want to treat into left main with IVUS guidance. And I think that's what I would do. I would want to put not just stick a stent in there, but really optimize a stent in there. I've been to see what you did do the QT, because I think you can get a very good result. You've got good runoff. And if there's problems later on, then surgery is always an option, because you're not closing that door. But that's my approach to this.
I'm just going to ask Umberto to comment.
It's a hard call. I have to say, these are one of these cases where I think also, patient preference is important. It's a proximal disease of the LAD. You have to go back in the left main in the bifurcation. We all know that bifurcational lesion with stenting, are not as good as ostial lesion. I won't be reluctant if we all agree to just do Lima to LAD. I won't be reluctant myself.
Yeah, and I would agree with you, but I don't think there's anything. I'm not against the Lima. I'm just, I suppose, giving what my approach would be to this. I think.
Yeah, of course.
Yeah, I mean, and I think the point is about the stenting really is that when patient choice is very important. But I think if the patient choice is between cracking the chest open and doing this one graft, as opposed to having it and going home the next day, and then with an optimized IVUS guided proper PCI, and then coming back, that's a difficult choice, because the preference will be, well, actually, I'd rather have that and not have that, and not have to recover for 3 months for my sternal, unless you're talking about an off pump or something like that. So I think it goes both ways, doesn't it? I don't think there's one right answer and one wrong answer. And so I suppose I've just given my approach to it. I don't. What I did do.
I think you both make a very good point about patient choice. I think this is the kind of patient that you really have to talk to and explain to them the risks and the benefits of both treatments and the long-term outcomes. Siddhartha, what do we do?
So this patient was very much happy to have whatever we thought was the best treatment for them, not concerned about the recovery necessarily, and didn't particularly want it done the next day and to be able to go home, but just wanted the best long-term outcome. From memory, I know what the outcome was. From memory, in the MDT, there was discussion along similar lines that PCI could have been done and would have been reasonable. The slight concern was that it's quite a long segment of stent, as in you have to go, if we're going to go normal to normal, then well past that diagonal. So this person had an off-pump lemur to the LAD after about 3 months after the original infarct, and I saw them once in the clinic afterwards, and they've done very well. So yeah, this person had an off-pump lemur to the LAD, even though I agree PCI would also have been entirely reasonable.
You can see from the chat that everyone's liking that as a training case, that lemur to the LAD. Okay, Siddhartha, do you need to do a study for ischemia burden? Once you've treated that, you've already treated the circumflex lesion. Do you need to prove there's ischemia there in the LAD?
I personally did not think that you would have needed to prove it. And actually, the latest kind of trials, in terms of complete revascularization, it doesn't ask for any kind of ischemia testing. It's just whether it's angiographically significant or not. And of course, you cannot second guess a FFR result because that's the point of doing it. But I would put my house on this LAD, which is a very long segment of disease, right from the ostium into the middle of the vessel, being positive on a pressure wire. But they did not have a pressure wire; they went straight for the operation.
Yeah.
Okay, great. Okay, case number 2. No, number 3, because we've done case number 1 already, haven't we?
Yeah. Okay. So case number 3 is a 55-year-old man. He was admitted with an acute coronary syndrome. He had a small troponin rise, cardiac sounding chest pain, and he had some anterior T-wave inversion. Again, he's already had his echocardiogram. He's got good LV and RV function, and there are no significant valvular abnormalities.
So, Mr. Lang from Edinburgh. Are you with us, Mr. Lang?
I'm here. It looks like some proximal LAD disease there. Circ looks okay.
I agree.
Yeah, there's some proximal, some mid-LAD disease. D1, osteal D1 disease. Yeah, so disease of the LAD, high diagonal.
And what are your thoughts on treatment? So the right was mildly diseased.
Yeah. So he's basically got 2 vessel disease with proximal LAD disease. So, sorry, could you just show the history slide again?
Yeah, so he's a previously pretty fit.
Yeah.
A 65-year-old, in his 60s man.
Okay.
55-year-old man.
Okay.
Smoker, but otherwise fit.
Okay. And he's got ST anterior T-wave inversion, so it's an N-STEMI.
Yes, in the LAD
territory. In the LAD territory, okay, fine. And does he have ongoing chest pain?
No.
No. So in the context of 2 vessel disease with proximal LAD, we can consider either CABG or PCI. It sounds like he's probably fit for surgery. I discuss it at the MDT. I get an idea of what the patient's preference is as well. But I'd say CABG and PCI are both viable options in this case. And he's diabetic, you say?
He's non-diabetic.
Oh, non-diabetic, yeah. Yeah. So I'd say CABG and PCI are both viable options, and I'd speak to the patient.
Okay. Dr. Nair, Ashvin Nair from Malaysia. Are you there?
Yep, I'm here.
Okay. So let's say that you speak to the patient, he decides he wants to have surgery, or you want to, or you decide you're giving him surgery. What conduits are you going to use?
Yeah, I'll consider using a LIMA to the LAD and probably a vein graft to the diagonal.
You'd only consider the LIMA to the LAD?
Well, yeah, I mean, I would, from the evidence, the long-term patency rate of the LIMA is much more superior, so I would definitely use a LIMA to the LAD.
I think everyone would do that. Umberto, conduit choice here?
So it's interesting because there is one study called PREVENT that says that when you have a diagonal, if you put a vein graft, you can jeopardize the LIMA patency for competitive flow. So if you, even though clearly you have two, these are two separate stenoses, maybe in this case you can also do a jumping, you can do a side-to-side LIMA with the diagonal, and then and just you land your LIMA on in the LAD. So just a jumping on, to the diagonal, and then using just arterial graft, you can still do a mid cab instead of cracking the chest. But I think in this case also I wouldn't be reluctant to, especially if the cardiologist feel he can save the diagonal. It's a big diagonal. I think it's a, also PCI is an option here. Patient can be seen, maybe in, at the second stage. But I think in terms of conduit, possibly I would do a jumping of the LIMA to the diagonal and then LIMA to LAD.
Mike, conduit choice? Mike, are you still with us, or we lost you? I think we may well have lost Mr. Lewis.
I'm here. I'm here.
Thank God for that. Conduit choice?
I mean, I have to say that we're barely meat and two veg in Brighton. Certainly mammary, obviously. And then, I don't know, I'd probably go for a bit of vein. I think that's what we would do. I think that would be our fairly standard practice. I think that would be, that's what you'd probably get in Brighton.
Do what you do every day for the exam. Mike, is that correct? Do what you recommend, what you would do every day when you're in the exam situation.
Absolutely. Yeah. Talk about why you would do what you do every day. Don't come up with some fancy, clever sort of jump graft solution that you do not use, because then you will fall over and get yourself caught up in something that, you're then having a conversation about something you're just not happy with. And so make sure that you just do what you would, what you and your team would do every day, because then you will be comfortable talking about it and you'll be able to explain why that would work well for you and keep your patients safe. That's essentially what the exam's about. It's just checking that you are safe, and that's what you're there for.
I just ask a controversial question, Mike. Are people still doing the jump graft? And what is the patency of those jump grafts?
I have to say I'm not a fan. For me, it's all eggs in one basket type thing, but there are surgeons I know who still use it a lot. And some of the Plymouth surgeons are big fans, and they would argue that because you've got a better runoff, you've got better chance of long-term patency overall. And so, but I didn't train with people who used them, and so I've never used them very much unless I'm short of conduit, in which case then it's a get out of jail sort of type maneuver. But for me, one graft to one vessel. I don't know what if things have changed in Birmingham, Aaron, but when I trained there, that's what I was taught, and that's what we would routinely use.
That is what I would use. I would use a vein and a mammary there. I think if you're not using something like jump graft regularly, it probably isn't the right thing to do. you can make things an awful lot worse. And if you jeopardize that LAD, then that's what you're really going in there to treat. You're going in there to treat the LAD. Umberto would be different because if that's a technique he uses on a regular basis.
No, eventually I would do the same. No, eventually I would.
So, Siddhartha, some of the delegates here obviously worked with you because they say this is very challenging for PCI.
Well, I don't know about that. Let me just see what they've said. Yeah, I'm not sure actually. So I was keen to treat it actually, but it is proximal LAD extending into the mid-vessel, and if of course it is a bifurcation, and you'd have to treat the diagonal. So I can't remember if it was you, Aaron, but I just called the surgeon down who was on call, who looked at the pictures with me, and we agreed PCI was reasonable, and they had a DK crush to the LAD, and they went home the next day. So I didn't take it to the formal MDT. The surgeon said, much as Umberto did, that if the patient particularly wanted CABG, then they could have it. But if they were happy to have PCI, then they were. So I guess it's a bit difficult. It's not a truly informed decision with the patient because they've probably already had a little bit of sedation. And I've done it, but I've done it because I think at the time it was a reasonable option, and I involved the surgeon, but not the full MDT. I don't know.
I think Said made a good point with the last case as well. If there's any issue, if you have incidental restenosis, then you haven't spoiled a surgical option for the future.
Yeah, absolutely.
Can I ask a question with regard to that? Because there was a sort of a bit of a vogue for some data showing that your outcomes for surgery post an upstream stent weren't as good as they were if you went for a sort of straight off the bat type graft, and there was some concern around downregulation of endothelial function from the stuff that washes off the stents, and therefore the graft, it wasn't as such a free hit. And I don't know if that data has progressed at all since I last read any. Has anyone seen anything on that? Is there anything more on that? Because certainly if that is the case, then we need to be careful about this notion that, you can have a stent and then have a graft later and there's no loss to the patient, because clearly that wouldn't be the case if that was true. And I know that David Taggart talked about it quite a lot a few years back. I've not heard much more on it and not seen anything published on it, but that's not because I'm sure people have been writing about it. I just haven't seen it.
Yeah, I mean, I think, Mike, I haven't seen that in particular detail, and certainly not recently. But I mean, one of the things when we're talking about where you're going to put your graft is sometimes the stenting extends. It's long segments of stenting. One of the biggest things is the long segment of stenting tapering down, where you've got relatively smaller caliber. So you're putting your graft as distal as possible. So it may well be in those cases that you don't. But generally speaking, I've not heard of any comeback with that, to be honest. Not that it happens that often. But I mean, looking at this case here, where you could really put your grafts on quite nicely, couldn't you, on that little humpback bridge, as I call it. So I don't know. I don't know that. Siddhartha, do you know the most recent evidence? I've not heard anything about that recently, certainly.
I haven't, but same as Mr. Lewis, I've heard Dr. Taggart talk, Mr. Taggart talk about it. I have to say, you have to wonder, in terms of stuff still coming off the stent before new endothelium grows over it. I mean, it would have to be early stent failure, for it to be significant. And I can't imagine that in 5 years, for example, it would be a problem. But I could see the theoretical kind of, lack of healing from, surgery into if drug is still being eluted downstream.
Yeah, and that would be very early, though, wouldn't it? As you say, because otherwise it's endothelialized, yes. So you're not going to have that problem. So it may well be that he's, and again, maybe I should try and search that paper. If it's in the early stages post-stenting,
yes,
then it may well be because all the flow is not normal then, and that might be that situation that you've described, actually.
So anecdotally, when I've seen or operated with very abnormal LADs post-stenting, it is been those early stent failures. So you wonder whether that is what you're seeing. There's something biological. I again haven't seen anything. I know that David Taggart published on this some time ago, but I haven't seen anything anything recently either, Mike. Okay, question for Mike. Age is not in the guidelines. In the exam setting for a patient suited for PCI and CABG, am I justified to suggest younger patients should be offered surgery, or should I stay on the fence?
A career in politics may well beckon. I mean, certainly we have an aged population down in Brighton, and so I think our sort of cohort of patients that we routinely see are perhaps older than some of the cohorts around the country. But I think, I think the data is clearly, it's gleaned from trials that looked at younger cohorts of patients than perhaps the ones that we're, I suppose, all around the country now seeing. But we still have to sort of apply the data that we have and the knowledge we have from those guidelines in a sensible way. And I'm perhaps lucky. I work in a unit where we have a very collaborative relationship in general, and cardiology surgery will try to find a way through for each patient to get them the best treatment we can. And age per se doesn't play an enormous part unless it's an extreme of age. And I suspect now, whereas perhaps 5-10 years ago we were operating on patients for revasc into their mid-80s, that hasn't happened very much recently. We occasionally get patients who aren't suitable for a PCI option who will operate in their mid-80s, but up to about that point, we would apply the data and apply the guidelines really based on the patient's condition rather than their age per se. It doesn't add much to your Euroscore calculation. You just do a Euroscore on age and keep changing the age in the calculator. The actual risk doesn't go up very much. I know that's slightly a wrong way around to think of it, because the Euroscore was gleaned from a retrospective analysis of a large number of patients, not many of whom were very old. But in terms of clearly what's felt to be the most up-to-date risk scoring, it's not a massive impactor on its own. It's all the other stuff, all your comorbidity.
So Dr. Kigali is going to talk to you more about age tomorrow, especially when we talk about TAVI. But I echo what Mr. Lewis says, and there are patients who are 60 who look like they're 80, and there are patients who are 80 who look like they're 60. So you have to look at the patient that's in front of you and work it out, not just based on a number.
And just because you can do it doesn't mean you should do it. That applies to life. Sorry. Damn, they're recording this as well.
You're getting free philosophy as well as everything else this afternoon. How about that?
Okay, Siddhartha, before we get much more touchy-feely, go to case 4.
Idea. So this is again a young man, so relatively young, 61-year-old. He's got a bit of past medical history. So he's had a previous right hemicolectomy for carcinoid. He's an ex-smoker. He's got high blood pressure. His ECG doesn't show any particular abnormalities, but he's got a small troponin rise. So again, he's treated as an ACS. He's on dual antiplatelets, and he comes in for an angiogram.
Okay, Mr. Iqbal, are you there? Yes, sir.
Hi.
Okay, go for it. Yeah, so what do you think?
Okay, so I can see a narrowing of the distal left main stem there on the left side of coronary views. Any more views at all? Yeah. Yeah, so distinct narrowing there of the distal left main. Regurgitation of the dye when you inject into the left main there. LAD itself is good caliber and no further disease downstream. And circumflex again looks, it's got maybe a discrete disease in one of the OMs. dominant right. Again, couldn't see any disease in that view there. Yeah, so I think the right's just free of disease.
Okay.
How's he done, Siddhartha?
Yeah, I mean, he's right. So I think Yasser was just saying there's an isolated distal left main stem lesion, which we can probably see in a couple of the views, but probably easiest to see in the spider, which is this one.
You're being asked, is that thrombus?
Well, I would say I didn't image it. Angiographically at the time, I didn't think it was thrombus. I mean, there may be some thrombus there. Generally, if it's an acute coronary syndrome and we're saying it's a plaque rupture event, if you image it and you look closely enough, there should be a little bit of thrombus. But I didn't, certainly in my angio report or discussion at the time, I didn't mention it.
Okay, so Dr. Jarrett? Dr. Jarrett from the US, are you there? Nope. Mustafa Snozzy?
Yeah, hi.
Hi.
Yeah, so this patient with distal left main, he's in acute coronary syndrome. So I'll check if he's got ECG changes or chest pain. Will ask for intra-aortic balloon pump for stabilization.
So he came in with chest pain, but by the time of the angiogram, he's pain-free. His ECG is ischemia, but he's had a small troponin rise prior to the angiogram.
So he's stable now.
Yes.
So yeah, for left main, I think will arrange for inpatient cabbage for him. So.
And what are you basing that on? What's your evidence? What are your guidelines for that?
I'm not sure.
Your suggestion is not unreasonable. I mean, Mr. Lewis showed you some guidelines earlier, and it said, isolated left in low syntax. I mean, surgery does have a 1A indication.
Yes. Yeah. So yeah, based on the guidelines, I think for prognostic benefit, he will go prognostic benefit from cabbage.
How would you classify the rest of the coronary disease?
How
could you classify the rest of the coronary disease that's there? So we said there's distal left main. How would you classify the rest of the coronary disease?
There is no other significant lesion in the LAD or left circumflex or the RCA. So just the only distal left main.
Yeah. So if you were going to divide this up, let's say you were going to score this type of disease. Do you know any ways of scoring disease, coronary artery disease? Angiographically?
No, I don't know.
Dr. Kigali, do you know any ways of doing it?
Yeah, I mean, I think Siddhartha mentioned already the syntax score, didn't you, Siddhartha? And I think it's important actually just going back a step, if I may. The considerations that you're thinking about, not just jumping to the guidelines, is, it's distal left main, is there any other coronary disease, etc., is really the relative jeopardies into the coronary circulation. So I think you have to have that in mind rather than jumping straight to surgery, which is what we were saying previously with regards to discussion and the MDT, isn't it? Because actually, if you pre-made up your mind, it's definitely surgery without contemplation for anything else, it makes it more difficult, and it's not necessarily the best way forward, is it? So, I mean, the syntax score is a good way of doing it. We know about several studies, including the Noble study, etc., which you guys will know about, looking at surgery, looking at PCI. So it's important to have an awareness of all that and to be armed with that when you're fighting us interventional cardiologists, because we can be pretty vicious, can't we, Sudhakar? Nicely vicious. Is that fair?
What would you have done for this one, Saib?
I think these cases are really important, and it's very important to discuss with the surgeons. Okay, this is not a one-upmanship. It's not about me getting a stent in as opposed to a surgeon getting a graft on. So I would definitely get a surgeon down. The patients come in acutely with chest pain. They're on my table. Just because I've got a guide doesn't mean I'm going to treat it. But I would discuss with them and say, look, I can get a very good result here. I can do this. I've got good runoff. I don't have any other vessels there which are jeopardy. It's a big dominant right coronary artery. So I'm not as worried about the circumflex. I can always cross through the stent and treat the circumflex if I needed to. But I would stent this unless the surgeon really gave me a very good reason not to. And I would put the risks there. The risks are not very high for this. I think it's a nice clean lesion. I would do it as IVUS guided. So I'm not talking about a quick smash and grab. I'm talking about a proper angioplasty, IVUS guided, optimized. That's what I would do. But I'm prepared to listen to arguments, which is the important thing. You need to keep your mind open as to what's the best thing for the patient. And I would, of course, discuss that with the patient. It's not a high syntax score, is it? It's not a high syntax score.
No.
Delegates, come on. Are you going to let Dr. Kigali stent this man?
I'm not being vicious, by the way. I'm being calm right now.
Okay. Any evidence for stenting this patient, Saib?
Any evidence for stenting it? Yeah, there is good evidence for stenting it. I mean, I think you can get a good angiographic result. I think the distal left main is the issue, which is a discussion with regards to bifurcations, but you've got a big, because of relative jeopardy, if you like, to the circumflex and to vessels that are coming off or branches coming off there. And we know that if this was a left main, body of left main, discrete stent, that would be even lower risk. I think a Lima graft or a stent are not the wrong answer. I think it'd be much easier if it was just an ostial left main stem or a body of left main stem. But that's why the MDT discussion is important. And we don't always have the evidence because the trials don't always fit every single patient that you come across. Quite often you find distal left main where you've got horrible diffuse disease down the circumflex and an intermediate or a high OM, as well as an LAD, and the right coronary is affected as well. It's not just that discrete. This is extremely discrete disease, actually, very discrete disease and short.
Yeah. Umberto?
No, I agree that because the circumflex is small, PCI, it's variable. I'm always a bit skeptical in sacrificing, let's say, jeopardize the circumflex in this kind of lesion. But I think in this particular case, it's a small circumflex. So also, if you lose it, you may not have a major issue. Again, I think this is another case where patient preference, can play a role, because I think both options are valuable. Also, grafting that circumflex, may not be. Also, grafting, you need to consider, because the LAD and the circumflex are communicating, because the lesion is before the bifurcation, you may have competitive flow. You might just be doing the Lima and that's all. So I guess it's a good option. PCI is a good option.
Yeah, I think with this type of patient, I think I'd agree. I think both options are possible for this patient. I think both options will give a good result. So can you mention Excel trial and exam? Yes, you should. This is the other thing I'd say about this type of left main disease. This isn't a very common left main disease, is it? You normally have multi-vessel disease with left main disease. Isolated left main disease like this is not particularly common. I think if you're talking about left main and then multi-vessel disease, that's a very different patient, isn't it, Sudhakar?
Yeah, that's right. And again, as Saib said, it's not all about the guidelines, but the ones we looked at earlier would equally support PCI to this, and there's probably equipoise in the evidence. So I have to say I was keen to stent it because, as Saib said, I'm not saying that they wouldn't have noticed if the circ had gone down, but I think it would have been unlikely, and also I think we could have rescued it. So I got the surgeon on call down who didn't think it was an unreasonable thing to do, and I just stented from that proximal LAD back into the left main stem, and the circ we didn't have to do anything to, so it stayed open with a stent across it.
Actually, more often than not, technically, so like I expect you've seen this, is that when the circ comes off at 90 degrees, it's often actually not protected, but it's because things like that can happen, but we can always cross and reopen it. But and the analogy is, of course, if you've got a recessive right coronary artery, you don't forget about it, but actually it's a recessive right coronary artery. And this is actually not even codominant, it's a recessive circumflex, really, isn't it, compared to a large dominant right. So I think it's I think, again, we go back to what we said before, Aaron, which is each case on its own merits. And, you know, the coronary anatomy is never exactly the same from one patient to the other. The guidelines, obviously based on studies, and the studies patients are those specific patients. So, and they don't always fit the bill, do they, perfectly?
That's right. So there's a question about what's the stent patency for that type of PCI?
I mean, we would expect that to be good. I mean, I think the long-term studies of PCI versus CABG would say that you're more likely to have a recurrent event with PCI. That's not an increase in mortality, but in terms of either repeat target vessel revascularization or perhaps another end STEMI, then I think there is certainly a higher risk with PCI than CABG. But I don't think, you know, I would not expect this patient to, you know, to come back over several years with any issue. I don't know what type.
Exactly, and particularly I think with left main, isn't it? I mean, I think the left main vessels of stenting is usually much bigger. And when you look at the
and
area,
as I said, you know, we used IVUS.
Yeah, exactly.
It's a big stent that's pushed out to the, you know, you would be surprised if there was a problem.
Yeah, when you've optimized it with IVUS, and you know what the area is, and it's greater than a certain millimeter square, you're highly unlikely to get that coming back. Absolutely.
So I've got a question in the chat about grafting both. If we do graft it, would we graft both the LA and the circumflex? I would graft both, depending on what that circumflex. That circumflex may well be small when we finally get around to it. So if it ends up being a good target, yes, I would graft that as well. Umberto?
I agree. Yes, if it's a good target, of course, yes.
Okay, Sudhakar?
Okay, moving on to the next one. So this guy's interesting. I don't know if we've done the right thing or not. So he's a 32-year-old man with chest pain on exertion. So he's otherwise well, but he's describing typical angina, worse on exertion, relieved with rest. His ECG was normal, his echo was normal, and he had a CT coronary angiogram, which showed an aberrant takeoff of the left coronary artery from the right coronary cusp. And then it's described as having a malignant course going between the aorta and the pulmonary artery. And so this person, I have not done an invasive coronary angiogram on, but took straight to the MDT for views.
Okay, Mr. Ali, Jason Ali from Papworth.
Hi.
You are the MDT.
So the patient is experienced. I mean, if you have, would you proceed to do some sort of exercise test to demonstrate ischemia on exercise before proceeding?
Yeah, totally reasonable. And what would you do if the exercise test is positive or the stress echo is positive? And what would you do if it was negative?
That's a good question. I think that I've seen a case similar to this in the past where there was a positive exercise test, demonstrable ischemia with this so-called malignant course, and we took the patient to surgery for grafting. If it is not, if there was no demonstrable ischemia, I guess the issue is that the patient is reporting typical angina. So I suppose that in that regard, then you could ask yourself, was the exercise test necessary? But it's a 32-year-old who you're going to potentially take to surgery. So I think it's reasonable to perform an exercise test to demonstrate the ischemia before going ahead with surgery. But if you didn't have demonstrable ischemia on exercise imaging, then you would discuss with the patient and the options, but essentially he will probably need to have surgery.
Okay, Saib, what would you do with him?
I mean, I think the exercise test, whilst it's an option, it's not very, the yield is not great, is it, from exercise testing? And I think what we do know is that this patient has got chest pain on exertion, which sounds anginal. I presume, Siddhartha, we're assuming it's cardiac sounding chest pain. I think you want good evidence, don't you? You need a strong mandate to go in and do anything surgically, because that's a big undertaking, particularly in a 32-year-old man. You would want to see evidence that the CT coronary angiogram is helpful in that it shows you a malignant intraarterial course. And then, the question is, okay, I want evidence for that. And maybe MRI is one of the things that I would do here to look for ischemia, or depending on the patient. And we don't have that much information about the patient. He's otherwise well, but there's nothing else at all. He's as fit as a fiddle. He's been running. He's not had any syncope or pre-syncope or anything like that.
No, he's not had any pre-syncope or syncope, and I don't want to say he's been running. He's an averagely fit brummie, so no particular problems, but not a regular gym goer.
Yeah, I mean, I think we need as much information as we can, can't we? It's not because I'm worried about surgery, but there may be other stuff going on. Congenital stuff, anomalous stuff often goes in twos, doesn't it? It's not just necessarily one thing. So I would want to get a bit more information. The CT coronary angiogram has given us a little taster of what's going on here. We know if you've got a malignant course, that can cause problems. We don't know about the pulmonary arteries. We don't know about other stuff that we need to know about. And I would want to get an MRI. I think structurally, I'd want to know a bit more about what's going on. And then you can get some evidence also of ischemia before you do anything. And I definitely want that information before jumping in and saying, just bypass them. You don't want to go in there, crack the chest open and find stuff you didn't expect. Maybe I'm being a bit of a wuss and overcautious, but I think I'd want that, I think, if I was a surgeon, probably.
So I've got Mr. Mohammed with his hand up. Have you got a question or a comment?
Yeah, I have a comment. I think that's the problem in these patients is the risk for sudden death. So for the prognostic purpose, I will do surgery and will most probably unroofing of this course. I think that most probably that's intramural in the aortic wall between the pulmonary and the aorta. And such course of the left main will be compressed between two vessels. I think the best option will be to unroof this coronary, also the left main.
So a couple of really good points there, Mohammed. First is that the reason I was asking our earlier delegate about the need for the stress echo or exercise test or whatever is that, there is some evidence. I think there's a study of some US Army recruits that, that this kind of lesion is associated with sudden death. And, you could argue that on a prognostic basis, they should have surgery. And that goes on to the next thing you suggested, which is unroofing. Umberto, I don't know what the practice is in Bristol, but I think Aaron, you can correct me if I'm wrong, but I think the practice in Birmingham is for this kind of patient, if we were going to operate, it would be a lima and vein graft rather than unroofing.
Yeah, that's right. That's what if we do operate, it's traditionally been bypass grafting. We've had a couple of chats with our congenital surgeons about this.
May I say something?
And they think that actually the unroofing procedure can be very, very difficult. So we go down the line of grafting if we do anything.
I've been there myself a couple of times, and so because we have a congenital team, so we have done also unroofing, which in principle is you just put the probe into the intramural course and then just you open from the aortic side. I think, as Aaron said, there may be complications too. So once we perforated the aorta, during this maneuver, and we end up doing grafts. I think it's really depends on. So the congenital team is more prone to consider unroofing. That was my sense, but because most of the time these patients are referred to us, and not to the congenital team, they may end up having graft, which is always, a very good solution. We never really had issues. The reality is that the problem with grafting is that because the stenosis is dynamic, it's not a fixed stenosis, but this dynamic is mainly, is mainly present when the patient is under stress. So one question is whether there is a lot of competitive flow and the patency rate, the patency of the graft you put may be lower. So that's why I guess maybe, personally, I would rather discuss this, these cases with the congenital team. And as I said at the beginning, I've done, a few of them. At the beginning, I was very prone to do cabbage, but when I, merge with the congenital team, they are very familiar with, this kind of procedure, and it's not a bad solution too. That was my kind of undertaking.
Can I just ask, at the age of 32, is there actually any data about the patency? Because of the dynamic stenosis, as you say, if you graft, he's 32, how long, and this is not a criticism, this is just, you've got to do what's safe for the patient. So is there any data about that? Because that would be interesting, wouldn't it? Because a redo procedure or stenting is not going to work, because this is a problem, isn't it? This is a problem which is a dynamic situation, as we said. So do you have any data about that, or do we not?
So I think we have data regarding, the fact if there is competitive flow, clearly, the patency rate is much lower, and you can end up seeing this lemma very, very tiny. Again, because I've been there with congenital team, the roofing it's not it's not necessarily complex. It's relatively simple to them. It may become simple also to the adult surgeons. I think there are different cases. There are cases where the stenosis is clear and it's less dynamic. I think I'm very nervous when it's very hard to see it. It's very hard to see it, especially, and in these cases, possibly, the roofing may be an option.
Siddhartha, what did we do?
So we discussed all of these points actually at the MDT, and foremost was that we were offering, if we were going to do anything, it was a lemma to the LAD and a vein graft to that OM, to an OM. And, in a 32-year-old, the patency of a vein graft with normal flow in the circumflex most of the time, and maybe even the lemma to the LAD with normal flow in the native LAD, we just weren't convinced that he wasn't going to have a problem very soon. So I suppose we focused more on the chest pain rather than the future prognostic possible benefits. And we did do an exercise stress echo. And actually, he managed a reasonable amount on the exercise stress echo with no particular inducible ischemia. So even though when I'd seen him in clinic, I thought the chest pain was, sounded like typical angina. He didn't really have any symptoms during the exercise stress echo, and there were no abnormalities. So actually, we didn't do anything. So he's under follow-up with me. For what it's worth, he's on a beta blocker and some nitrate, but he hasn't had any treatment to the anomalous.
So when you did the stress echo, Sudhakar, did you do that on beta blockers?
No, the beta blocker was started later as a.
Okay.
He's still having some funny symptoms, which initially I thought they were. It's funny how these things in your mind work. So when I first saw him, I thought, oh, it sounds typical for angina, and that's why I did the CT. And then after the stress echo was very reassuring, I was a bit, well, there are atypical features to the angina. So we're keeping him under follow-up, but he's never had any pre-syncopal or syncopal episodes. And he's, this is about 3 years now, and he's been absolutely fine in that time.
My only other thought was just before you said the beta blocker, actually, is whether calcium antagonist, if it's a dynamic stenosis, whether a calcium antagonist would help at all. But I don't have any evidence for that. That's just talking off my top of my head.
So just a quick question about, do we ligate the artery when you're grafting it? There was one in our institute done recently. We did not ligate the artery. I don't like the idea of ligating the artery, because if you lose the graft, you've also lost your artery, and I think you could end up in an awful lot of trouble. Aravinda, quick question.
Regarding that ligating, because I know with alpaca, we recently had a talk where the congenital surgeon said that that's one thing you need to always do, and I was actually going to ask about that as well. So is it different when you're considering an anomalous right coronary artery from the aorta as opposed to from the pulmonary artery?
I think that'd be one to ask you congenital surgeons. I don't know the answer to that, but I say I don't like the idea of ligating it. Umberto?
So one of my colleague, what he does, he kind of, put a snare. So when he comes off bypass, he try to close and see what happened. And if nothing happened, he close it. If if the patient goes down, then he opens. So, clearly there are, different schools. I think I share with Aaron the fear of ligating. Yeah, I think, the surgeon perception is that when you end up in trouble is about what you have done and not what you haven't done. So, we kind of like to leave it rather than close it. I agree.
Thanks.
Siddhartha, have you got time for one more case?
Yeah, I think so.
Yep.
So this man's also quite interesting. So he's asymptomatic. He's very overweight, so morbidly obese. He has end-stage renal failure due to focal segmental glomerulosclerosis, and he's on hemodialysis. So his resting ECG is okay, his echocardiogram's okay, but he's being considered for renal transplantation. And he then had a MyoView, so a myocardial perfusion scan, which suggested over 10% ischemia burden. And he was referred for a coronary angiogram to help decide whether he would still be a candidate for renal transplantation or not.
Okay, we got Kate Woolwork there from Oxford. Or Mr. Waterhouse from Middlesbrough. Okay. Samir Thakur from Australia. They've all gone. Aravinda, you're on my screen. Unlucky.
So this shows there's a discrete lesion, tight lesion in the proximal LAD, and also I can't see the full course of it, but it looks like there's some other focal disease as well. So I'd like to see some other views.
Yeah.
So it's a diffuse disease, LAD, with some evidence of calcification as well. Right dominant system, there's some diffuse right-sided disease, but with potentially some obstructive lesions as well.
So I did take this patient to the MDC. So he's asymptomatic. I mean, he's not overly active, but no chest pain, no breathing problems. And this is all, I suppose, the series of investigations have arisen as part of his renal transplant workup. So he's got severe LAD, proximal and mid-LAD disease, as well as that severe disease in the mid-right.
Okay, Dr. Shetty from Liverpool, what are you going to do? What are you going to recommend? Dr. Higgins from Ireland.
So he's 55 and he's waiting a transplant. He's asymptomatic. It looks like 2-vessel disease. I'd probably do it if he's done an exercise stress test to corroborate with the findings of ischemia on the MRI. I don't know. It's your debate of do nothing, best medical therapy, or revascularization.
Which one are you going to recommend?
Well, being a surgeon, probably revascularization.
Okay.
By cabbage.
So why? What's your reason for intervening on him? Remember, Mr. Lewis showed you a slide. We have two reasons generally for intervening on people. What are they?
So if you're symptomatic,
yep.
Or else you have acute coronary syndrome.
Symptoms and prognosis. Yeah, those are the two reasons why intervene. So, what indication does he have?
Well, for prognosis benefit is what you're looking to revascularize for.
Siddharth, do you agree with that?
I think it's difficult. This guy's 55. He's got end-stage renal failure. He's morbidly obese. I'm not certain that coronary artery bypass grafting gives him a prognostic benefit. The kind of things we were talking about in our MDT is actually the main benefit of doing this is that the renal surgeons and the transplant surgeons would then consider him for a renal transplant, which is probably the thing that is going to extend his life.
Aravinda, you got your hand up?
Dr. George answered the question in the second half of his last statement.
But now you're on. So what would you do, Aravinda?
So we had a similar a case, but it was exactly the same thing. So the renal transplant MDT had accepted the patient for transplantation, provided that his cardiac disease was sorted. So based on those prognostic grounds, and that he had flow-limiting lesions that would be amenable to surgical revascularization, they were treated surgically. But in that case, I think it was a single vessel disease.
So surgery or PCI?
Surgery.
And what conduit would you use?
So it would be a lima to the left anterior descending and a vein graft to the right, particularly given that he would be at high risk of later coronary artery disease given his immunosuppressive therapy.
And what type of lima?
So in our institution, we'd use a pedicled left internal thoracic artery.
Any concerns about him being on dialysis? He's most likely right-handed, isn't he? So he's probably going to have a fistula on the left side.
This man does have a fistula. He did have a fistula on the left, so he's got a left brachiocephalic fistula.
I know this was discussed earlier as well, and there's no evidence to suggest that having an AV fistula should compromise the use of a left internal thoracic artery.
Umberto?
100 times PCI. Would have no doubt.
100%. Yes. This is crazy.
Because the reality is that I think there are different issues. One issue is that of course is there are so many comorbidities that the post-operative course is going to be quite long, and I think the operative risk is high. PCI is feasible. These are quite limited lesion, and I wouldn't be obsessed by ischemia. By showing ischemia, because patient needs to undergo to a renal transplant, and I don't think they would do him unless we treat his coronaries. I think CABG in this setting is quite high risk and should be considered only if there is no PCI option. This is my take on this patient. Unfortunately, renal failure is also at very high risk for Senald complication, and this patient is obese. So I think surgery is a bad option in this case. Bad option.
Looks like everyone's woken up. Eshan.
Thanks, Aaron. Sorry, I've just been observing from the sidelines here quietly. Just to comment on one thing, possibly because this is the last case, mainly for the delegates. I've just been observing some of the answers, and having been through this process recently, having sat the exam a few years ago, I think when you're commenting on the angiogram, it's important to be a bit more descriptive of what you're seeing. I've heard a lot of, there's a lesion in the proximal LAD, there's diffuse disease, but if you don't quantify that, such as mild, moderate, or severe, the examiner may not really understand what you mean. So assume that the examiner doesn't know what you do know. So try and express that vocally to make it very clear of what you're talking about, because the severity is important in the strategy of revascularization. that's one comment to make with regards to answering some of these questions and the approach you take. With regards to this case, it is tricky, but I fully agree with Umberto here, where PCI would be the overall preferential option given the significance of his comorbidities. And as Sudhakar mentioned, the aim would be to get him to a renal transplant. And the surgery here would set him back a long way before he gets there. And if he were to proceed with PCI, then he'd be meeting those targets with regards to his cardiac function for him to be eligible for renal transplantation. So that's my opinion.
Thanks, Ashwan. I agree with Umberto as well about the treatment for him. Regarding competitive flow into the Lima with dialysis patients, I think that there is some publication about it, and so if we do have to graft these patients, I would either use a free Lima or a vein graft. And I think vein grafts do have good patency to the LAD because of the degree of runoff. Gustavo Guida, your hand's still up.
Thank you very much. I just wanted to make a little intervention. We've been discussing several cases in patients which have been symptomatic, have STEMIs or non-STEMIs. I think if this patient was presented with a non-STEMI, then we probably would have a bigger argument to go for surgery. But since this is an asymptomatic patient whose benefit is only going to be his renal transplant, then probably the best solution is PCI.
I'm not sure that whether it's an acute coronary syndrome or asymptomatic would change his risk. I think he would still be high risk for open surgery with the comorbidities that have been pointed out.
Yeah, absolutely. I think one of the things which is really important is, I think Mike was saying this, you've got to justify your reasoning for what you're going to do. And I know prognosis is a really nice word, which is an easy way to justify. Yeah, it's prognostically significant. Once you've got renal failure, end-stage renal failure, dialysis dependent, that argument for the guidelines for prognosis for proximal LAD goes out the window. There are other multiple comorbidities as well. We know with renal failure, your mortality is higher, your bleeding is higher, the outcome for the patient and healing is long. So all those things together, the comorbidities. So as you say, Sadak, as everybody said, actually, I think the first choice for these end-stage renal failure patients, actually, if you can do it, is PCI. If you really have to do surgery, then you do it, because I don't think it's straightforward at all. Because what we're doing is extrapolating for a normal patient who hasn't got end-stage renal failure, normal renal function, normal LV, proximal LAD, just do it. Whereas the renal failure patients do not do well. They really don't do very well. So I agree.
I agree with that. I think still the patient will benefit from PCI. What I think is with the absence of symptoms and being a patient with an incidental finding of coronary artery disease, there is absolutely no benefit with surgery.
Yeah, I think that I agree with you. I think the indication to do anything at all clearly would be stronger if he presented as an acute coronary syndrome rather than asymptomatic via the screening test.
But if he did present with acute coronary syndrome, we'd still PCI him. He would not go to surgery. I think that's the point where I suppose we're trying to make, really.
And also, if I can also patient not on dialysis, but end-stage renal disease with like 10, 15 EGFR, I think these patients are the worst for surgery. You see them, they look okay, but actually, they, stop, passing urine, they, get wet in their lungs, they struggle post-op. So I guess, unfortunately, the, end-stage renal failure surgery is very, very poor. This has been, at least my experience. And I have to say, sometimes I end up speaking to cardiologists here in Italy. Oh, but we give him contrast. I said, well, yeah, but your contrast against my, full operation is nothing. And I kind of, miss, I think UK cardiologists, which in some extent I felt sometimes are a bit more pragmatic.
So the patient with diabetic with triple vessel disease, a stronger case for high-risk coronary surgery. Well, I mean, maybe on the angiogram, the fact he's diabetic, but I think it still does not change that overall patient risk profile of the end-stage renal failure. And it may be that in these patients, that if there is no PCI option, and the only thing they can have is renal transplant, then you may need to surgically revascularize them. But I would say that he's unlikely to get a renal transplant whilst he's as heavy as he is. So I will put it back to them and get him to lose weight until he becomes a suitable transplant candidate, if we're going to go down the route of a high-risk operation. And the other thing is, if you're doing something for a prognostic reason, someone has to live long enough to get the prognosis. Siddhartha?
Yeah, so I agree with everything. Agree with everything you've said. So our MDT, the surgical view was that he should not have surgery. He's high risk, and it's there isn't a strong enough indication for it. So he did undergo PCI. It was straightforward to the right coronary and the LAD. And again, as you alluded to in your answer, he's yet to have a transplant. So it's about 3 years on. His BMI is at the cutoff for renal transplant. So he's at 37. Apparently they have a 35. He went back to their renal transplant assessment and he's still deemed not fit enough for other reasons. So again, my personal practice now is to do as you've suggested and to clarify. The problem is you never get a guarantee that if their heart disease is fixed, they will then be listed. It's more if their heart disease is fixed, he can be considered, whereas at the moment he cannot be considered. And the final thing to say about the renal transplant guidelines nationally are that if you're over 50 or under 50 and diabetic, you get a myocardial perfusion scan. And if that's positive, then you can't be listed until you're treated according to, a cardiologist or a cardiothoracic surgeon. So it's not, the test is not repeated. So, all that the renal transplant surgeon in Eastness want is that you have stented something or you've done a bypass to something. They don't then reassess them with a myocardial perfusion scan.
I was just going to say, Siddhartha, actually, just imagine now, in 3 months' time, you get called. This patient is get a little bit of chest pain. Oh, in-stent restenosis. Oh, that is higher in renal failure patients.
Yeah.
Oh, yes, it is. Oh, what are we going to do now? Let's wait for another 3 years. That's going to be the next step, won't it?
Okay, great. Well, thank you very much, everyone. Thank you to all the faculty. Thank you, Siddhartha, for the cases and your presentation. Saib, for your contribution was great. Thank you, Ashan, Umberto. Thank you to Mike, who's not here, but we'll be back again tomorrow. That's it for the day. We start again tomorrow with the aortic valve and the mitral valve. So we'll see you all tomorrow. Thank you very much.
Bye, guys. Thank you.
Bye, Alan.
Thanks.
Thanks.